Dear colleagues, it is my honor and pleasure to welcome you to our 8th International EndoSwiss workshop on diagnostic and therapeutic endoscopy. Please, the first slide. Our meeting is hybrid, and we are pleased to have an outstanding international and national faculty here in Zurich. We are very honored that our meeting is so much appreciated by the endoscopic community all over the world. And so far we have 1,563 registrations from 121 countries. I would like to thank at this moment our friends and supporters who promoted our workshop all over the world. Focus of the meeting is to learn about the latest innovation in endoscopy and their potential role for our daily clinical practice. And in times of conflicts, endoscopy connects. This is our motto, and our philosophy is that patient's care is in the center of our doing. I would like to address a big thank you to the industry. We all know that without the support of the industry, such a meeting is impossible. Thank you very much for your support. And we start now with the first session, with the first live demonstration. And I beg Professor Neuhaus in the podium. Please, the first case. This is a 40-year-old female, and in 2023 she experienced dyspepsia, and an upper GI endoscopy was performed. And the referral gastroenterologist found a subepithelial tumor in the antrum. The biopsy was not productive, and he sent the patient to our center, and we decided to perform again an upper GI endoscopy and contrast enhanced harmonic EOS and an EOS FNA. And I would like to demonstrate you this case. Here you see this subepithelial lesion. And what is very interesting, we could find the previous report from 2018. So in this area, there was no lesion, a very important information. And in the radial ultrasound, you can nicely appreciate here this lesion originating from the deeper submucosal layer and the muscularis propria, about 2 centimeters. And we performed an contrast enhanced harmonic EOS. We injected Sonoview, and here you can nicely appreciate after 12 seconds there is a classical hyperenhancement, and such a hyperenhancement is typical for a GIST. This is the time intensity curve. You see nicely after some seconds there is a high increase, and then there is a relatively quick washout. And we decided to perform an EOS FNA, and the diagnosis is very clear. It is a GIST. 2 centimeters, and what are now the therapeutic options? So on the one hand, we can perform laparoscopic surgery. Then we have several options with regard to the literature. We can do hybrid approach, combined endoscopic or laparoscopic approach. We can perform a full thickness resection with Ovesco set. However, according to the guidelines, this should be done only up to lesions to 1.5 centimeters. And there is a new method which was first described by a Chinese endoscopist. It is the endoscopic subserosal dissection. It is so-called fourth space endoscopy. And we will go now to Professor Inoue, who will demonstrate us this technique. So we can switch in room 9.
Can you hear us? No. Hello.
Good morning.
Good morning.
Yes.
Can you hear us?
Yes.
Yes. So this is a case of a this tumor in the gastric antrum. Okay. So we would like to resect this tumor. So we have already started the distal mucosa dissection. This part is everybody recognize the same procedure to our submucosal dissection. So nothing special. So anyway, so after this, so this is a tumor itself. You can see it. So come close. This is the tumor itself. And then ultrasonography demonstrated the tumor is derived from the fourth low echoic layer. So maybe if we dissect behind the tumor, so we have to cut the muscle. So, so step by step. Anyway, so this is a mucosal incision already done. On the right-hand side, you can see the surface of the muscle layer. Maybe this one is the same. This is also a muscle layer surface. And then tumor itself, at this moment, it looks mobilized well, but so if we continue dissection, this tumor is connecting to muscle layer, I think. So,
So how are your strategy in this approach is that you go first to the submucosa, then you cut the muscle, and you try to keep the serosa.
That's right, that's right.
Would it be an alternative to proceed to a submucosal tunneling technique for complete full thickness resection, then to close the enterocyte?
So I prefer, in the esophagus, we create a submucosal tunnel, but in the stomach, I prefer to direct approach to the tumor like this. So sometimes in the stomach, so we lose the growth, and this is a hemostasis. Okay, looks good. Okay, good. Okay, anyway, so this is a submucosal tumor. So at this moment, we'd like to inject submucosal layer. So at this moment, so mobilization is not bad, so we'd like to continue. And then next step is to, we'd like to give a traction to this tissue. But anyway, injection into submucosa behind the tumor. Okay, injection please. Okay.
Haru, the experts have noted, what do you use for an instrument there?
Sorry?
What do you use for an instrument? So what kind of knife do you use?
So I would like to explain the detail of this device, that this is a knife out. Okay, this is originally a triangle tip knife, J, from Olympus, and then so close. So now we cover the tip of the knife with some food, very tiny food. So like this. So you can see this is some penetrating vessel here. So now the nurse closed the device. Then so using a splay coagulation, we can coagulate the vessel very easily without using the grasping forceps. Anyway, so needle out. Okay, like this. So catch. I would like to cut this fiber. So energy setting is a splay coagulation and effect 2. Okay. So like this way. We can see the surface of the muscle very well. And the injection once again. Okay. So open and close.
Can you, as a surgeon, shortly comment on the alternative of laparoscopic wedge resection
Injection,
for such
please.
a lesion?
Yeah, of course, if the tumor is extended to externally, so it's the best indication of the laparoscopic local resection. It's a quick procedure. So it's an alternative technique. Injection once again.
So now we can nicely already
Injection,
appreciate the muscle
please.
layer.
Injecting. Okay. Okay. So anyway, so we can dissect the step-by-step needle out, and the hook the target tissue. So this side, I would like to dissect.
Can you comment on your special hood that you use for resection?
So we use outer seas of the quick clip floor to cover the tip of the knife. Then, okay. So this part is a tumor connecting to the muscle layer. It's an injection once again. Okay. Maybe we have to dissect the muscle layer after this. So we'd like to extend this side, the other side. Yes, this side a little bit more. Okay. So using the cutting current, and also mucosa cut is a cut current. Okay. Okay. Fortunately, less bleeding, so close. The hemostasis is very simple. No change of energy setting, just a splay. Just a splay onto the, corner bleeding point. So at this moment, so triangle tip knife is 2 centimeters behind the tip of the knife. So just a splay applied to the target. Anyway, at this moment, I would like to apply the traction in order to make the procedure faster. So maybe 1/3 we have already done. Okay, so we would like to bring the traction. So, sorry? Stefan, so the further diameter of the tumor, it's around the 2 point something.
1.9
1.9.
centimeter. Yes.
Yeah, 2 centimeters. Yeah.
So Haro, maybe you can explain us your lifting approach or your traction device.
The distance from the peeling is just, wait a moment, please. So I would like to insert the endoscope again. Now I'm inserting the coagulating forceps to bring the snare wire to the site. Okay. Okay, open the yellow snare.
Yeah.
Okay. Yeah. Okay. So now we insert the coagulating forceps. So, okay, snare open. So this is a yellow handle snare. So we just take, no, open. Okay, please catch it. Okay. So take it back. And then we bring the, okay.
What is the diameter? Is this a 10 millimeter snare or?
Diameter the 20, I think. We can choose any diameter snare. Okay. So at this moment, we also use a very flexible food. Okay, so go straight, and then bring it to the site. So question from Dr. Schneider.
I was just asking the distance to the pylorus.
Pylorus is 2 centimeters from the pylorus. Yeah. Okay. So anyway, so we release the open.
So no laparoscopic bench.
What is the advantage of a snare compared to a string for lifting?
Okay, can I have a openable clip?
Haru, do you understand?
Yeah,
Understand?
yeah. Sorry. We are preparing the quick clip probe. So, further question.
What is the advantage of a snare over a string?
We can try any type of attraction, but I just prefer this one. So reason why we fix this snare wire 3 clips. So only 1 clip.
I think for us
Okay, open.
I think for us European it's more easy to use because we only need the snare
Okay,
and place the snare with a
Catch,
clip.
Okay. Okay. Then we'd like to catch the. Okay, open. Okay, so close. Okay, fire.
So the snare is introduced beside the endoscope, and now you're fixing the snare with several clips, and you grab the mucosa and submucosa.
That's right. So point is snare is coming the side by side of the scope. And then so only 1 clip may slip out. So we place several clips. Okay. Okay, rotate a little bit. 345. Yes, you're right. Okay. Come close to the target a little bit. Okay, close it. Okay, fire. Okay.
So you call this technique multi-point traction.
Yeah, multi-point.
We see that you are assisted by Dr. Epley. Would you do it in a different way, Patrick?
No, I think we discussed, or Stefan mentioned, the full thickness resection for this tumor. I think it's too large, the tumor, to perform a full thickness. And we discussed with Dr. Schneider that the localization of the tumor in front of the pylorus is not that good for a laparoscopic wedge resection. So I think it's a very, very good option to resect the tumor like this.
Yeah, we agree. And also those are close to the cardia. These are the challenging lesions for wedge resection because this can cause stenosis.
Aha. We lose. Okay, once again. Okay.
Whereas we have to admit when we have subepithelial lesions at the anterior wall of the gastric body, wedge resection is still a very good alternative and fast alternative.
I will try to catch the right side of the tumor. Okay, okay. Wait a moment. Okay, looks good. Slowly close. Okay, fire. Deploy. And then I hope you can give a good tension to the target. Okay, approach closely to the tumor. So please keep tension, keep it to this, yeah. Okay. So our specimen was mobilized a little bit.
Oh yeah, we can nicely see.
Good tension, yeah.
Yep, so, yeah.
Good tension we have. So we'd like to approach the muscle layer. Okay. So at this moment, so we can keep the traction like this. Okay, okay, okay. Once again. Okay, wait a moment. Some starts is coming.
We would like to motivate our online participants to send your questions. We are happy also to ask them, Professor Inoue and Epley, to reply.
Okay, one more Buscopan if possible. Yeah. Or drip. Maybe drip infusion of the Buscopan may work longer. Okay, injection. So I'm trying to inject the, okay. So this part is connecting to muscle layer, so we would like to dissect directly. Okay. Okay. Okay, step by step. Need out. Okay. Okay, this is a muscle cut.
Haro, why do you think it's so important to keep the serosa? Because you nicely showed that we have now a couple of options to close the complete perforation site, so attended perforation in case of full thickness resection. Why should we spend time to keep the serosa?
So it's always difficult to anticipate we can preserve the serosa or not. So it's always a very, if we try to preserve the serosa, of course, you know, serosa is very thin and very fragile, easy to lacerate. So anyway, anytime, so we approach from the under visual control from inside. So now we are dissecting some muscle fibers. Okay.
Okay, Haro, you have nicely demonstrated us how you started this procedure. You used the traction device with the snare and clip, and now you're cutting on the level of the muscle. We will let you work, and we will present the next case, and then we will come back to you.
Yeah, thank you.
So we would like to present you now the next case. Next slide, please. This is a 74-year-old female, and in the history she had a diabetes mellitus for more than 26 years. There's a history of cholecystectomy, and the patient experienced now since 2 years a recurrent abdominal pain and also a significant weight loss. Then, since April 2022, she also experienced diarrhea with steatorrhea. Next slide, please. So, the referral gastroenterologist and we decided to perform an MRCP and an abdominal X-ray. And I beg now Mishka Patak, our radiologist, to demonstrate us the X-ray pictures and the MRCP.
Is the patient symptomatic?
Yes.
Yeah.
You can click.
Okay. So what you see here is a 3D MRCP, and if you look closely, you see that the main pancreatic duct is dilated, and you see that there's a void between the main duct and the papilla. You see, even if you turn, there's never a connection between these two ducts. So we weren't sure either is there a void due to a stone, or is there an pancreas divisum where we could see a second duct. So this is point to point, slice after slice, and you see there are dilated parts with signal voids in it, which means that there are stones within the pancreatic corpus. And then you go on and you see that there are several bright lines. Oh yeah, very good. Thank you very much. That there are several bright lines, one after another. So we didn't know, one is the remaining cystic duct, one is the call it the ductus choledocus, and one will be the pancreatic duct. You see there's always some, but we never were sure if there's what we couldn't find out with the MR if there's really a void or a stone there. Then the conventional image just showed that there are no like bigger stones that we could detect on these images.
Thank you very much. So we always hear if we have a pancreas divisum or not. So in this case, it is not clear what we can submit. We have a dilated pancreatic duct. We have suspected stones from the abdominal ultrasound. So our differential diagnosis, it could be also an incomplete pancreas divisum. And an important information is also that there are no radio opaque stones in the.
And the pancreas is a little atrophic, so I'm parking my shoulder to the right. The pancreatic duct can still be traced, a little anechoic, and then you find an atrophic pancreas. It pretty much ends here. Usually the pancreas terminates in between the kidney and the spleen, but here, superior to the kidney, you start losing the pancreas. That tells us it's an atrophied pancreas. And then the duct is still there, a little thin in the body and the tail, and then it's quite dilated on the neck of the pancreas. But I think all the details is going to be in the head of the pancreas. So I'm going to advance the scope through the pylorus, and now I'm right in the head region. I want to just move on, and I'm going to look for three structures: the pancreatic duct, the bile duct, and the portal vein. And obviously, from what you have described in the history, this is something that's going to be very, very hard to miss. The pancreatic duct is right there with some calcification inside. Let us see if we can get some more information. So you got some stones. The portal vein is beneath that. You got some stones. I'm just going to torque around a little bit clockwise direction and see if I can take it to the papilla. And here I see another calcified structure, which probably is the pancreatic duct. I'm going to use color flow, and here is bile duct. And there is a saying that if you find the pancreatic duct, the bile duct, and the portal vein right below each other, you've got a stack sign, and it is unlikely to be a divisum. And that could be the case here, actually. So you got a pretty small, thin bile duct. I got a pancreatic duct with a lot of calcifications inside, and both of them seem to be terminating into the major duodenal papilla. So this could be a pseudo divisum and not a real divisum. Once more, here's the pancreatic duct with stones, here's your bile duct, and I can trace the pancreatic duct almost into the major papilla. So the third step is going to be to advance the scope into the second portion, and then you shorten the scope as you would with an ERCP. I'm going to suck air, torque the scope, and try to IVC. It's a very compressible structure. And on the other side is the aorta. So once we do that, you can keep either structure in view and slowly retract the scope, and you start looking for the unsymmetric.
But interestingly, in the
Here is
parenchyma,
the-
there are no stones.
Yeah, once more, we have the same thing. Here is the aorta, here is pancreas a little bit, torque around, and there is a calcified structure right there. So Amit is going to have a fun time cannulating this because it's really blocking the ampullary orifice right there. And here is the bile duct just superior to it. So I'm not sure whether this really is a divisum. Sometimes when you have a big stone in the major papilla, then what happens is the minor becomes prominent and you think it's a divisum. So this probably is a pseudo divisum because bile duct is right above that. You got a huge stone blocking the pancreatic duct orifice, and here on the right of it is the pancreatic duct right there. Many, many stones.
And is the stone close to the papilla, is it diameter of 8 millimeters
Yeah.
approximately?
I think let us look at it.
So it will be challenging to remove it
yeah.
without lithotripsy. Yeah?
I think, I know that probably many are not fans. Generally, if this is going to be difficult, we would do what we call a pancreatogastrostomy. It's one of those, probably a very challenging EUS procedure. It's about 5 millimeters here, but I'm pretty sure, I'm not sure whether it is a branch of the pancreatic duct. You look at that stone, causing almost like a strictured appearance in the head region, right there, right there. It's completely blocking the duct. You pull back, blocked off. There is the pancreatic duct, and then I'm going to pull back more, and then you come into the stomach, and then I'm going to lose this view, and then here is the stomach. So I think if this is a failed, Amit is always successful. I hardly see him fail, but there is an opportunity to do a pancreatogastrostomy on this patient if.
Or maybe you can do a rendezvous.
No, it won't help you. I can get you the wire, but then you have to grab the wire and go back into the pancreatic duct.
Yes,
yeah,
yes.
that's true. That's true. It's a little challenge, but otherwise, this is a great case for pancreatic duct drainage by EUS. It's doable because
Okay,
there is
so
enough pancreas.
I think we have discussed nicely several options for the audience. So first possibility is to try a cannulation of the pancreatic duct. And
Yep.
for sure, Shaim also mentioned a potential procedure which we may think about if the cannulation fails.
Yeah, the third option is ISWEL.
Yes.
As shown from the Brussels group, just ISPA without any ESCP achieves the same results as ESCP with stone extraction.
Okay. So thank you, Shaim, for
Yeah,
this
no,
excellent
very
demonstration. And later we will come back to Amit.
Yep.
Yes.
We are coming now to the next case presentation, and Katrin will present you the next case.
Good morning. Our patient is an 81-year-old man who recently had his colonoscopy. It showed a very large polyp ranging from 13 to 18 centimeters ab ano. The biopsy showed a tubular adenoma with high-grade dysplasia. I now have a video for you to show you this polyp. First, you hear normal white light endoscopy. You see this large sessile polyp, very compact. We then go into inversion and use the TXI for the enhancement of texture and color. Then there will be a switch to the NBI mode. Here you can nicely see the regular vascular pattern. We subsequently performed underwater zoom endoscopy using crystal violet, which is very helpful in evaluating the pit pattern. In this case, you can see tubular pits, rather large ones, as well as you will soon see also some dendritic pits coming up here. We then switched back to the NBI mode. And here there is one area where you can see that the vessels have a more corkscrew-like appearance coming up here, and you see that they don't have like a 100% connection anymore. So overall, this endoscopic assessment allows us to classify this polyp as an LSTG mixed type, 0 to 1S. The JNET type is 2A to B, and the CUDO is 3L to 4. Regarding treatment, we decided to go for endoscopic submucosal dissection. And the learning objectives in that case are the decision-making on specific ESD approaches, to learn about lifting techniques and devices, effective hemostasis, as well as tips and tricks to facilitate the ESD procedure. We're very honored to have Professor Yahage here with us, who will now do the live ESD.
Insert the endoscope to this patient and watch the lumen again and again until it completely becomes green. And currently, I'm working together with Rat, Hanife, Jane, a wonderful local faculty member. And I'm currently using Olympus nice endoscope, which is GIF H290T. T means therapeutic endoscope, which has water irrigation and 7 o'clock working channel for the gastroscope. Because of the good maneuverability of the gastroscope and the location of this big lesion is lower sigmoid colon, therefore I selected the gastroscope rather than colonoscope for my treatment. And I found a lateral extension here, and the lesion size is relatively big, therefore it is really good candidate for ESD procedure to achieve reliable unblocked resection. Now I'm keeping retroflex position and injected glycerol solution to the submucosal layer. We are ready to start mucosal incision from the oral side in the retroflex position. I prefer to keep the retroflex position because the tip of the endoscope becomes more stable than in the straight endoscope position. Now I'm introducing 1.5 millimeter dual knife J. Could you open this one? Yes, this is 1.5 millimeter dual J. And could you flash the, yes,
injection pump, we can, yes, stop it please. We can inject additional fluid cushion at any time. So open it please. Approaching to the target area and gently touch to the target tissue and start mucosal incision. Currently I'm using, oh, it doesn't work. Could you check the, yes, RF generator? We are using Bio3 and I prefer to use dry cut mode. I will switch. Can I see the setting? Yes. Now I'm setting dry cut effect 2 for the mucosal incision. Oh, it doesn't work. Strange. What is the reason why? No, strangely, it doesn't work.
Okay.
I'm stepping foot pedal of Bio3, but
in the meantime, I may ask you, do you use the tapered hood, the SD hood?
yep. This is SD food from Fuji because I'm planning to do a water pressure method to open the submucosal layer. Therefore, I attached SD food. For the standard ESD procedure, I prefer to use Olympus straight food, but for the water pressure method, I really prefer to use SD food because of the tapered tip. It becomes quite easy to go into the submucosal layer. Now we are checking the RF generator. I can switch. Cut is out, so I need a dry cut effect too. Okay, thank you very much. Let's try. Gently touch to the target tissue. Now it works very well.
Great.
Okay, for the dry cut mode, there is no interval. Therefore, we should step the foot pedal intermittently. We don't have to go quick. Just keeping the white ceramic tip on the surface. And if there is some bubbles, I can flush away using the water irrigation.
Looks great.
Yeah, thank you very much.
There are some papers now in the literature that sometimes for this incision or for ESD, the new post-processing filters from Olympus should be used, TXI or RDI. Do you do that, or you still do your incision and ESD with a regular white light?
I prefer to use regular white light for all the ESD procedure.
So you don't see an advantage of RDI?
No. I need a precise quark for the submucosal dissection.
Okay.
Okay. Precise sect 3, effect 3. Yes, that's good. Okay. So for the minor bleeding, we don't have to stop it. Mostly we can just coagulate the blood vessel using precise sect. It is usually good enough. But if there is some bleeding like this, we can use close tip of dual knife. Close it, please, and switch to the spray 1.2. This is good enough. And by applying close tip of dual knife and use the spray coag 1.2, it usually works very well. Okay. Then I would like to coagulate a little bit more here.
Do you see advantages of dry cut compared to endo cut for the mucosal incision?
I can make a much more precise mucosal incision using dry cut because I can control interval and the duration of the cutting. I still prefer to use dry cut mode. But in case of having lots of bubbles within underwater condition, I sometimes switch to endo cut because we can reduce the bubble. Okay, open it, please. Is this dry cut mode? Yes, okay. Then, oh, it doesn't work. Yes, please don't touch. I can control it. Okay. Even underwater condition, we can make a smooth mucosal incision because the electrode of the dual knife J is quite small. Therefore, we don't have to change the electric current setting. And right after making partial mucosal incision, I usually start the submucosal dissection using precise sect. And there is small vascular network, therefore I'm going slowly here to avoid bleeding occasion. If we cut here quickly, it will cause bleeding. Now we can see rich vascular network, which is much bigger than 1 millimeter. Therefore, in this case, I dissect the surrounding tissue like this and switch to a low setting of forced coag, which is 0.3. Yes, this is forced 0.3, and hooking this blood vessel with open tip dual knife and coagulate it until it turns to completely whitish. This is the best way to avoid bleeding situation. From the other side as well.
And you do not need to use the co-grasper at all?
Usually no.
Usually no.
Because I can coagulate blood vessel like this.
And now, from the beginning, you are underwater.
Yes. This is normal saline underwater condition. If we use distilled water for this technique, it doesn't cut well because it is necessary to have electrolyte to the target tissue to transmit the electric current to the tissue.
And are there any differences in terms of the electrosurgical effects between underwater and under CO2 resections?
For the dual knife, there is no difference because the electrode is quite small. But in case of using much longer electrode, such as hook knife or IT knife, we should change the setting of the electric current. Usually, it requires much higher current when we conduct the dissection underwater condition. Could you switch? I will switch back to the precise sect. Now I can dissect here. Oh, strange, it disappeared. Okay.
Now, is damage of scopus possible?
Oh, wait a moment. Can I switch to the spray coag and close it, please? In case of having minor bleeding, I can stop it by applying close tip of dual knife. Because there was another blood vessel behind here, that's why it caused the bleeding. But usually we can coagulate the target thick blood vessel using a low setting of forced coag. Okay, switch back to
Now Isa, we have another question, and then we will go to the other room. So in the past, the strategy was always to cut around the lesion and then to continue with the submucosal dissection. What is your plan here? So you started in retroflex position. Are you planning to make a tunnel, or what is your plan?
I'm planning to make a small submucosal dissection closet, please, and switch back to spray. My plan is to make a small pocket at the oral side in a retroflex position, then switch back to the anal side and to continue the procedure in a straight position using the water pressure method.
Okay, so we know your plan. We let you work a little bit, and now we are switching to Professor Maideo.
Yep.
Yeah, hi, Stefan. So first of all, I would like to thank for calling me here. It's a great honor giving me this very simple case of pancreatic stones.
Yes.
Shyam just beautifully demonstrated the and there are procedure imaging techniques. Investigations are very, very important. First is, of course, an MRCP, which tells us the pancreatic ductal anatomy and whether there are any associated strictures, whether it is a divisum, whether it is an incomplete divisum or what we call. Most important is a plain X-ray, because if stones, then these stones usually do not need ESWL, because only if the stones are seen on an X-ray, that means they have so much amount of calcium that they need ESWL or some lithotripsy technique before doing a ERCP. Now here, fortunately, we could not see the stones on an X-ray, and maybe these stones are not very hard. They are just conglomerate of proteins with some amount of calcium deposition. So what I've done is I've passed the scope inside, and I've tried to position the ampulla of Vater in such a way, you see here, so that my sphincterotome tends to go towards the lift it a bit. And now I'm going to inject a little contrast. Little contrast. Is anything going in? You can see some duct filling there. I can see that there is some duct filling there. So what we'll do now is again attempt, because the direction of cannulation for pancreatic duct has to. Okay, now, yes. Again, I lift it a bit.
What kind of wires do you recommend for pancreatic?
I am going to use a Terumo wire. That's what I usually prefer.
Angulated.
Angulated Terumo 0.032, ideal. So once more, we can inject a little contrast. Yes. Can you inject?
Leaking.
Are you seeing some duct filling there?
No.
No? I think I can see that duct there. So I need to give a proper direction for the guide wire. So I'm going to now gently lift, rotate it a bit, and push the scope in. Yes. And now you try to go in with the wire. Anna, I'm very happy that a very, very experienced nurse, Anna, is helping me. Yes. Can you zoom and magnify that picture a bit? Yeah, okay, I got it. Yeah, it's come out. Yeah, well, we can try again. Take the wire in a bit. Yeah, okay.
The challenge is probably to get the wire alongside the impacted stone.
In the juxtapapillary region, the wire across it can become difficult. So that's why I had already primed Sham that he may have to give me a wire from up and do a US guided rendezvous. So take the wire back, take the wire back. Yeah, swoop. And now I'm going to again give you a proper direction so that it may be easier perhaps to go in with a wire. Okay, we'll try again. You can see some whitish pancreatic juice coming out. Now the direction seems to be proper.
Pancreatic juice or contrast? This is a little bit different
Yes.
to differentiate.
Again, try. No? Yeah. Your wire has entered. I think your wire has entered somewhere. Has it entered? No. Can you zoom the picture? Make it bigger? Magnify? Magnify it. Yeah. Maybe you can put a little bit more contrast and see. Just to see what's happening. Is it filling?
Cheyenne, in the meantime, I would like to ask you, when you proceed to pancreatic gastrostomy, to approach from the proximal side, and you fail to pass this impacted stone area and the papilla,
Inject first.
then what
Only
is the
contrast.
next step? To place a stand for long-term drainage?
You're right, horse. Navigating a wire through the papilla is a huge challenge. So generally what you do is just leave the wire coiled by the periampullary region,
Yeah, it's gonna
and
go.
then you put in a 5 or 7 French stent, single pigtail, and you just let it stay there forever.
Forever, yes.
Yeah,
Okay.
that's it.
Now?
Yeah, you're now filling the duct.
Even in a younger patient, you wouldn't consider surgery in such a case.
That's a
Not
good
going?
one. Young patients, surgery should be the correct treatment. Generally, these patients are elderly, alcoholic, not a
Yeah,
good
okay.
surgical candidate, and that's when you leave the stents indefinitely. But young patients, without a doubt, they go for a pusto.
Okay, thank you. Yeah.
One minute. I'll just move this. Yeah. Better now?
So, what do you recommend in case of such a difficult cannulation? For the biliary access, we should, according to guidelines, after 10 minutes or so, proceed to
Now you can try.
to different techniques. Would you consider
Wait. Pull it back.
needle knife sphincterotomy in case you fail with cannulation?
For a pancreatic duct?
Going now?
Yes?
Going?
Yeah, I think so. I think with a huge stone.
It's going? Not going?
Yeah, I think it's a safe technique. I don't think pancreatitis should be a concern here, and I think needle knife might be okay.
Oh. Okay, we try once more. Because my sphincterotomy has gone inside once.
I had the impression you were a little bit in the duct.
Yeah, he is in the duct,
Yeah.
but probably the stone is impacted and it
It's
cannot
just at the
pass
juxtapapillary, yeah?
the wire alongside because it's
Okay.
fully
Can I try?
impacted.
I'll try.
This is a typical scenario. And therefore, what I said, in such a case, ESWL, although the stone may not be calcified, is an alternative.
But it's always better to have an endoscopic papillotomy before.
Not according to the studies and guidelines from Brussels, showing no difference in the randomized
It's hitting
control
the
trial.
stone, and I think
ESWL first is
I'll give you a direction, huh? So we pull the
equivalent
scope back
to
a bit.
ESCP followed by ESWL.
Yeah, can you take out that wire which is coming in the way? There's some wire. You know?
Because even when you are
Yeah, it's
able
coming in
to
the way.
pass here, it will be very difficult to
Just
remove
wait,
the
wait.
stone by primary ESWL.
Okay, now you try. That wire has to be taken out. That's exactly on the ampulla.
Yeah.
It's almost gone. Pull back the wire. Pull back the wire. Now try again. Oh, it's out. Okay, so we'll try again. We are just there. No. You know why? Because here pre-cut is not the solution for a pancreatic cannulation. That can be done bile duct at the most. Yeah, we can try again. I have gone somewhere inside, but still it is not entering the duct.
I agree here because it's not, you are in the duct obviously.
Yeah.
For
But
a
I
few
think the stone is
millimeters.
impacted.
Yeah, exactly.
But we should see, we should try. But what I need is, I need that wire to come out. That wire. Yeah, it's on the papilla.
I think
Exactly.
it's an EKG lead or something, right? Let us
Yeah.
see what we have.
You know, on the X-ray you see that there is some artifact. There is a wire there.
I understand.
Oh yeah, you have entered now. Wait. Now you have gone inside somewhere. Let me go. On.
Okay.
No. Now try here.
I got it, Ahmed.
Yeah. Still not.
Can you focus on the papilla and magnify? Okay.
Yeah.
Okay, Amit. So
Yeah.
I think
I'll
take your
try once
time.
more.
Take your time, and we
Yeah.
will come back later to you.
Yeah.
And we switch again to Haru.
Slowly. Slow. Wow, it's almost hung up there. You got.
I've gone
It's in.
inside.
It's in. Yep. Ah. You're in.
But is it the PD? Yeah, it is the PD.
Story. Yeah. I think it's coming out through a side branch. It goes in and then, yeah, you're in.
We are gradually approaching behind the tumor. So, okay, need out. We can see, okay. Now we are approaching behind the tumor. Some minor bleeding, okay, hemostasis close, and then 次は新しいやつね。Okay. So hemostasis. Okay, good. Okay, good. We can see several minor oozing from the surface of the tumor bottom. Okay. Okay, so needle out.
Almost finished, huh?
Okay. We would like to go behind the tumor. Oh. Okay, we have to confirm the muscle fiber. So we have to go this side. This is the peel of the tumor, so we have to dissect here. Okay, needle out. Okay. This part should be dissected. Okay. At this moment, so patient abdomen is very quite soft, so no perforation at all. You can see muscle fibers.
Okay, Harold, you will further mobilize the tumor. We will switch back to Amit.
Okay. So we have almost mobilized the tumor. Okay. I think it's better to see.
Of the X-ray.
Amit, we are back with you.
Oh, you're back with me?
Yes.
So see, I've entered the pancreatic duct. Can you see my wire has now entered inside the PD?
Yes, we can.
But my sphincterodome is not entering. That stone is very, very tight there. So I'm going to do a little sphincterotomy first.
Mm-hmm.
Okay. It is not entering. So what I'm going to do now is push the wire. We take out the sphincterotome. I'll try to put in a cannula, which is a taper tip, and see whether that goes in.
Yeah. We've got to be careful with the exchange. We've got very little wire.
Yeah. We shouldn't allow the wire to come out.
Yeah,
Push it. Push
very
it.
slow.
Oh, careful.
It's a turmo. Got to be
Careful.
careful.
Yeah. Push, push, push. Push, push.
So where's the tip? We couldn't see on fluoroscopy where the tip of the guide wire is.
Yeah, even I can't see it here because there is another. So that is confusing us a bit. Push, 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 push. Keep on pushing. Yeah, very good. Push, flush. Very good. Anna is doing a fantastic job. Yes. Push the scope in a bit. Some.
Push this.
Yeah. Okay. Okay.
Okay.
Now give me a tapered cannula. Thin, tapered cannula. You have Olympus? Yeah. Yeah. This is the tapered? Yeah. This is good. This is good? Yeah. This wire will go? Yeah. So another option is what we do, even if our wire has now gone in, suppose we are sure we are in the pancreatic duct. Next thing to do is, if your sphincterotome is not entering or cannula is not entering, we can pass a very thin balloon. And we can just do a little bit dilatation of that area. It's not going. Yeah. Okay.
But do you think that you can insert the balloon far enough inside the duct?
Hurricane balloon, in case we have a hurricane or any such type of balloon that's very tapered. Can you pull? Pull the wire a bit. Pull.
Okay, let's see how the tapered catheter
Yeah,
goes
let
in.
us see further whether the tapered catheter goes in.
Yeah.
Let me try. Let me try. So I'm doing a little jugglery here, movement, and see whether the tapered catheter is entering. Even that doesn't seem to enter. Tapered catheter is exactly at the entrance to the pancreatic duct. It just doesn't enter. So normally radiolucent stones are not so hard. No, this doesn't enter. Okay, push the wire again. Push it. Yeah. So what are your suggestions, host? What do you think I should do now?
You use the retriever maybe?
Yeah, that's a good idea.
Yeah, but as long as you cannot pass with the wire, get it more inside, you can just open the papillary side. And you are not above the stone.
Or you have a cystotome?
Cystotome.
6 French cystotomes? Sometimes that works better. Yeah? You have?
Okay, Amit, we let you continue and
Yeah.
we get
Push,
back to you
push.
later. So
Yeah.
we let our experts continue working in the operation theaters, and now we will start with our session hot
Yeah.
topic colonoscopy. And I'm very honored to welcome Professor Rösch from Hamburg, who will take over the discussion. And I'm very honored also to welcome Professor Bretthauer and Dr. Kaspar Truninger from Switzerland. And they will discuss now colonoscopy in the daily clinical practice with regard to the new studies which have been recently published. Thomas, the floor is yours.
So, good morning, everybody. It's getting a bit drier, less blood, hopefully.
I don't think so.
No, okay. So, hot topic colonoscopy. Stefan asked us to mainly center our focus around the screening colonoscopy study, and and here are these case control studies. Which show that it's enormously successful. So a massive reduction of colorectal cancer incidence and mortality, comparing those people attending colonoscopy as compared to some unclear rest. And of course, there's a lot of advertisement, and we are so happy that over 20 years we saved 1 billion euros. But then there is this guy who went from Germany to the asylum in Norway and combined German with Norwegian mentality, which can be very dangerous. So, Michael, what have you found out? Well, what's the truth about screening colonoscopy?
Yeah, I don't think this is going to be dry at all, Thomas. So I can get the control over the slides. So Down to Earth, that was the title that was given to me, and I'm not sure about that, but we will find out in the next 10 or 15 minutes, and then we're going to have a discussion with Thomas and Kaspar later. So
I don't know if you are aware, but in colorectal cancer screening, we are kind of in a peculiar and outlier position as compared to many other, or all, I think, other cancer screening areas. For breast cancer screening, you have mammography. For prostate, you have PSA. For lung cancer, you have CT. All one test for one cancer. We are in the fortunate, but also a little confusing position that we have many tests and many test options. Here are some from a recent guideline, but there's more than FIT every year, every other year, then colonoscopy, sigmoidoscopy. You have also CT, you have the capsule, you have DNA with Cologuard and other tests. A lot of options, which makes it fun to work in this area, but it makes it complicated to find out what works, what doesn't, what's best. So how do you do that? How do you find out if things work when you talk to a patient or when you write guidelines? Well, I think it's pretty straightforward, but we are still struggling to do it. So what I think we all need to do is, number one, to compare the benefits of a screening test. And important here is that we talk about the absolute benefits, and I will come back to that later in the talk, and that we see what risk of disease the particular patient or individual really it is has, for example, for the next 10 or 15 years. And there are quite good calculators online where people can put in their age and their gender and if they smoke or drink alcohol over family history, and then you will get a disease risk back for colorectal cancer. And here on this slide, you see that on the left-hand side, you have a scenario where people have a 2% risk of colorectal cancer for the next 15 years, and on the other side, you have a 4% risk. 4% risk, 15 years, that's high risk. 2% is still high, but lower. Many people have a lower risk than that if you go into the calculator. But of course, age, for example, is, as you know, a risk factor. As people get older, the risk is higher. And then you do what these people in the guideline did. You explain what the risk is without screening, that are the blue dots, and then you explain how small the risk can get if you do one of these screening examinations. For example, and I'm just going to show you one of these because there's a lot of information here. For example, if you look at this particular here, so this is a patient with a 2% risk of colorectal cancer for the next 15 years, derived by the calculator, which is online. If you do no screening, then the 20 is exactly the 2%. It's 20 out of 1,000. If you do FIT every year here, or FIT every 2 years, you reduce the incidence just a little bit to 19 or 17. If you do a colonoscopy, from 20 to 13, and so on. That's what you get. This guideline was pre-Nordic trial. This is based on modeling, only modeling. But this is a nice way to show it to your patients or to your colleagues. So after the benefit, you have to talk about the harms. And here again, in that guideline that I referred to you, the harms, and you know all of what that is about 3 in 1,000. Again, you use the same absolute measures. Here it was per 1,000, here it is per 1,000. So it's 3 per 1,000 or smaller. So you have the benefits and the harms. There's one thing left that is called burden. So what does it mean to have a colonoscopy, for example? Is it painful? How long does it take? What does it cost? What about the bowel preparation? These are things that you also need to explain to people. It's harder to quantify things. Quantify the burden of a bowel prep. It's hard to do, but at least it needs to be explained so people understand, okay, what is this about? And a table like this is helpful. So before we go over to the trial data, let me just mention that luckily, and as we have seen, for example, just in the last hour, luckily we as a field improve all the time. And so the effect estimates, both for the benefits and the burden, they may change because we get better and do new stuff. For example, we know that ADR, adenoma detection rate, is related to cancer risk of our patients. And this is a recent study, just as an example from the US, showing that people, and we know that, people who find more polyps, their patients have a lower risk. And because we are getting better, of course, the screening gets better. Another thing is AI, CAT-E, CAT-X, we're talking about this all the time, which may have an improvement on what we do with patients, and therefore also effect estimates will change and need to be frequently updated for those benefits and for those harms. There's also harms related to CAR-T. Finding more polyps, maybe more perforations or more overdiagnosis. We have to take that into account. So down to earth, coming back to the title. As you know, colonoscopy is the primary screening test in the US. In Europe, not so much, but some countries do a lot. Some countries don't do it at all and do fit screening. And the screening interval is different in different countries, so there's a lot to learn. The evidence before screening, and Thomas showed you a slide from a German study. Here are 2 US studies that indicated that colonoscopy may be very effective. 50, 70% reduction. National Polyp Study, which also is an observational study, 90% reduction in colorectal cancer mortality this is. But again, this is all observational evidence, and it's hard to make inference for clinical practice from observational studies. There's a lot of biases here. So therefore, usually when we, for example, start with a new drug therapy, we always want clinical trials, randomized trials. And this is the first one that we published a half a year or 9 months ago in the New England Journal, which is about colonoscopy versus no screening, a clinical trial, a randomized trial, just as we like to have to inform our policy. So the Nordic trial was a randomized trial in those 4 countries, Norway, Poland, Sweden, and the Netherlands, with almost 100,000 people. These screening trials need to be large because the disease risk is small, as I showed you, 2%, 4%, and you will see how much risk we had in the study. So you have to enroll a lot of patients to do a study with a good sample size. Important, everybody got randomized. The people who were randomized to no screening did not get anything. They were even not informed that they were in a trial. They just lived their lives, and there was no screening in the areas where we did the trial at the time. And the other folks got an invitation to a colonoscopy. There were no GPs involved. Letter straight to the people, come and get the colonoscopy. So as you can see, about 30,000 people were in the screening group and about 56,000 people in the no screening group. Most people in the trial came from Poland and Norway, just a few from Sweden, and from the Netherlands we had about 9,000 people, but these data are not included because somebody in the Netherlands thinks that they cannot share data with other people in Europe anymore after GDPR. It's a process that we hope we will win eventually. Screening participation, I will come back to that later, was 42%. So out of the people who got the letter, 42% showed up and had a colonoscopy, much higher in Norway as compared to Poland and Sweden, as you can see there. The screening performance was good. Bowel prep was good. Cecum intubation was good. Adenoma detection rate, I think, was good, 31%, as you can see, lower in Sweden than in the other 2 countries. It's a very simple explanation for that. I will come back to that. And few complications, which is important, harms. As I said, there was no screening for the people who were in the no screening group. It's probably difficult to believe for you who come from areas where screening is everywhere, but there was no screening in the areas when we did the trial. This is the main result, colorectal cancer incidence. As you can see, the red group is the screening group. They have a higher incidence to start with. That's entirely predicted because we find cancers at screening. And then the curve gets flatter, and at about 6 years, the curves cross, also that's predicted. And then the curve is lower in the screening group as compared to the control group, 18% lower. So that's the effect of colonoscopy screening, 18% reduction, 18. Of course, as I told you, not everybody showed up. That's the name of the game in clinical trials. So we also did so-called per-protocol analysis where we only count the people who actually had a colonoscopy. That is high-risk business because then you get all the bias back from the observational studies, which we don't like. That's why this analysis, the primary analysis, in all clinical trials, not just in this one, every drug trial, every trial you read in the Lancet, in the New England Journal, in Gut, where Thomas works, it's always intention to treat first, because this is the result we believe in foremost. But we understand, it may get a result which is lower than the real result. So therefore, we also did this. So only the people who showed up, the reduction is 31%. This is the best you can get. It's probably a little biased, it's probably a little too high, but this is the best you can get, 31%. What about mortality? Well, very short story, no difference. And you can see it, the curves are totally overlapping. I believe it's too early to see mortality results after 10 years, and the risk is very, very low. You can see it there. Almost nobody died of colorectal cancer in the trial, out of the 100,000 people, thanks to the better oncological and surgical treatment we have now. Just one word about all-cause mortality. So death in general, no difference. I don't think that's very surprising, but it's a reminder to us that we should not say that colonoscopy saves your life. It doesn't prolong life. It doesn't. It can save you from getting colorectal cancer. That's pretty nice, but you probably won't live longer. You die of something else. There's been criticism. People will say, well, you know, only 42% showed up. I think that's high. Some people said it's low. Well, you know, the ADR was smaller than at Doc Rex's clinic in Indiana. Well, look at how obese the people are there, and you know that obese people have more adenoma, so entirely predictable. But so here's what I think. Number one is adenoma detection is always a reflection of the prevalence. In Sweden, and I didn't show you the numbers, Sweden has a much lower prevalence and incidence of colorectal cancer than Norway and Poland. If you ask me why, nobody knows. If you find out, you'll probably get the Nobel Prize. But it's just a fact. And so there's less cancer in Sweden as compared to the other countries. Therefore, there's less adenomas. Therefore, people can't find the adenoma, so the ADR is lower. Logic. It's not a problem. It's just the way it is. Participation, well, if you want higher numbers, look at the per protocol or look to Norway. We had 61% participation, which is exactly the participation in screening in the United States. So our folks over there may look at those numbers. And then there's some stuff about sedation, which really is nonsense, I think. Okay, so I've jumped over this. So I think, ladies and gentlemen, colonoscopy screening still is a good thing. I think it should be offered if you want to offer it and you can pay for it and your country can afford it. But it's not a magic bullet. And then 80 or 90% that some people said, it's just, I don't think it was ever realistic. There's hardly any intervention in medicine which is 80 or 90% effective. In medicine, not in screening. I think 20 to 30%, for instance, is pretty good. And mortality we will see in the future. And then again, it's all about the benefits as compared to the harms and explaining it to people. And some people will say yes and others say no to screening colonoscopy. That's fine as far as I'm concerned. I think I stop here, Thomas.
Okay, thank you very much. And just one very brief comment. I don't know how it's in Switzerland, but if you send out one single letter in Germany, I'm absolutely sure that much, much, much fewer people than 61% will come. But anyway.
I agree.
Before we start the discussion, we want to go back to Professor Yahagi, and because that's one polyp which we would like to find during screening and see how far he is. And have a seat, yes.
Oh, yep. Okay. Can I have knife?
Now, Hisa, we are with you.
Okay. I already completed the lateral mucosal incision and submucosal dissection on the both sides, and there is a remaining healthy mucosa here at the inner side. Therefore, I'm going to make a mucosal incision here and quickly dissect the remaining submucosal tissue. So before starting rest of the procedure, I'd like to give additional submucosal fluid cushion from the edge of the incised area. Okay, flushing away the bubbles from the food and gently touch to the submucosal layer. Okay, injection please. Currently, I'm injecting glycerol solution through the knife. It is very effective. Okay, okay, stop it please. Then open. Now we can see the edge of the previous mucosal incision and hooking this edge and conducting mucosal incision by using dry cut mode and going to the right side, go slowly, slowly, and checking the direction and border of the target lesion. Usually, we don't have to press marking dot when we conduct colorectal ESD procedure because border of the region is quite clear. And in case of having bleeding, we can stop it. Close it, please. Oh, there is really thick blood vessel here. Okay, and spray coag, please. Yeah. And touch to the bleeding point, right behind here.
Just a short question.
Because of the presence of the mucosa, it becomes a little bit difficult. I would like to open here, switch back to dry cut and precise sect. Open.
Can I add?
And now, shall you use co-grasper?
Usually no, because I can deal with the bleeding by utilizing the tip of dual knife in most of the situation. Of course, if there is really severe bleeding, I sometimes switch to the co-grasper. And this endoscope has RDI, which we can visualize the bleeding point much easily. Okay, close and switch back to the spray coag. Yes, I think there is a bleeding, oh, unstable. Touch to the bleeding point and it's spontaneously moving. Okay. And check the situation and a little bit more to this side. And air bubble does usually disturb the clear visibility. That's why I'm flushing the bubbles by utilizing the additional water irrigation. Oh, this blood vessel is quite thick. Little bit upper side. So by using RDI, we can visualize bleeding point much better, and at the same time, we can reduce the psychological stress because of the yellowish color. It's much better than reddish color. We can have calm situation by utilizing the RDI. Oh, still there is some bleeding. Okay, touch to the bleeding point.
So the next generation will have a green blood flow. I hope.
Okay, nice.
He probably
Once
can't hear
more.
us, but Stefan, what's the educated guess about histology? High grade or
Okay, switch back to
cancer,
the
or?
white light.
But what's the
still there
educated
is some
guess of
bleeding
final
here.
histology?
Back side.
Cancer.
Close it.
Cancer. Okay.
You think so? Yeah. I think the surface looked benign.
Yeah.
And
But
low
it
grade.
was so compact.
That's
So the
true.
bulk-
Now,
the
it
bulkiness
is
is
coming
the
from
issue.
back
Yeah.
side.
Okay.
Unfortunately, it becomes very difficult to touch to the bleeding point. I'm lifting the mucosa, okay, then I can
Could be cutting.
open.
Cutting
Yes.
is useful.
I think, yes. After opening this area, it becomes much easier to recognize the blood vessel. And by cutting the surrounding tissue, I can expose to this very thick blood vessel here. This is kind of artery because of the whitish color. This is really dangerous blood vessel. We can see the pulsation here. Therefore, I would like to dissect a little bit here, then apply forced coag. Could you switch to the forced coag? This is really thick blood vessel. It's a little bit challenging, but completely catch here. Is this forced coag? Okay. Then apply the forced coag and give some tension to the target tissue. It takes some time. And from the other side, it's really thick blood vessel here.
It looks dangerous.
Yeah, this is really dangerous blood vessel because this is artery. We should carefully coagulate here. a little bit longer and pulling back and give tension to concentrate the electric current to the catched area. Otherwise, electric current goes a little bit deep. Oh, it goes a little bit bleeding already.
Now, Hisa,
Yep.
why don't you use a forceps?
You mean the coagrasper?
Yes.
Yes, sometimes I use coagrasper, but the majority of this
For
kind
example,
of
now.
Oh, yes. Yeah, because in order to save the cost of the procedure, I prefer to use dual knife. But in case of having actual really severe bleeding, I switch to coagrasper, of course. But nowadays, I can finish most of the procedure without using coagrasper by using this technique.
We see you like dancing with a vessel.
Okay.
Still there.
Yeah. Still, there is pulsation at the lower side. Oh, and there is another bleeding coming from upper side, somewhere around here. Yes, here. Could you close and switch back to the spray?
It's nice to see that bleeding can be something very aesthetic.
Mm-hmm.
It's usually not the case.
Oh, it already stopped. Okay, let's attack. Oh, here's another bleeding. Oh, it's slippery. Okay, let's ignore minor bleeding and focus on this sick blood vessel. Okay, switch back to forced. Yeah, knife out and catch here.
And the water, it looks beautiful.
Yes, but in case of having actual bleeding, it turns to really bad condition. Therefore, we should avoid severe bleeding when we conduct ESD within underwater conditions. Yes. And give tension to the target tissue. Oh, this is really thick artery. It's quite challenging. I think we had better to use coagrasper because the lower part of the sick blood vessel is not coagulated yet and still having pulsation. Can I have 4 millimeter coagrasper and 4 millimeter?
And the stomach, that's
5 millimeter coagrasper is for stomach and 4 millimeter coagrasper is for colon. And when we use coagrasper, it is necessary to suck all the liquid. Otherwise, we cannot use coagrasper properly because electric current goes somewhere. So
now Hisa,
yeah.
I think everybody appreciates that this is nothing for hectical endoscopists, and nevertheless, we have to move on. We believe in the coagrasper very much, and in the complete removal of the lesion as well. Thank you.
Yeah, thank you very much.
Okay, I'm told we have to go to Haru.
Yes. So, hello.
Hi. No bleeding at least, and no tumor. Haru?
I think he's talking. It's just something with the microphone.
Removed already, and then I would like to summarize. So this is the mucosal margin, and then you can see this part, some oozing is from a submucosal layer, and then it's just a oozing, and you can see circular muscle fibers here, and then so closely to the center. So you can see the defect of the circular muscle, and then this part that we have already dissected the circular muscle layer, and then center, you can see a longitudinal muscle layer, and then the linear center of the food circle. Now the linear center is the subserosal layer. They're not perforated, so patient abdomen is totally flat. So no perforation. This is a mucosal flap. So like this, we have successfully removed this tumor. So this tumor is a little bit fragile. So some injury onto the capsule. So specimen is I'm now trying to bring it out.
Haru, what's the plan? Do you close some of that wound,
so
or
yes,
what's the plan?
So our planning is to close. So of course, the most of the part is the circular muscle layer still remain. So the center of this muscle layer defect should be closed. But in this case, tumor located at the antrum. So antrum mucosa is easy to approximate, stretch well. So we would like to use a loop 9 and then close this defect.
Close the entire defect, if we understand correctly.
Okay, so now we would like to take the specimen out. Okay, so specimen located at the, okay. Hopefully we can find the specimen. Yeah. So this is a tumor. We can keep the tumor in the cap and then take it out. Okay, this is a resected specimen. Can you see? Okay. Okay. This is a small GIST tumor. So during procedure, I think some part of the capsule that was injured, but fortunately we taken out the specimen in one piece. And also another important point, we do not perforate, so washing the lumen much and remaining potentially remaining, I don't think so, but potentially remaining this cell should be washed out. But anyway, so no connection to the peritoneal cavity, so I think it's okay.
So Haru, one question. If the capsule is injured, it's formally not R0. Should this be, which is extremely unlikely, be a malignant GIST? What happens next?
But if we perforate, it's a problem. But we don't perforate. So at the time of GIST resection, so far, we do like this. So capsule is not, it's a fibrous layer. So I don't cut into the GIST tumor. I said potentially. So risk of injury of the surface, I mean. But I think we resect the tumor in an unblock.
Okay, so we have to adapt histopathology a little bit to the needs of the endoscopist. But
yeah, that's right.
We asked the boss, shall we watch the closure or?
Yes, we
yes.
like to move
okay.
on to the closure.
It takes away a little bit time of the session, but your coffee is secured.
Okay, so we'd like to continue. Okay.
So maybe, because I'm not sure whether we can watch the entire closure, can you tell us the plan? You're just starting from both sides and.
Yes, now we are inserting the loop 9. Please release it.
A loop, okay.
Okay,
yeah.
So this is a loop 9. So we place this loop through the, okay.
And then you clip it and then you pull it.
Yeah, that's right.
Okay, I'm not sure whether we can watch all of this, but it was a beautiful demonstration. Thank you very much.
Thank you.
And the tumor is out.
Yeah.
Okay.
Sure, no way.
I think that's all for live. And the boss has to tell us we had 60 minutes, we used 15 and have 20 left. Is that correct? Because if so, we have to go on to the next lecture. And, okay.
Let's do Kasper's talk first, and then we can, if we have time, we can discuss both screening and surveillance afterwards.
Good.
これ何クリップ？これ手話クリップじゃん。
No. So screening is finished, polyps taken out. The question is what next? Too much surveillance, not enough?
That's when the problem starts.
Yes.
Yeah.
So good morning also from my side. I think the field was opened yesterday with the wonderful talk from Jacques Bergman. Less is more. You continued, Michael, in the same direction, and so I will show some new data, but I cannot show everything. So I will not cover all the topics listed on this slide. And I will first talk about adenomatous polyps, the conventional ones, and just briefly, non-advanced adenoma. That's a small tubular adenoma with low-grade dysplasia. And if you have one or two of those, then it's the low-risk adenoma group. So here on this slide, you can see a summary of the different GI societies guidelines for surveillance. And you can see there is pretty much agreement, concordance between the different guidelines regarding the high-risk adenoma group. But when it comes to the low-risk group, then it's quite a difference. And it's also different between the ESG and our Swiss guidelines in the past and now in the actual guidelines. You can see it was expanded from 1 to 2 until up to 4 small tubular adenomas, and above that the time interval was extended for up to 10 years. So what the critical aspects therefore are multiplicity. Can we really expand that up to 4? And how about the villus histology? Because this histological criteria is not used anymore in our guidelines and the ones from the ESG. So this is a large US study and showed no significant difference in the absolute risk, both for incidence and mortality, between patients without any adenoma and those with low-risk situation, where there was a significant increase in incidence and mortality with high-risk adenoma in high-risk adenoma group. I will, for time reasons, skip several slides. This is a meta-analysis summarizing the data from several studies. And as you can see here in the upper figure, for the low-risk situation, there is not much difference, whereas for the high-risk situation, the adenoma risk is threefold increased. And when you move on to mortality, you can see there is no difference between those without any adenomas and the low-risk situation, where there is a significant increase, 2.7-fold increased risk for mortality associated with high-risk situation at index colonoscopy. So taken together, I would say we have quite solid data that up to 2 small tubular adenomas, that's the low-risk situation, there is not an increased risk for incidence and for mortality. So how about having more than 2 adenomas, small ones, non-advanced ones? And this is a large study from the US, and as you can see here, also for when you compare, when you look at 3 or more small adenomas, both the risk and the mortality is not increased when you compare to the general population. This is a meta-analysis, as you can see here, and there is also no difference when you look at incidence, and is also no increased when you look at the mortality. So this is another meta-analysis that has just been published earlier this year. And as you can see from the different features that are characterizing a high-risk situation, mainly size, particularly larger than 2 centimeters, and the presence of high-grade dysplasia are associated with the risk for metachronous colorectal cancer, but not multiplicity. And of course, the consequence is if you include multiplicity, then you have a high number of number needed to screen to detect an additional metachronous cancer. So what's about the villus histology? As you can see here, this is data from UK study, and you can see here there is no increased risk in the multivariable analysis for this criterion of villus histology. And this also holds true from this Polish study. No increased risk both for incidence and mortality associated with the presence of villus histology. I will now move on to the serrated polyps, which is an umbrella term for a different type of serrated polyps, and the features of serrated polyps associated with an increased risk are mainly size, the presence of dysplasia, location, and the subtype, mainly SSL and TSA. So these are the current guidelines from US ESG and our ones in Switzerland. And you can see once again, there is quite an agreement what is the definition for the high-risk situation. But there is a difference between a low-risk group. And the major difference is that the US guidelines, they differentiate between whether it's a hyperplastic polyp or it's a sessile serrated lesions, whereas in our and the ESG guidelines, we just use the serrated polyp group as a whole. So the question here is, the critical aspects, is the risk for development of metachronous cancer after baseline colonoscopy same for HP and SSL? And again, the second question is, how about multiplicity? In this large Swedish study, as you can see here, for mortality, there is no difference as whether you have a HP or an SSL at baseline endoscopy, where there was a little bit increased risk associated for hyperplastic polyps when you adjust for a family history of colorectal cancer. When you look closer at the data, then the risk is only associated when the hyperplastic polyps and the SSL are located in the proximal colon. The problem of this study is that we have no information about polyp size, the presence of dysplasia, and multiplicity. So we don't know if the increased risk associated with for example, hyperplastic polyps, is it really just a matter of size, or is it holds true also for smaller ones? This is another study that looked at serrated polyps as a whole group, and as you can see, location and the number of serrated polyps was not associated with metachronous colorectal cancer risk, whereas size larger than 10 millimeter was associated with an increased risk. So we have now much more data as compared to our previous baseline guidelines, and the current data are not based on the high-risk group, but are based on data from a harder endpoint, that is colorectal cancer incidence and mortality. However, we have to keep in mind this also has some potential problem with the lead time bias that is increased. And so I think the data is quite nice to increase the low-risk group from 2 to 4 small tubular adenomas, as shown here. Nevertheless, the data are not perfect yet, because we have to wait until the end of this decade until we will get the first results of a randomized control trial, which is comparing different intervals for same polyps. So what else after size and polyp subtype and dysplasia? How about adenoma detection rate? Michael already mentioned this. It's a very important criteria of our work, quality control measurement. And here are just two studies. And you can see whether you are a high or low performer. There is a marked difference, and you can see on the right side, it's the same, the adenoma detection rate and the risk for metachronous colorectal cancer is associated. Maybe there is a plateau of around 40%, but at least the aim should be to get 8 years of 40%. What else then about looking closely and have a higher adenoma detection rate? Well, we don't include lifestyle information to tailor recommendations. We don't include genetic factors. So there is a large field to improve, but the other question, as it was just stated before, is what is the acceptable risk for what you can accept as a risk for metachronous cancer? If you go for 0, it is never ever possible. As we can heard just from screening, we cannot reach 90%. And so this is also a debate that has to go beyond our scientific data. Thank you for your attention.
Okay, please join us here. I think after these 2 lectures, everything seems to be clear, Michael. So we hear that we focus on small adenomas. They have a normal prognosis, so it doesn't matter. We don't do well in advanced adenomas because the risk is still increased. So is it surprising that Nordic didn't do so well?
Okay, so there's a lot of things here. First of all, I think Nordic did pretty well. I think there's definitely too much surveillance for the small adenoma patients. I mean, the whole field is very interesting. If you think of it conceptually, we remove adenomas, and we believe in the adenoma carcinoma sequence, Thomas. I think the 3 of us believe in it, so that most cancers come from adenomas. Hold on, that's my point. So almost all cancers come from adenomas, and from that follows that if you remove all adenomas, there will be less cancer. The Nordic studies showed that. It's not perfect, it's not 100%, but maybe it's 30, that's pretty good. But look, we don't do colonoscopy every day in all these patients. We talked about that in the taxi yesterday, we could just leave the scope in and then just, oh, there comes one, then we take it out. That would be fun. Then we may be reaching 100%, but we don't do that for obvious reasons. So there will never be 100. And so then the question comes in, so who are the folks with the highest risk? Because we all have to accept some risk in life. We cannot live with 0% risk. And the pandemic made that very clear. We have to live our lives. So I think the people with the small adenomas, we can just leave them. Because as you just pointed out, Kasper,
People or the adenomas?
No, the adenomas have to come out. Okay. First colonoscopy in your life, not at age 25, but maybe 50 or 60. If you don't have adenomas, all small ones, you should never come back.
Done. Okay.
You're done. That will relieve a lot of workload for the other people with the large adenomas. And there, I think, this is a monologue. Coffee is postponed. There, I think, it's far too complicated. What you showed, the tables and everything, and the villas and the size, is it 10, is it 15, is it 20? What about this and that? It's too complicated. Let's make it easier. And I think looking at the data, what I think we should do in the future is say, well, the people who have adenomas or serrated polyps, for me, that's not a difference really. The risk is the same. Over 2 centimeters, that's the high-risk people, and the high-grade dysplasia. Everybody else is smaller risk.
Okay. So we have 3 risk groups, basically. So all the low-risk stuff is goodbye, never come back, which is not the case. And then we have 2 risk groups. So you eradicated the villus histology, which I've never understood.
Yeah.
That's probably nothing.
Yeah.
High grade is the bad thing, right?
The majority of villus histology is associated with large polyps and the presence of high-grade dysplasia. So it's mostly not an independent risk factor.
And size 1 is maybe a little bit, so size 2. So we have a high-risk subgroup among the advanced ones, and the low-risk subgroup among the advanced ones gets 5 years, and the rest maybe even earlier, no?
Yeah, I don't know about that middle group. I think we should focus on that high-risk group, the 2 centimeter high-grade dysplasia.
But
that's what the highest gain is.
Can I challenge you, is it wise to do in the high-risk group a 3 versus 5, or should you do a 3 versus 1 year in the high-risk group?
Oh, that's a good question. I don't think we have the answer, but like if you ask me what I think, my opinion, there's no evidence, I think 1 year is too early.
But tell me, one thing we forgot actually, and you mentioned it on the side, the advanced adenoma resection 3-year group rests on a complete resection.
Yeah.
So in all fairness, and if you are a perfectionist, it should be a histologically proven zero resected en bloc. And then, true, the polyp is gone.
True. Well, I would say the baseline colonoscopy quality is getting more and more important. If this one has really is sophisticated, then we are on a better basis to extend our intervals.
But if you think this to the end, this would mean a piecemeal resected large adenoma comes back when?
I don't think. What is piecemeal? If you have several pieces, then
Yes.
it's really piecemeal.
Yeah.
If it's just you have 2 pieces, clear margin, I don't think this is piecemeal. But this
Which
is
margin?
my.
I mean, it's.
This is.
I would trust, if you have a high-quality endoscopist, I would trust that person. The endoscopist has to write in its report, okay, I've looked this over, take photograph, there's nothing left here, it's an R0. Piecemeal, period. If you have a good quality system for your endoscopists.
Which, as a fan of evidence, you should prove in a study that that's true.
Yes.
Okay.
But there's another thing here which comes up, which is really interesting, and we talked about this by email. I have no solution for this, but this will bite us in our asses. So here's the thing. We have ADR and all that stuff. We're setting out our quality systems. We are measuring ADR, and you and me and you and everybody. We still, all the surveillance is based on the patient characteristics, the polyps, the size, what we talked about. But you saw it on the last slide. It's really about the endoscopist. So today, if you are a very good endoscopist, you have a very high IDR, your patients are coming back earlier than your neighbor endoscopist, who is the poor one who doesn't find the polyps. He has a lot of normals. And that's a big problem, both for the patients in the first place, but at the end it's a problem.
There's no difference,
but
right?
look, at the end it's a problem for us, because now you have 10 endoscopists, and you see that 9 of them are very good, 1 is not so good. And then you have patients that have been at that number 10. What do you tell those people? I'm sorry, we found 2 polyps, your neighbor had 2 polyps, but he was at a better colleague, so you have to come back there and there. What would I do as a patient? I would call you and say, Thomas, I don't want to go back to that guy, I want to go to the other guy.
Right, but on the other hand, is the difference so big? If you have an 85% adenoma detection rate, only small polyps, and the other guy has a 40% also small polyps, and in theory there shouldn't be much of a difference.
40 and 85 not, but if you are down at 15, then
okay,
you have a
but
problem.
that's consensus.
Yeah.
So there's the limit is probably now at 30 or something.
Somewhere,
yeah?
I would say
you shouldn't be below 20 for sure. And probably not below 30.
For average risk population, it should be somewhere around 40.
But what do you do with these people? You fire them?
The endoscopists?
Yeah.
Well, if you can afford, if you have enough others, then yes. Right. Sorry.
Thank you for both presenters for their study. My name is Matthias Sauter from Zurich. Thanks for both presenters for their study, for their presentations. I have a question on the screening study. I actually found in the additional data, I found a table about which cancers were early stages, intermediate stages, and late stages, and I was surprised to find that in both groups they were actually quite equal. So
yes.
Usually we see in the screening population we see more early cancers, and there was no real difference. Can you explain that? May that be part of the problem, that some people had some symptoms, then went to the screening, and we were actually not looking at asymptomatic people, but at people that needed a colonoscopy for symptoms, and just found the letter in the mail and said, okay, I'm going to do the colonoscopy.
Yeah, thank you for bringing this up, and congratulations, you read the paper really well. Yes, it's there. I cannot totally explain it. It was surprising to us. I think it may have to do with self-selection, what you just described. Some people come, some people don't. We see that a little bit. If you also saw, we have curves for Poland and Norway. Obviously, the Polish people who came were at higher risk. Maybe that's some symptoms that they didn't tell anybody about. We had symptoms as an exclusion criterion, but of course,
But on the other hand, that's the same problem in every screening study. So we looked into this in our Berlin group, and 10% of screening patients had symptoms, which is not so much, but yeah.
But it's I can't totally explain it. Yeah.
What?
Michael, as far as I remember, about 1/3 of the endoscopists in your study had a ADR below 25%. And did you make a subgroup analysis if this had an impact on clinical outcome?
Yeah, very good question. We have, but the number of cancers is so small that there's no meaningful results. You know, there's hardly any cancers for the people who were at the screening, after the screening, although we have 100,000 people. So I think the study will be too small to look at the individual endoscopists. Maybe at 15 years, I don't know. But we are monitoring that.
And I think one of the problems with screening is that colorectal cancer incidence started to go down before screening started. And,
yes.
This is one aspect, but I think another aspect is also your cohort is pretty young. And with increasing age, there is a proximal shift from colorectal cancer. So I think the benefit for the proximal colon, which can be only be assessed by colonoscopy and not FlexiSig, will come clear in the next 5 to 10 years. Because now the data are pretty similar, like sigmoidoscopy trials.
Yeah, they are.
One other question. Just one other question. Talking about cost reduction in the future, what would you think? We have this low-risk group that we just see every 10 years. What do we do with the histological work? Do you think we still should, when we have these high-resolution endoscopes, still remove the polyp, not send it to a histological report? Because this is another cost factor that is quite high. And we see that actually these patients have almost no risk compared to the others. Just show you these polyps, as we see, they're benign, they're low-grade adenomas just away. Or do we still send them for histological workup?
Good question. I don't know if you want to answer, Thomas or Kaspar. I think, well, you have to resect them. If you believe in the adenoma, see them, you remove them, but you look at them with your ID and everything, NBI, and maybe CADEX in the future. You ask the computer, yes, that's not a adenoma, you remove it, you just don't send it.
Well,
that's I think, not now, but in the future, I think that will happen.
I would say the cost here in Switzerland, maybe a colonoscopy costs between 600 and 800 Swiss francs. The histological workup is another 200 Swiss francs per polyp, per specimen you send. So it can be pretty much more costs in one patient, maybe 400 francs more.
I totally agree. I think at some stage we come to the point where we resect and discard if it's less than 10 millimeters.
Well, we
and
could do
at
it
least
now.
one.
We don't need anything below 5. Throw it away. You don't need AI. Nothing. The risk is so low. Why do you need to confirm here and there? And it's a legal thing, a medical legal thing only. Yeah.
Absolutely, as long as they don't have any lawyers in the background.
I think it's important that you document. You take a couple of photographs, you know, so you can document and describe it. I think that's important.
I think everybody can wonder when he met the last 5 millimeter polyp, which surprisingly turned out to be cancer. 10 years? Never? So, Jacques has a question.
This example of what Thomas is saying, so let's say a polyp less than 5 centimeters, there's enough data to actually put this in a guideline. All our guidelines are, the bigger part of what we put in our guidelines is evidence-based. So as soon as we put this in a guideline, it's evidence-based. And then you have proof, and then you can defend yourself against lawyers. It just takes courage. That's the only thing.
I agree.
Maybe we have to follow your approach for Barrett's. That means we just remove all the polyps, but we don't make any follow-up for the low-risk situation like you do for the low-risk Barrett situation, and we use that money and information for more research.
Well, screening works, but surveillance basically
That's
sucks.
what I mean. Surveillance only for high risk, and the rest we just leave completely and look what happens.
If you have one colonoscopy that you can spend on a patient, you rather Michael, would you do a screening in an unscreened patient or severe high-risk patient that has had a colonoscopy before?
That's a good question. I'm not sure how to answer that.
No, you don't just do it.
Yeah.
I think so.
Gut feeling, what would you do? Would you do a fit positive screening colonoscopy in a patient in which we find, 40% relevant polyps? Or would you have that patient that had a high-risk polyp cleaned by an adequate endoscopist undergo surveillance for the rest of his life?
I would do the fit positive.
Okay, thank you.
I'm not sure, Jacques, because we are, at least now, we are not doing well with the advanced adenomas.
Well,
so
then,
these
then,
are the patients we need.
Then we need to solve that instead of surveying them
yes.
as a compensation for bad quality treatment.
And
so
the excuse that the endoscopist was not good enough, maybe, but...
But Michael pointed out the exact reason. We're looking at patient characteristics, whereas probably the biggest determinant is the quality of the endoscopy. And with AI, especially quality-related AI tools, we can basically monitor that and bring that to a certain level. And then at some point, because if you're going to investigate this for surveillance strategies, it will take you ages before you can actually reduce the cost. So I think, at least in our country, we would likely say, okay, at some point, we sit down, we change the guidelines, and we're going to monitor if that cost reduction and cost saving actually pays off, instead of investigating it for ages, for knowing what we already know.
Okay, this has to bring us, can we take 2 more questions? Yeah.
We're talking a lot about quality of endoscopy, and if I look at my fellows, they all want to become the best gastroenterologist there is. So they all want the best quality. And on the other hand, we're measuring our ADRs, we're measuring our times, how much time we take for a colonoscopy. And we have heard Jacques' talk yesterday, and oncologists are getting better and better. Why don't we just stop with the whole screening program and care for the patients that have a problem? And if they come with a symptom, then we can deal with the symptom. And all those asymptomatic, really asymptomatic patients with a very, very low risk for a cancer, why don't we just skip all that and as he said, take the money and spend it on more sensible, more reasonable stuff in medicine?
Before I'm being blamed for killing screening. Screening works.
I know.
Probably the best thing we ever done. The question, and Michael's putting it, how do we proceed after that? And what's the optimal screening surveillance? But please, not a 30% risk reduction. Basically, if we would do that if that would be the threshold for everything we do, then I would not be giving these lectures.
Final question?
So if I may follow Jacques' point, is any role in looking for a better marker to decide who should undergo surveillance or not once you identify patients in the screening programs?
No, of course. I mean, and a lot of people are looking. But I'm wondering if there is one. I mean, you know, Kaspars, you are having your basic science stuff. You have had that for 15 years. You are looking, everybody else is looking. I don't know, did you find anything yet?
There are lots of studies, but nothing is really convincing, whether it's the inclusion of lifestyle factors, risk factors, whether it's genetic, epigenetic parameters. So there is no microbiome, maybe in the future in 20 years, but currently there is nothing of all this molecular profiling really benefiting and can tailor our recommendations.
And if so, it's likely to be double as expensive as colonoscopy, a sophisticated lab test. Huh?
And it's funny, Thomas, you just mentioned it. Colorectal cancer incidence went up. Now it's went down, 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 down. We have no idea why that happens.
Yes.
And we're looking at all this stuff that you are looking at and everybody else, lifestyle, microbiome. But things are happening. It's gone up and down the last 40 years. We don't know why.
If this will proceed for the next 20 years, the decrease in incidence, then it's even getting more and more. Then yes,
okay.
We don't know why, but it's solved.
If this gets too melancholic, I think everybody needs a coffee. I'm grateful to the 2 presenters. I think we should follow Jacques' advice and tell the AI not to look at the bit pattern of small polyps, but tell us what not to do. Thank you.
Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands, so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands, so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today.
So we start? Yep. Okay, so welcome back, everyone. It's my great pleasure to co-chair this session here together with Jack Beckman from the Netherlands. My name is Christoph Schlag. I'm coming here from the University Hospital of Zurich. And also Stefan is here on the floor. Thank you again for this kind invitation. And this is a great honor to be here. And it's a great meeting.
We are very happy to have you with us.
And I think we are ready to start with the next live demonstrations. And so I would like to hand over to you, Stefan, and you give us a short overview.
This is our fifth case. Next slide, please. This is a 70-year-old male, and he experienced a 5-centimeter large CBD stone and intrahepatic stones. And he received an ERCP last year with a spyglass, EHL, and stone removal. Please show the next video. This is the X-ray. You see here this large stone. Next. Also, patient had intrahepatic stones. Okay, next. So we performed a spyglass EHL, and we were able to destroy this stone. And the next picture will show you that we could remove the stones then with a basket. Okay, nächstes. So the CBD looked quite free of stones. Next. And then patient received a cholecystectomy, and now, next slide, he received an MRI in April 2023, and now Mishka Patak will demonstrate us the MRI pictures.
So we see it's quite impressive with all these. You see, this is liver. This is the strongly dilated bile duct, and you see even here, close to the papilla, you have intraductal stones. But you not only have stones within the bile duct, but within the intrahepatic parts of the bile as well. And you see they're hugely dilated. This is on the left side, segment 2. You have there, that's not the gallbladder, that's intrahepatic, like a street full of stones in one of the segments. So you have different segments that are hugely dilated with multiple stones. These are just a transverse image. This is, again, it's not the gallbladder that has been removed. It's an intraductal cast.
So as you will appreciate it, patient has a choledocholithiasis and also intrahepatic stones. It's very interesting. Patient is completely asymptomatic. And next slide, please. Now we are planning to perform a spyglass cholangioscopy. And the first question is, can we remove the stones from the CBD? And the second question is how to deal with the intrahepatic stones. And I think there's no better than Horst Neuhaus, who will demonstrate us how he will continue with this case. And with him is Patrick Epley from Luzern.
Thank you, Stefan, for this kind introduction and for giving me this challenging case. And what you already mentioned, it's very important to consider the history of the patient, and that is asymptomatic. So that means we have to consider that, because I think it's quite unlikely that we can remove all stones in the left hepatic duct. But let's see what we can achieve. So I'm perfectly under control by Pratik, and Anna, please, will assist me, and Silke and Salome. So perfect team, fantastic endoscope, the Olympus TGF-Q 190V. So when you show the endoscopic image, then we can nicely see the papilla and also the size, the location of the sphincterotomy. Can you see a small sphincterotomy? Maybe there is already some scarring, so the very small opening. So, and I'm using the Cook sphincterotome, the tritome, because we want to see how large the papilla is, because we consider to remove stones and fragments, and therefore I would like to get a larger papillary orifice, and therefore I asked Anna to advance the wire. It's not necessary to inject, because we have seen, so advance the wire and we proceed for a CRE balloon 12 to 15. So it's not, because when we do cholangiography with the ESCP, we will see the same as we did, or even less as we did with MRCP. We know exactly what we can expect. We have the impacted stone left hepatic duct, and also some stones in the periphery of the right side, and stones at the hepatic confluence. So therefore, the plan is to, as I said, to proceed now to large papillary, large balloon dilatation, followed by spyglass, because we can, it will be impossible to remove these stones with conventional ESCP techniques, and we have to see if we can approach the left hepatic duct. So for dilatation, we use the CRE balloon, 12 to 15, because we have not seen a tapering of the distal part of the CBD in MRCP, and therefore it's safe to do that. So we see now the proximal end of the balloon is here, and now, Anna, we can already inflate to 12. So it's pressure dependent. So half of the balloon is inside, and okay, and you can proceed. So 15. Okay, 15. This corresponds to a pressure of. Yeah. Okay. Okay. 6. Okay. 6 atmosphere.
Just two questions through the balloon dilation. So first, how do you choose the size of the balloon? Now you said you choose a 12 to 15. What are your thoughts on that? And the second one, how long do you do the dilation?
This is a good question. In case of, this should not be mixed. In case of a large balloon dilatation, it's just enough if you inflate it for a very short time, so for half a minute or so, as we can already see. Now we have a nice access here. As you see, it's much easier. And, well, we can, for those who have limited experience with spyglass, you can insert it over a wire. But I think to save time, I will proceed to freehand cannulation. Now we get spyglass ready. So coming back to the timing for dilatation, the difference is when you do sphincteroplasty without sphincterotomy, just sphincteroplasty as an alternative to sphincterotomy. This is the difference to endoscopic large balloon dilatation. Then you should dilate at least for 2 minutes, because the studies show if you dilate less, then you have a higher risk of post-ESCP pancreatitis. And this is probably because you have just an edema and did not really open the papilla. So now we get spyglass ready, and as you can see, this can be quickly done. And most of you probably know the technology. It's 10 French catheters, steerable catheters. So I have the wheels for 4-way deflection. We have a 1.3 millimeter working channel, CMOS video technology, 2 LEDs, and 2 separate irrigation channels. So I'm inserting it now through the 4.2 millimeter working channel. So, and you see the Y connector, when you go close with the camera, the Y connector to the inner channel allows that we insert any kind of instruments, in particular the EHL probe through the channel, and through the side port we could, for example, inject contrast. So I close the valve, elevator open, so we see the distal end, and just to show you the efficacy of irrigation. Is it? It's not yet connected. This one, okay, no problem. So you see, as I said, 2 separate irrigation channels, very effective. This, I have to admit, is an advantage of a DPOX and also mother and baby scope, because then you have to inject through the channel alongside, for example, an EHL probe, and this is less effective. And we should also finally connect vacuum here, or we have here. Here, vacuum is here. That means, coming please close with the camera, when we want to decrease the interluminal pressure, which is especially important in the intrahepatic system, to avoid intensive flushing, but we want to decompress, then I just open the valve, and then it's connected to suction. This should minimize the risk of cholangitis, and if you do pancreatoscopy, of pancreatitis. So as with all rigid instruments, it's recommended to come close to the papilla, as shown here. So I've not yet bent it in, just getting close, kissing the papilla. So, and then I advance the scope a little bit more deeply into the CBD, and now you can nicely see that we have a straight access. Yeah, you can nicely see the distal part of the CBD. This is, for example, also interesting when you want to exclude intraductal tumor spread of a papillary adenoma. And now we should switch to the cholangioscopic image, please.
Or just one question. You are hardly using your elevator for this, right?
Yes.
It's just largely your big wheel.
Exactly.
To avoid any damaging on the cholangioscope.
Yes. This, I think, okay, now I have to turn around. Okay, this is a little bit tricky, okay. So we
don't see the cholangioscopic picture yet?
So we,
okay.
Yeah, but it's important. I have also to see the duodenoscopic image. Because otherwise I have no control of the to the papilla. Picture in picture, please. Because otherwise you lose easily access and you lose the position. So I'm advancing now the scope. We are in the mid portion of the CBD. This should be the area, probably the, no? Okay. So this, no? So the cholangioscopic image large and the duodenoscopic image small. Because otherwise, especially when you proceed to interventions, if you don't have the duodenoscopic image anymore, then you easily lose the position. But we don't want to lose time, so then switch back. If you cannot manage this, then we have to try it. Okay. So we are still, of course, this could be this, maybe this could be the stump of the cystic duct. Patient is previously underwent cholecystectomy. So, and now I flush.
So is there any situation you would use a guide wire as well, or you just are
not yet
comfortable enough to do it only with the scope itself, the navigation?
Scope itself, navigation.
Of course, you generally give the patients antibiotics.
Yes, in all cases with proximal lesions. Yeah. So here are already some stones, combined stones. We are at the proximal CBD, should approach the hepatic confluence. So where can switch back to the duodenoscopic image before? I feel inconvenient not to see, okay. Where is it here? Okay.
Oh, B.
B, okay. So now we are approaching the hilum. So as you can see, I'm rotating the wheels, and we already see the hepatic confluence here. And now I lock the wheels, and now we can open the valve. So to switch to suction, is the vacuum on? Vacuum? Vacuum pump should be. Okay, so as you can see, I flush, and simultaneously I open the valve to get rid of the mucus here. Okay. It doesn't work well. So, and now we see here the right and left hepatic duct. And now coming back to your question, now we insert a guide wire. Firstly, guide wire. To see how far we can advance the wire before, or let me see, just a moment, I have to switch back. Yeah, as you can see, huh? So yes. I need the colonoscopic image, in the duodenoscopic image, so otherwise.
And so far you have not used any fluoroscopy at all, right?
Not yet, not yet. Okay. So I try to keep it in a short root position, but then it's not so easy to approach the hilum. Okay, now. So I lock the wheels. Yeah, so. Okay, so now let's advance the wire, yes. Because the position is not so easy, and it's always so the confluence is completely normal, and I think the stones that we have seen in the common hepatic duct are relatively small. This is not the issue. And now we have to see, this is sometimes in this situation No. Let it. Okay. So to see, this is already the side branch here. So now I advance the wire, and in the same way you can do wire-guided cannulation. So now fluoroscopy. Where's fluoroscopy here? The left? Okay. So can you focus on the tip of the cholangioscope? Who moves? Who is responsible now for X-ray?
And just a question to Stefan in the meantime. If you know this patient has been put on also diastolic acid, or yes. Because it looks a little bit like she has some
now
problem.
Can we turn the picture around to the left, right? Yeah, now, okay. So we are obviously in the right hepatic duct. The guide wire is in the direction of segment 6 here. So we can now inject a little bit contrast to the side port to confirm that there are no larger stones on the right side. And this is the way how we can evaluate the, yeah. So it takes some time. Okay. The CBD is filling. Yeah, it makes the turn, and you see the large dilatation of the CBD, and this is the right side, but the problem is on the left side. And therefore, we haven't seen now stones here, as expected from MRCP. So I close the valve again. So pulling the scope, I lock the wheel. So then this should be the left side here.
Can we have the cholangioscopic image back?
No, this is also right side. Okay. Yeah. This is another segment on the right side. We can let me see. We can inject a little bit contrast here.
Next case.
Yeah. Okay, Horst.
Yes.
I think we will leave you alone for a while at least, and we come back later on because we will go now to another room and have a look to another interesting case.
Okay.
So I think Stefan will introduce the next case now. So see you later, Horst.
Thank you.
So we would like to demonstrate you now a very complicated case as well. It is a 50-year-old male. He had a liver cirrhosis with a hepatocellular cancer, and he got a liver transplantation in 2021. And now a cystic lesion in the uncinate process was detected, and this lesion measures already 3.5 centimeters. And we actually have performed an MRCP first, and Miška Patak will demonstrate us now the MRCP pictures.
So this is the 3D MRCP, and you see that there are like a knot of cysts in the pancreatic head. If you go then in the transverse images, you see it's not actually in the pancreatic head, it's in the uncinate process. And you see there several of these cystic lesions, and you have, in some you have like some dots, and you see also that these septae, they are quite wide. This is a coronal image, you see. And then when you give contrast in the arterial phase, you see there's at least some contrast enhancement of these septae. And then this is the portal venous phase. And you see that also parts of these cysts take a bit of contrast. This is the so-called diffusion image. Again, in the diffusion image, you have restricted diffusion. These black lines, these black dots, they shouldn't be there. If it's just mucus, it's white. So these are more or less classical worrisome features in a cystic lesion in the Angstner process with contrast enhancement, the thickened septae, which take contrast as well, and diffusion restriction.
So this is a 3.5 centimeter large cystic septated lesion of the pancreas with intracystic nodules. And I think this is now not such an easy lesion, and the decision is also not easy with regard to the liver transplantation. And I'm very happy that Chaim will demonstrate us now an EOS in this case, and what will be his final recommendation for the patient, wait and see or surgery.
Hello.
Hello.
Hello, we hear you.
Yeah, oh, thank you. So, Stefan, we heard the story, and we're just having a good look at the pancreas. So, I think we have identified the structures that need to be demonstrated. So, there is no surprises here. Aorta. And then as soon as you see the aorta, we look for the celiac artery. And once the celiac artery is identified, you advance the scope. You're almost always on the pancreas, which is what we are looking at. There are some features of chronic pancreatitis in this patient. The pancreatic duct is very, very tiny and small, probably hardly a millimeter in size. So it's very important to start looking at the pancreas in the tail because you want to know whether it is a main duct IPMN, given the story. Is it a branch duct or a mixed duct IPMN? So I have features of pancreatitis, a very small pancreatic duct, and then I pull back, and then you can see some lobulations on the pancreas, and then you just move your shoulder to your right, and you retract your scope, and the pancreatic duct will always follow you, and you keep tracing it, and I keep tracing that further. It looks pretty normal, except for changes of chronic pancreatitis in this patient. I'm now over the spleen, which tells me I'm pretty much at the end of the gland, and then you can see the pancreas nicely diving into the splenic hilum. And then I exactly do the opposite of it. I push the scope in, turn the shoulder to the left, and then here is the pancreas again. So the body and tail look pretty innocuous, except for changes of chronic pancreatitis. So you got the picture-in-picture view. So I'm advancing the scope past the pylorus into the duodenal bulb. You suck air. There is a portal vein with a heavy flow. And then I look on this side, and then immediately you see the bile duct here, pancreatic duct below, the portal vein posterior, and then I'm just pushing in. I just move my shoulder back and forth, and here is the cystic lesion that you detailed. So if there's any confusion, you can put your Doppler, and as you can see, they are all ductal structures. Obviously, that's the reason we don't have any uptake. And here is the cyst lesion. Little posteriorly. So it's always important when you evaluate a cyst that you go to the uncinate process and then you retract, only because if the pancreatic duct is larger than the bile duct at the uncinate process or the papilla, then you're dealing with main duct IPMN. So I'm just shortening my scope like what I would do with an ERCP. I'm sucking air, and then I'm right away on the pancreatic uncinate. So actually it's an uncinate lesion. And once more, here is bile duct. This is all pancreas. Let me see if I can identify the pancreatic duct because that's very important. And then you just make some small movements back and forth. It's multiloculated cyst. Once more, bile duct. Posterior to that is the pancreas. Obviously, we can't sample here. You have to go through the bile duct, and that will be unfortunate. So I have to find a good window first and make a determination whether sampling will change anything, and to figure out what this lesion is. So I've looked at the uncinate process. I wouldn't say it is the greatest exam from the uncinate. I'm going to try one more time, and here it is once more. Bile duct. Posterior, yeah, now I got what I wanted. Here is the pancreas. So you have to just focus on the pancreas a little bit, and you can see it's not dilated at all. So once more, bile duct. Here is the pancreatic duct. They both go into the papilla. Looks quite normal.
So once you do that, this clearly, the differential diagnosis gets narrowed. We are either dealing with a serous cystadenoma or a branch duct IPMN. The fact that this patient had a transplant, I'm sure they have done a lot of scanning pre-surgically, and it was not a serous cystadenoma. So now you want to laser focus on this region, and here is the cyst lesion. Yeah, that is the nodule inside. It's not big. It's about 3 to 4 millimeters. So there is enough data to tell you that when you're looking at a mural nodule, and if it is a mural nodule, if it is more than 9 millimeters, there is almost always cancer. But if it is less than 5 millimeters, then actually we don't know what we are dealing with. So this is quite small, 4.5 millimeters lesion inside. So you just go back and forth. Here again is a cyst. So there is this issue of contrast. Does contrast help? I don't believe in contrast. In the United States, we have just got an approval to use contrast. It doesn't help with anything. It might show increased uptake if a mural nodule is, and to differentiate from a mucin plug. Here, you can see that the lesion is connected to the duct wall. It's not a mucin plug or anything. It is connected to the duct wall. So what we are dealing with is a very complex mucinous cyst lesion with a mural nodule and some high-risk features. What is the size of this lesion? That is one thing where MRI scores over CAT scan, an EUS. I think EUS is a little overrated for pancreatic cyst lesions. There's a lot of false positives and false negatives. So if you look at it carefully, and I'm going to freeze the screen here, and if you want to measure, starting from this dimension, taking it all the way down here. So this is approximately 4 centimeters, and then starts there, and then I'm just going to get down, and it's about 4 by 3 centimeters. So now we can use SonoView. We can go ahead and inject and see if it adds any advantage. So if you have to sample this lesion, we have to ask ourselves, what are we going to achieve?
My question.
Good.
What is it?
So,
is it just
Shaim, can we just pause there for a second and just poll the audience here?
Absolutely.
Okay, so who thinks this patient needs an FNA or some kind of tissue sampling during this procedure? Raise your hand if you want an FNA or an FNB. And raise your hand if you, then nobody's raising their hand, so basically then, who wants then to leave the patient alone? We're not going to sample it, and we're going to send him off and never scope him again. Who wants to do that? Again, so, and who wants to send the patient to surgery, despite the fact that he's a post-liver transplant case? Okay, in my country, it usually works, if you raise your hand, it works like this. And if you're not raising your hand, you're basically not here. So again, surgery, hands up. Yeah, so, and sending him off and leaving him alone because he's old and he has a liver transplant. Nobody. Still not everybody's raising their hands, so be careful because I will target you for questions. Shyam, nobody wants to sample, nobody wants to leave the patient alone. The vast majority wants to send the patient to surgery.
Okay.
So you're done.
Yeah, pretty much. We can do the SonoView.
You have a mind of your own, we've noticed over the course of this.
So
what would you do?
I wouldn't, I agree with the audience. I think this is a surgical, if this patient needs one thing, he needs a Whipple. That's it. There's nothing we are going to prove. Yeah, we're going to go and give SonoView. So I think we need to change, since I don't use SonoView, aren't we supposed to change the settings on the computer to see both the,
No, but
so I think, that's not elasto. We just need to show SonoView for contrast. Yeah, CHI, there we go, beautiful. So you can see I'm very naive with contrast because we just don't use contrast at all in the United States. If you have to sample, this is purely an academic question. I think the only accessory I will use is a 19-gauge needle in conjunction with a micro. They call the Moray forceps, and that I would use to go and sample this lesion. if there is evidence of cancer in it, if you want chemotherapy and if you want tissue. Otherwise, a regular FNA or a FNB needle, limited utility in a patient with a multi-loculated cyst. I don't think we're going to get anything sampling this lesion unless you have a microforceps. The other option is to use a spy bite. You can also put a spy bite through a 19-gauge needle and you can sample. So, not seeing anything fantastic happening here. This is what I like about contrast. The screen is beautiful. It glitters like the solar system, but then I have no clue what I'm looking at. And then people always come with a lot of explanations. I think if you are dealing with a serous cyst adenoma, it's useful. Neuroendocrine tumor is useful. Some data on mural nodules versus mucin plug, that it could be useful. But apart from that, nothing. You can see that there is, it makes no change to me. So I will not base my judgment on contrast imaging. It doesn't help me in any way.
So Shai, a couple of questions, and then we have to couple of questions, and then we have to round up and go back to Horst. Let's say we found a CT scan of 8 years ago, and then this lesion was already there.
So that's a beautiful question.
So then would now suddenly this thing look like a serous cyst adenoma?
You nailed it, John. So this is the problem that we have. The accuracy of EUS for pancreatic cyst lesion is anywhere between 50 to 65%. I think we do a fantastic job sampling and saying whether there is cancer or not cancer. What we are horrible is differentiating the different type of cyst lesions. I think we do a terrible job. Once again, we are all data driven. I don't have data to prove, but I can tell you, after transplant, something happens in cysts. And the reason is, I have seen a couple of patients with about 3 or 4 millimeter cysts. They've gone and had a transplant. They came back within a year and a half with a deep jaundice. We thought it's a rejection. But then when you do a CAT scan, the entire liver was flooded with liver mets from a pancreatic cancer. So the biology of a cyst neoplasm, in the setting of immunosuppressive therapy, something happens. But if you ask me evidence for it, I don't have it. But I've seen about 8 to 10 patients. So if this patient had a lesion exactly 10 years back, I would call this a serous cyst adenoma. But since we had a CT scan, I'm sure they did not do a transplant with a big cyst in the pancreas. This more likely is a mucinous cyst.
Okay, and so you would suggest that this patient would undergo Whipple's resection based on what?
Yeah, Whipple's, and I wouldn't do anything else because there is no point surveying this patient anymore because we think we know what it is.
Okay, thank you very much. Excellent demonstration. We will be taken back to Horst, who's hopefully in the left liver lobe now.
Thank you. No, pretty good. No.
Horst, we're back.
So I would like to show you on fluoroscopy where we are. So after we confirmed that there are no stones on the right side, I approached the left side, and as you can see now on fluoroscopy, the left hepatic duct is completely blocked according to also the MRCP because of multiple impacted stones. And we can see the stones here. We already partially fragmented the stones. Position is quite difficult because the instrument is in a very angulated position. So, and Anna, could you flush? Okay, so we have the EHL probe, and as you can see, we can effectively fragment here, and this is very safe. Always you have to reassure that you see the tip of the probe. So, for example, not firing at this in this situation, then it may cause minor bleeding. The challenge is, as I said, to centralize the position, and of course, flush. It has to be done under continuous irrigation. And the technology of EHL is it's spark discharge at the distal end of the probe. So it's a contact method. We need a direct contact to the stone, as we can see here. And we use a lot of fragments. And this is, again, also the advantage of spyglass and also now of the IMAX, that we have separate irrigation channels. So, because otherwise you have a lot of clouds of fragments and sludge and can no longer focus and position the stone correctly. As you can see, we quickly fragment, although we are in not an easy position. So we suck, of course, with a duodenoscope in between to minimize the risk of aspiration because the patient is not intubated. Maybe we already fragmented the stone here. I cannot now pass.
Or so one of the questions is, what are you using for flushing? Just saline or any special
Saline,
stuff?
yes, saline.
And it's constant flushing and the vacuum system is on, right?
Yes,
so
exactly.
You're circulating
exactly.
the fluid.
Yes. So at this stage, I think we fragmented. We should now inject contrast, or there's another stone here, to see if it makes sense to continue. Because when the whole left liver lobe is full of stones, so yeah, contrast. So that means, Anna, use now the side port of the Y connection. Okay, so yeah, okay. There's now more resistance, but Anna is very strong. Anna versucht. So, okay. Okay. You see this enormous dilatation of the left side. Yeah, it doesn't look so bad because there was a complete obstruction before. This is enough, Anna. So I think it's worthwhile to continue with fragmentation, to remove the fragments. So would you please so kind to flush and I fire?
So Horst, just explain this again. You just said now it's worthwhile to continue. When would you have not continued?
When I would have seen that all the segments are full of stones with no chance for complete stone removal. When stones are impacted in segment 2 and 3 and all side branches, then I think, as I said, in a symptomatic patient, on a younger patient, I would recommend left hemipatectomy, which is a minor now surgical procedure, can be done laparoscopically, because also the risk of recurrence is high, and in young patients you have also to consider an increased risk of about 10% of developing cholangiocarcinoma. But here I think it looks not too bad. So my aim is now to fragment as much as possible. Then we leave a wire in the left side, and then we proceed to probably balloon extraction.
But are you confident to do it only in this session, or do you think he has to come back for another one?
I will try as much as I can in this session.
Yes. So you're confident.
So let's say that because he had the same procedure last year. So let's say last year they also cleared out the whole left system, and now you're clearing out this whole left system again, and you're satisfied, and then he comes back in a year, and again he's asymptomatic, but he has his whole left system full of stones. Would he then need surgery?
Less is more in endoscopy, huh?
Yeah. Well, then maybe
you are right.
Indicated.
No, therefore I said from the beginning we have to consider the history of the patient. But last year, Stefan removed a huge impacted stone in the common bile duct.
Okay.
He was not in the left hepatic duct.
So he deserves an attempt to clear his whole left system, and then if this problem is recurrent, then surgery becomes an issue, right?
And I would not spend now and repeat procedures so often. We try what we can today, Flash, and finally we come together to a good conclusion, Jacques. It's always you and Dr. Schlag in the background and Pratik, so I have not to take this decision on my own.
Sorry,
thank you for your modesty, Horst. We will leave you work on that. Maybe we'll come back, and now we're switching to the lecture of Amit. I think. Yes, Stefan is nodding, so that's. So we're going to learn from the Grandmaster tips and tricks on the papilla. We saw you tipping and tricking on a difficult case earlier this morning, so we're looking forward to your lecture.
Thank you so much. So once again, special thanks to Stefan for calling me here. It's a great honor and privilege for this really outstanding and prestigious course. So I'm going to talk to you on tips and tricks at the ampulla of Vater, which is basically related to selective cannulation of the bile duct and of the pancreas. So before I begin, I just want to tell you the definition of the ampulla of Vater in the eyes of a beginner in ERCP. The definition is, ampulla is a small, delicate organ situated in darkness and surrounded by vital structures. The reason is that the ampulla of Vater is the first and the most important hurdle for doing any further therapy inside the bile duct or the pancreas. And these are the words of Peter Cotton, who mentioned way back in 1991 that from a beginner's perspective, ERCP can sometimes be 99% perspiration. In fact, today you saw me perspiring a little bit while trying to take out the pancreatic duct stone, but it was not for the cannulation part, but predominantly because the stones were impacted inside, just in the beyond the ampulla of Vater. Now, why is this so? Why is the ampulla of Vater and selective cannulation a tricky issue? Because the innocuous looking ampulla of Vater, which looks very simple, is actually a very complex organ. As you can see here, there are multiple sphincters. And if you see the course direction of the bile duct as it goes through the ampulla of Vater and the lower part, it is not straight. It is virtually a S-shaped course. The bile duct traverses vertically down, then a little bit horizontal pathway, and then once again a vertical pathway. And the other issue is that no ampulla of Vater is the same if you take consecutive patients. It's like the faces of a human being. In fact, there was a paper published a few years back which showed the influence of various types of ampullae and the difficulty of cannulation. And if you were to see here, they showed in this paper that depending upon the type of ampulla, it can pose various difficulties of cannulation. For example, here you can see success rate somewhere around 93%, which can drop to 71% if you have such type of an ampulla of Vater. And therefore, you have to keep on modifying the technique, understand the anatomy of the ampulla of Vater, and only then you will be able to achieve a proper selective cannulation. Well, this was the traditional old technique of cannulating the ampulla of Vater, maybe around 25, 30 years back, maybe even more than that, longer, where we did not have excellent sphincterotomes which could be bent. We did not have very good guide wires or glide wires. So the technique was to identify the ampulla of Vater, take a ERCP cannula, which could not be bent, then put the tip of the cannula in the orifice, and then try to ram your way inside the bile duct. Well, such type of a technique was invariably associated with failure or complications. Now, this whole situation changed because of the better understanding of the ampulla. You see here, this is the course of the bile duct. So nowadays, to cannulate selectively the bile duct or the pancreatic duct, we follow a stepwise approach. The standard technique of cannulation, then cannulation with a glide wire, which is recommended. If that fails, we modify the technique according to the ampulla of Vater, and the technique can also be modified depending upon some events which occur during cannulation. And if everything fails, you have to change the technique if all traditional methods fail, and use the special techniques in surgically altered anatomy. The whole story changed because of the advent of hydrophilic glide wires, and because these glide wires can be rotated beautifully from outside by the assistant, and the guide wire itself finds its way across the lower part of the S-shaped bile duct. And you see here position of the endoscope for proper cannulation, and this is the ideal position where it is a slightly semi-loop position. You can sometimes use a completely straightened duodenoscope, and very rarely, if the ampulla is not coming in the right position, then you use a loop position of the endoscope to keep the endoscope a little bit more stable so that the ampulla does not keep on moving, and then you cannulate it. So what is the basic traditional technique? The traditional technique is you first go inside the orifice. Second thing to do is to pull the whole duodenoscope back so that after you have cannulated, you straighten the lower S-shaped. And after you have straightened it, after pulling the duodenoscope, you just bring the big wheel of the duodenoscope towards the ampulla, and that way you can straight away enter inside the bile duct. I'll show you this, what we do. So this is how we are using a sphincterotome without the glide wire, identify the orifice in the right direction, orient it, bend the sphincterotome, and then bring the big wheel near. Now this can succeed in quite a large percentage of patients. But nowadays, most of the times we use the glide wire technique. So instead of just cannulating and injecting contrast, we use this rotatable glide wire, usually a curved tip hydrophilic glide wire. And you see here, this is how that glide wire can be rotated from outside with a finger. This was done beautifully by Anna when I was trying to do my procedure just now. So here you see now that the glide wire is taken out. You identify what is the direction of the bile duct in your mind. And then after taking the glide wire out, with the glide wire itself, you cannulate the orifice very, very accurately. Because if you see here, the orifice of the ampulla obvator are like the layers of an onion. And if by mistake you don't go in the exact orifice, your wire will keep on penetrating just outside the orifice and create an edema. Now, once the guide wire tip is inside, you orient the axis of the sphincterotome towards the direction of the bile duct. And that is the time where the assistant keeps on rotating the wire. The wire usually finds its way across in the bile duct. Now, if you are doing the procedure in a supine or a prone position, even without injecting contrast, if you see the guide wire has gone parallel to the spine, that means you have entered the CBD. And after that, you just pass the sphincterotome ahead, put some contrast, and thereby you can achieve deep selective cannulation. There was a meta-analysis, you can see here, of contrast injection versus glide wire cannulation, and you see here, higher cannulation success rate with glide wire assisted technique has been proven. So nowadays, most of the endoscopists use a glide wire technique for cannulation, but not contrast. What if you have a situation like this, where the ampulla is facing down? Here again, you take the help of the sphincterotome, you lift the fold. So what we do is, we open the elevator, drop the sphincterotome inside, go in the orifice, bend the sphincterotome, and then it brings you in the axis of the CBD. And then once again, after bringing it in the axis, the assistant rotates the guide wire, and you enter inside the duct quite effectively. You have to modify the technique sometimes if the ampulla is not in the right position. Here you can see here, we are not getting the ampulla in the right position in a normal straightened endoscope technique. So therefore, we may have to do a long loop technique. So here you can see the ampulla is a little flat. We are trying to cannulate it. It's just not entering, and the ampullary position is not very stable. So now I push the scope inside in a semi-long loop position. That brings the ampulla in a much better position so that the sphincterotome can go towards the axis of the CBD. So you have to keep on modifying the technique as you do the procedure. Sometimes you have to do it a semi-long loop technique. What happens if there is a periampullary diverticulum? This is a difficult issue because you can see here there have been a systematic review and meta-analysis which showed that if there is an ampulla located on the edge of a diverticulum, the difficulty of cannulation can be 50% more than a normal cannulation. And however, this study showed, or this meta-analysis showed, that there was no difference in post-ERCP pancreatitis, bleeding, perforation, or cholangitis. But selective cannulation can be 50% more difficult if there is a periampullary diverticulum. So what are the tricks if the ampulla is in the diverticulum? Here you can see this is a diverticulum, ampulla is inside, and only when you suck, the bulge you can see of the bile duct. Once again, the same thing. The orifice is right down here. So drop the elevator, drop your sphincterotome so that the tip of the sphincterotome goes in the orifice, and then you bend the sphincterotome and then just lift it. By lifting it, what happens is the roof of this ampulla becomes straightened. So now you have straightened the roof of the ampulla, and that way you can go in and cannulate it. What if the ampulla is located inside the diverticulum and facing towards one side? Here you can see the orifice on this side. You can't use a sphincterotome here. If you use a sphincterotome, it will keep on going in a wrong direction. So it's better to use a normal ERCP cannula and use the technique which is called as a fulcrum technique. So I put the sphincterotome tip in the orifice of the ampulla and just rotate the small wheel of the scope. By rotating the small wheel of the scope, the ampulla is fixed by the tip of the cannula, and it comes in the right direction for going inside the bile duct. Well, in case the ampullary orifice is just not seen, then sometimes we land in trouble. So because we can't do anything, so here we can use a technique which is called as a baby forceps technique. We can pass a baby biopsy forceps, catch the fold above it, and push the ampulla away, and by the side of the baby forceps, we can go in with a sphincterotome and cannulate it. So this is the way you can pull the ampulla out of the diverticulum. Another simpler method is to just give an injection of normal saline inside the diverticulum. It creates a depot of normal saline and the ampulla comes out. That is the time you have to grab and cannulate the orifice of the bile duct. Well, in case while cannulating your guide wire keeps on entering the pancreatic duct, then what do we do? One of the options is to leave a stent in the pancreatic duct, temporary stent, and by the side of that you can go. But another very nice technique is to use a double guide wire technique, where you leave the guide wire in the pancreatic duct, and with that guide wire inside, you go with the sphincterotome and go on the left upper part of this guide wire, pancreatic wire, and that way you can go in and cannulate it. So here now you can see that you have left the pancreatic guide wire inside, and by the left of that guide wire, again we are using a sphincterotome. And if you push the pancreatic guide wire away, the septum between the bile duct and the pancreas goes down, and that way it opens up the biliary orifice. So this is a very, very useful technique, a double guide wire technique. So don't worry if your guide wire is entering the pancreatic duct. Use it as an advantage. Keep the guide wire in, and then you can go in and cannulate the duct. Other option is to do a sphincterotomy, which is called as a transpancreatic precut. So if your guide wire is in the pancreatic duct, you leave the guide wire in, and over that guide wire you push a sphincterotome. Just orient the wire of the sphincterotome towards the CBD and keep on cutting the pancreatic duct and also the septum, and many of the times you can open the bile duct this way. But this technique, even though it is very useful, it is a little dangerous technique for a beginner, because if this technique is not practiced properly, it can lead to post-ERCP pancreatitis. So therefore, we resort to a technique if, in spite of repeated attempts, you just cannot enter the bile duct. Then one of a very useful technique is the precut. Now, precut is not a sphincterotomy, but precut is just an accessotomy. So here you can see what we do is, by precutting, we are only de-roofing the ampulla obvator and making your accidental cannulation into an intentional cannulation. So we de-roof the ampulla obvator, expose the salmon pink epithelium of the bile duct, and then intentionally cannulate it. So what we do now is, we have now first understood the anatomy, and now what I do is I take this needle knife sphincterotome, or you can also use the Sohendra precut sphincterotome, which unfortunately is not available commercially. But if you use the needle knife, I'm going to show you what is the exact technique of needle knife precut. So here you can see the needle knife. You start from the orifice, because there is a principle in surgery that it is always better to go from the known to the unknown. So instead of cutting from above downwards, it is better to start from the orifice so that you never lose the direction. And the most important thing in precut is not to cut too deep. It is like a surgical incision. When a surgeon opens the abdomen, he never enters directly into the peritoneum. It's the one by layer opening. So you have cut the mucosa, then you push the mucosa away, you start seeing the bulge here. Even by mistake, don't go by the side of the bulge, because then it can lead to a perforation. So your precut should continue on the bulge. So you keep on exposing that bulge and slowly keep on making cuts superficially on the bulge. And at one particular time, you'll realize that you see the salmon pink epithelium somewhere over here. Now, once you identify the salmon pink epithelium, you see here, very, very gently, you can again go in with a sphincterotome or a wire. So you have exposed the bile duct now inside the ampulla, and this is the way you can cannulate it. And if you master the precut, the success rate of cannulation can reach almost 100%. Of course, in case everything you have tried multiple times and this is what happens to the ampulla, which is completely butchered, then the only option we have left now is to do a US-guided rendezvous approach. This is relatively simple if the bile duct is dilated. So under US guidance, you can identify the bile duct through the duodenum, pass a guide wire which comes out through the ampulla of Vater, catch that guide wire, and over that we can railroad a sphincterotome and complete your procedure. Just to show you very quickly how do we cannulate pancreas, very easy, because you wrote that is not S-shaped. Pancreatic duct is straight inside the inside the ampulla of Vater. So you can use a normal cannula, and just by putting the cannula in the orifice, most of the times we can cannulate the pancreatic duct. But I'll just show you what happens when you're dealing with pancreas divisum. In case you have a divisum, the best method of cannulation is with a scope in a long loop position. Because with a scope in a long loop position, the minor papilla comes into view end on. So here you can see now that I push the scope inside, you keep on pushing the scope, that's the major papilla, and as you keep on pushing the scope inside, you'll start seeing the minor papilla. Now this is what is seen, and once the minor papilla is visualized, you can either cannulate it with a 025 glide wire or a 032 guide wire. Very, very gently you cannulate the orifice, and then you can go inside the minor papilla and complete your endoscopic therapy. Here, of course, what we do in our circumstances is to use this special minor papilla cannula, which is almost like a needle. So we first opacify the pancreatic duct through the minor papilla using such type of a needle cannula. And the advantage is with this, you can also dilate the minor papilla a little bit by pushing the cannula in and out. And then that makes passage of a glide wire very easy. Very rarely, if you have an incomplete pancreas divisum, but it is more in continuity with the minor papilla, we can perform a minor papilla rendezvous. So we go through the major papilla, get your guide wire out of the minor papilla, catch that guide wire, and over that we can load a sphincterotome and we can complete the therapy. So therefore, as a take-home message, for playing the tricks at the ampulla of Vater and for proper selective cannulation, right patient selection is important. The endoscopist should understand the ampullary and ductal anatomy in your mind, select the right instruments, proper and meticulous and gentle technique, timely modification of the technique and the approach if it is difficult, and stage your procedure if multiple attempts fail. There is no harm if you just stop the procedure, call the patient back after a few days, and then continue the procedure for better success. Thanks for your attention.
Thank you, Amit. We'll take one or two questions before we go to the third case that Catherine then will introduce. Any question from the group? If you entered into the pancreatic duct and so you have access to the pancreatic duct and you still can't get into the CBD, do you then prefer the freehand needle access, or would you simply use that sphincterotome approach like you've shown and do the transsphincterotome pre-cutting?
Instead of transpancreatic sphincterotomy, I'll prefer the double guide wire approach. So I usually leave the guide wire inside the pancreatic duct, and by the side of the guide wire, I try to cannulate the bile duct, which is invariably successful. If that also is not possible, then I prefer to leave a small 5 French pancreatic stent, and by the side of that, I do a needle knife sphincterotomy.
Because otherwise, that also prevents the post-EXCP pancreatitis. Okay.
And just following on this, how many pancreatic passages would you allow to do so? So only the first one, or after the second, after the third?
Three or four.
Okay.
3 or 4, not more than. Definitely no contrast.
Yeah, definitely no contrast.
Because that is a definite precursor of post-ERCP pancreatitis.
And not more than 3.
Only glide wire.
Yeah. But 5 attempts on the papilla, 5 times in the pancreatic duct means...
And 5 minutes of trial.
Okay, good.
Yeah.
Because
it's a rule of 5.
Yeah, but it's a much lower threshold of proceeding to the next step instead of continuing something that has failed before.
At least change your technique or modify it.
Okay. Amit will be available also during lunchtime, so please go up to him and ask him all the questions that you're too shy to ask now. So thank you very much. And Catherine, maybe you want to be so kind to come up and introduce the third case of this final live session.
Our patient is a 67-year-old lady who just recently had her colonoscopy, which showed a very large polypoid lesion occupying more than 50% of the circumference in the rectum, ranging from 8 to 14 centimeters. The histology showed a tubular adenoma with low-grade dysplasia. Here in this picture, you can see this large lateral spreading granular lesion. Again, we performed underwater zoom endoscopy with a crystal violet. We have a very nice regular pit pattern on this picture. Here is another area where you can see that there are smaller glands. So overall, our endoscopic assessment allowed the following grading: LST 0 to 2A granular mixed type, a JNet of 2A to B, and Kudo 3S, 3L, and 4. The treatment options are various. We decided for the endoscopic submucosal dissection. In this case, you will have a presentation of the technique of the pocket creation method. You should learn more about hemostasis and tips and tricks on how to improve your ESD. We are very happy to have Professor Yamamoto here to perform this live ESD.
Hiro, just 1 second, because we can't hear you. We still can't.
Can you hear me?
Yes.
Yes, we can.
Okay. Hello. I'm Yamamoto. Thank you for the invitation again. And I will work with together with Lemon and Mayo. And I want to show you the pocket creation method of ESD. Can I show you the endoscopic image? Okay, this is the lesion. And when I insert the endoscope, the lesion is located at the 12 o'clock. But it is better to locate to the 6 o'clock. So you have to be able to change the position by rotating the scope like this. And another thing I will check is the direction of the gravity. Using water and see the direction of the gravity. And in this case, the right side of the lesion, that is the downside of the gravity, and the left side is upside of the gravity. Okay? And while waiting for you, I have already injected a sodium hyaluronate solution. And for ESD, you have to be able to move the endoscope very smoothly, like this. Okay, then I will start the mucosal incision and dissection from the oral side, and the left side of the tumor, the upper side of the gravity. So I will use the under gas technique. Okay, needle out. So setting is the endocut eye. So this is a flash knife, 1.5, and about 3 millimeter to 5 millimeter outside, about 3 millimeter outside of the edge, I start. The tip of the knife is inside of the mucosa, submucosal space. Then I cut like this. And using the flash knife, this kind of needle type knife, it's safer to cut to the direction from the to the forward. Forward movement is safer because I cut up to the luminal side, not to the muscle side. So this is not connected well, so I cut again, like this. And then I can use the water jet to wash and see the blood vessel is not there. Then I dissect a little bit further with the swift coagulation, like this.
Just one question here. If your cap basically stabilizes your endoscope. So you're not moving the knife, you're just moving your scope leaning on the cap, right?
Yes, that's correct.
So that's
And-
for beginners. If they do ESDs, they have the knife too far out, and then the mucosa hangs onto the knife. And if you then start cutting, you basically jump forward because the tissue is actually hanging on your knife. So you should stabilize the cap onto the tissue, and then you see how elegant Hero does this just by simply moving the endoscope. Hero, we will be with you for another minute, and then we have to go to Horst, and then we will come back to you for the final part of this session. So anything you want to demonstrate at this point?
Okay, I want to show you this is the downside of the gravity. So then I use underwater technique. Underwater or in the air, whichever is easier to use, I select. That depends on the location, in terms of gravity. So this side is under the gravity side, so it's easier to use the underwater technique. Like this. Then I dissect a little bit more.
Okay, Hero, thank you very much for this first part of the demonstration. We will be back to you shortly. We'll now be taken to the RCP room to see where
Okay.
Horst stands with cleaning out the left liver lobe.
Okay, see you later.
Okay, also nochmal. Hier nochmal dilatieren. Jetzt?
Horst, we're back with
Yes,
you.
okay. So what we already achieved is, jetzt Ballon ablassen und Draht liegen lassen. So we fragmented the impacted stone in the intrahepatic system on the left side, as you have seen. So den Draht vor. Then we advanced the wire removed all bile duct stones with a basket and partially also with a balloon. And we already removed a large part of the stones in the left hepatic duct. And now I will show you, so as you can see, the left hepatic duct was completely blocked by stones, and now it's open. And can you show you see the fluoroscopic image? There are still, of course, fragments. And I just dilated stenosis downstream of the stones so that we have a better access to the left side. And now I will just show you how we remove the stones. A balloon is difficult, would be one option. In this case, because this balloon slipped alongside the stones, and therefore I'm using the Olympus Vortage basket catheter, and I will show you how it works. This is a very useful, specially designed catheter for smaller fragments and stones. And it can be inserted. What is also important, as you can see here when you show the hands of Anna, it can be inserted over the wire, because otherwise it's difficult to reach the periphery on the left side. And it's so now open the basket just to show the audience how it works. Yeah, as you can see, and we can even rotate. We can rotate the basket to entrap the stones. Yeah, it's very effective, because otherwise, with a regular balloon, you will have a hard time to catch these smaller fragments. So always in endoscopy and ESCP, work close to the operation field, so I'm close to the papilla. It's a long way to the left hepatic duct, as you can see, because the CBD is dilated and angled. So we could pass now here. We advance it even more in the periphery, but we don't advance it even more because otherwise when we catch too many stones, then it's difficult to remove them. Now we open the basket. Okay, so Anna takes care of the wire, that we don't lose the wire. And now I'm pulling it in an open fashion, like a parachute. I feel, again, a lot of resistance here, which is a good sign. So we don't close it at this stage. So hold the wire, please. Hold the wire. So, and now we see what we achieved. Yeah,
good.
Again, stones. And this is the way, let me see, there's some blood, but also stone fragments. And this is how we proceed. So we will remove as much as possible. And finally, we may leave a stent to minimize the risk of cholangitis.
Horst, would you consider placing a catheter, a nasocystic, nasobiliary catheter, just to flush the left system for a couple of days, or are you not a believer in that?
Yes, I'm a believer, but it's very inconvenient for the patient.
Okay.
So we did a dilatation, and when we place a stent, you will be surprised that next time when one of the Stephans repeat the procedure, then the stones already passed. So I try to make it very easy for you in the future. Right? Otherwise, I hope to come back in 2 years and we check again.
And does the stricture that you dilated, does that change anything regarding your policy and your anticipation of this recurring? Is that the underlying reason why he has these stones in the left system?
This is, of course, what was first, stones or the stricture? The stricture was not so tight.
Okay.
So I don't think... Okay,
well, thank you very much for this demonstration. And since Torsten is on the schedule to speak about difficult bile duct stones, it's actually an excellent transition for him to take over. And then after that, we will shortly go back to Yamamoto, who will then continue during lunch break, and then hopefully show us early in the afternoon how he stands with that huge polyp. And while Torsten connects his laptop, thank you very much, Horst, and good luck with being the cleaning woman of this left liver lobe. And hopefully see you at lunch.
Okay, so I'm already connected. I cannot see my presentation yet, but obviously my task is very easy because everything was already shown on the screen and discussed before. And first of all, I would like to thank Stefan for inviting me for the first time to come to Zurich. It's a great honor, and so it's also my great honor now to give this lecture on difficult biliary stones. Yeah, okay, just start. Management of difficult biliary stones was my task. So when do we have to predict difficult biliary stones? So basically we can have a look at the stone itself. If we have larger stones with a diameter of more than 1.5 centimeters, according to the number of stones that we are facing, if the stones have an unusual shape, like a barrel, for example, if they are located in difficult positions, intrahepatic stones is what you have seen right now in the live demonstration, and also the cystic duct junction can be really challenging. And we have anatomical factors like strictures downstream of the stone, narrowing of the CBD, sigmoid-shaped CBD, stone impaction, short length of the distal CBD, and also acute distal angulation of the CBD. What
techniques do we have to approach these kind of stones? You have seen everything right now in the live demonstrations. We can do sphincterotomy, of course. We can do balloon sphincteroplasty. We can do a combination of both, limited sphincterotomy and then the large balloon dilatation of the papilla. We have mechanical lithotripsy, and of course we have nowadays direct cholangioscopy, more or less. It's single operator cholangioscopy during these days. I would give you some data on the efficacy. Recently, we had the publication of this meta-analysis. Usually, nowadays, we always have meta-analysis. Here, it's very helpful. Almost 2,000 procedures were included, 19 randomized controlled trials. And this is a network meta-analysis comparing the different techniques within one meta-analysis. Here you can see the different techniques are included here. And this is what we get here. So first, the different techniques were compared against only doing sphincterotomy. And as you can see here, all the techniques except mechanical lithotripsy were superior to when we are dealing with stones larger than 10 millimeters. In this meta-analysis, larger than 10 millimeters, were superior to just doing sphincterotomy. Remarkably, single operator cholangioscopy in this meta-analysis was superior to every other method of or extraction technique of these stones. And this was here shown in this network meta-analysis. And as you remember, we defined difficult stones. We can predict difficult stone extraction with stones larger than 15 millimeters. So if we have a look at only the stones larger than 15 millimeter, also the combination sphincterotomy and large balloon dilatation was superior to all the other methods. So we know single operator cholangioscopy is effective, but what can you do when you don't have it? So nowadays in Europe we are used to have it available, but there still are units that cannot use it, and also parts of the world that simply don't have it available. And here you can see the combination of sphincterotomy and large balloon dilatation is superior to all other methods. In terms of adverse events, we can see also from this meta-analysis here, it's very helpful. There's no difference significant difference in terms of adverse events between the different techniques. Mainly, we can expect post-ESCP pancreatitis, bleeding, and also cholangitis. So no significant difference. Of course, nowadays we know that we combine direct cholangioscopy because we have maybe infected stones. We irrigate a lot. We combine cholangioscopy procedures with a single-dose prophylactic antibiotic. So let's have a look at the guideline. We have a ESGE guideline on biliary stones. Here it's also, can clearly see, we have here the recommendation when we can predict difficult stone extraction, it's recommended to use sphincterotomy and a large balloon dilatation, or in the case that Horst Neuhaus did, or is still doing, after sphincterotomy has been done, you can immediately proceed to large balloon dilatation. And after that, you can consider doing cholangioscopy and do intraductal lithotripsy. So more or less, I don't have to show you this case because it's more or less the same that you have seen in the live demonstration. Again, large dilatation here of the left intrahepatic bile duct system, and we expected a blocking stone here. And again, here single operator cholangioscopy was performed. Here we can nicely identify here the impacted stone. And here we are doing direct lithotripsy. Here we use laser technique. Meanwhile, we totally change from laser technique to EHL because sometimes more and more convenient, but it's also effective. And so as you have seen that all before, you can leave the guide wire. Then after stone fragmentation, you can then either use a basket or here in this case, use a balloon to extract the fragments from the intrahepatic bile duct systems. So also in the guideline, cholangioscopy is a recommended technique to do so. However, strong recommendation, but however, still moderate quality of evidence at that stage. When do we immediately go to cholangioscopy. So it's also patient dependent. If we want to treat difficult stones, if we can predict difficult stone extraction, but also if we need a salvage therapy after complicated standard therapy, like sometimes we can still have an impacted basket, for example. Sometimes these kind of patients, if we have a coexisting downstream stricture, also indeterminate stricture, if we have to rule out malignancy or neoplasia here, we can use it for radiation-free ASAP and also for the intraoperative treatment of remnant CBD stones during cholecystectomy. In terms of efficacy of cholangioscopy, I will just show you this meta-analysis again. And here the primary endpoint was the overall stone fragmentation rate. Here it was 91%. And remarkably, a complete stone fragmentation and extraction within 1 session. So very good endpoint for patients' quality of life. It's 77%. So obviously very effective nowadays, direct cholangioscopy. And for me, we still have some open questions. Of course, if cholangioscopy nowadays should always be the last option, try everything and then switch to cholangioscopy, or can we do it as a first-line treatment? And then, so you have seen the nice talk yesterday of Horst Neuhaus discussing the different type of cholangioscopy. So nowadays, we have to admit that single-operator cholangioscopy is very convenient, and then you can decide whether to use EHL or laser technique. Just wanted to show you a quick procedure here. We have a pregnant patient. We don't want to use X-ray here, so we can here use direct cholangioscopy to do a radiation-free ESCP. You can cannulate. The passage of the guide wire was easy. Then we can aspirate some bile. I think you cannot really see it here, so we were able to aspirate bile, directly proceed to sphincterotomy, and then guide wire. The guide wire can stay in place. We advance the cholangioscope and can nicely here visualize the stone. That would be difficult to extract without radiation. And here we can then perform cholangioscopy and use this through the cholangioscope instruments to catch the stone and extract the stone through the papilla. So very helpful. And this is another case, difficult stone. So I stopped the video here. So this is a patient with altered anatomy, Roux-en-Y anatomy, and the patient presented with cholangitis. And at that stage, we found a very large stone in the intrahepatic bile duct system after bilioenteric anastomosis. And so the first procedure that we did was a power spiral assisted ESCP, and we were not able to extract the stone. So we first placed a stent, double pigtail stent here, and to save the patient and treat the cholangitis. And then we came back here, you can see with the power spiral, removed the double pigtail stent here from the orifice. Then, oh, sorry, this was too quick. So we then dilated the bilioenteric anastomosis, and here through the enteroscope, through the power spiral enteroscope. This is not the spyglass, but is still a digital video cholangioscope, 7 French in diameter, and we were able then to perform here direct cholangioscopy through the power spiral enteroscope, seeing here the large stone and performing EHL through the enteroscope in this patient with altered anatomy, and finally then we were able to fragment the stone and extract here the fragments. So in summary, difficult biliary stones, we had to have to adjust our treatment strategy. If difficult stone extraction can be predicted, cholangioscopy is effective and safe for difficult stones. The second best option is, of course, sphincterotomy and large balloon dilatation. If we have stones larger than 15 millimeters, cholangioscopy offers the options of radiation-free ESCP, and we still have the open questions if we should nowadays use cholangioscopy more often or as a first-line treatment or only after failure of standard therapy. And so after that, as Horst Neuhaus yesterday did, I would also like to invite you to come to Düsseldorf next year in February if you want to learn more about biliopancreatic endoscopy. Thank you for your attention.
So,
Thorsten, thank you very much for this very nice overview and this very nice cases, particularly the last one I like almost the best. Are there any questions from the floor? So already all are tired and hungry.
So maybe, Thorsten, you allow us to have people come up to you during the lunch break so that we can spend 2 or 3 minutes going back to Yamamoto, see where he stands with his polyp in order to return after lunch. Hiro and Remus, are you ready to receive us? And how is the polyp going?
Hi, I started from the anal side. After making mucosal incision, I'm starting the pocket creation method. So after the mucosal incision and dissection, you can see the muscle layer right side. So the submucosal tissue is on the left side. So with the cap, with the transparent ST hood, I can lift up the mucosal side and then dissect. Until I go into the submucosal space in the pocket, it's a little bit tricky. I have to be patient here. I think I should cut the tissue on this edge.
So to lose a little bit of tension, or?
Yeah, I think I have to cut this tissue. Okay, then I go into the submucosal space, like this.
So now this pocket
creating
creating method is like similar to like a tunneling technique.
Yes,
that you do.
Yes, actually I called this technique tunneling technique, tunneling method at the beginning. I changed the name. That's because by the name of the tunneling, you imagine a narrow tunneling, just going to the other side. My intention was dissection under the lesion rather than a narrow tunneling. And I use a low wattage of spray coag. This is a 0.5 spray to coagulate the blood vessel. And then aspirate the water as much as possible. The amount of the insufflation of water should be controlled properly. Otherwise, the submucosal tissue becomes very thick. Now I can hook the submucosal tissue with a knife and cut. I step on the pedal for a short duration. That is the safe way. At the beginning, I have to be very careful. Here, this is the tissue I want to cut. Hook the tissue, then let's go in.
Do you actually coagulate all the visible vessels, or do you leave, if they are untouched, you leave them and treat them at the end of the procedure, or how you approach?
I just isolate. For big blood vessels, I isolate and coagulate. For a small one, I just coagulate immediately. And a little bit of bleeding, I coagulate with tip of the knife, the ball part, and coagulate like this.
So you hardly need actually the coag rasper, or do you use it if the vessel is very large, or how do you decide?
For a large one, I use the coag rasper, but usually not very often. Oh, this part. In this case, maybe traction will be useful, but I will make a pocket to this direction. Okay, so knife is out, and change the direction to select the dissection plane right above the muscle layer, not cutting the muscle layer, and inject through the knife.
How do you make sure that your tunneling or your pocket creation doesn't go above the lesion?
I will check the length in the middle of the procedure and compare the depth of the pocket and the size of the lesion. This pocket is too narrow.
This is like a tunnel now.
Yeah, right. I don't want to make a narrow tunnel, a little bit wider, but this part is difficult to cut, so I'm now. And another thing is I usually use a slimmer, more smaller diameter scope, but it's not available, unfortunately. So this is a little bit larger one than I use usually. In Japan, small diameter therapeutic scope is now available. So for the pocket creation method, the slim scope is better. Slim scope with a slim tip cap. Because I work inside the submucosal tissue, and if there is a blood vessel, then I coagulate.
Break away, right? Hiro, we're going to leave you here,
Okay.
And we will be back probably after about 45, 50 minutes to see where you stand. Thank you very much.
Thank you.
Okay, I hope everybody will enjoy lunch. Please visit the sponsors. And we'll be back sharp here at 2 o'clock for continuation of this live session. Thank you.
Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Iluxio Ultra. Iluxio Ultra by incorporating CAD-I, our powerful AI technology. With CAD-I, Iluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Iluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Iluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice.
dear guests. Welcome back to our session 4 now after the lunch break. We have some more interesting live cases to come up, but first of all, we would like to discuss the case from tomorrow morning where Amit Maideo was struggling with some very hard stones or pancreatic duct which was difficult to enter. Please, Amit, come up to the stage and maybe you would like to explain us what happened and how to proceed and what are your expectations for the next procedure.
So it was very interesting because first of all, even cannulating inside the pancreatic duct was a bit difficult because the contrast was just not going. And this is what we see many times when the stones, whether they are radio-opaque or radiolucent, they are firmly impacted just behind the ampulla vater. Initially, I was very enthusiastic and happy because the stones were not radio-opaque. So normally when stones are not radio-opaque, we can usually get inside and we can just do a little balloon sphincteroplasty, and most of the times we can clear the duct totally. So this was an unusual situation where radiolucent stones were also hard and impacted. Now when you land in a problem like this, where my guide wire went inside but my catheter just could not go. So you just can't place any drainage catheter, you can't place any stent. So the option here is maybe ESWL, but ESWL is most of the times done with a X-ray guided ESWL. So this is not amenable for X-ray guided because it is not seen on X-ray. So we need a sono guided ESWL, if at all. But that can be a problem because sono guided ESWL sometimes is not accurate, especially when it is just juxta-ampullary, and the shock waves may get dissipated in the surrounding organ, and patient may have complications like bleeding, or sometimes even kidneys can get damaged and hematuria. So in this situation, either we wait and just don't do anything. US guided could have been an approach, but US guided in this particular case was exposing the patient to a little bit more danger, a little bit more risk, 10-20% risk of complications.
Exactly, we know, I think we are very quickly with the indication of EUS-guided pancreatic duct drainage, but we should not forget that it is a procedure with a higher complication rate.
Yes.
And I think we have to think about, I think with regard to the stones, the management would not change if you do this. It would only be if the patient had recurrent pancreatitis, but in his case, she had abdominal pain, and that's why this was the indication to treat the stones.
So my suggestion is maybe we wait for some time, allow the edema to subside, and if the guide wire again enters inside, we should go in with a very tapered, thin hurricane balloon. And if that small hurricane balloon tip can be entered inside, we slightly dilate it, keep on dilating so that the stones get pushed aside, and we create some pathway.
I think the minimum what she got is a papillotomy.
Yes, so I could see some pancreatic juice flowing, and the contrast which we had put inside was also flowing. So temporarily, I think patients should have some benefit.
Okay.
Thank you.
Thank you very much.
You.
As we had a lunch break, Professor Yamamoto was still working, and he still is, and we'd like to go to the operation theater now and take a look how far Professor Yamamoto came.
Progress now.
Okay, we're with you now.
Okay, I will show you now. The distal side, the oral side, the mucosal incision was made, and from the anal side, I created a pocket. One is from this side. Let me show you. Like this. So this is the muscle fold. So elevating the muscle fold, and then I will press down the muscle fold and continue the dissection. And from the other side, from the left side, I also created the pocket like this. And in the submucosal pocket, this is the muscle fold again. So inside the pocket, I can open the wound and then dissect. Through the flash knife, I inject the saline. And I use the dry cut in the water. And when I see the blood vessel, then I use the spray coag, effect 0.5 to coagulate the blood vessel, and then cut with a dry cut, like this.
Yeah.
And then I go again.
Wie lange braucht ihr? Okay.
Like this. And dry cut. And inject through the knife. And dissect with the dry cut. And when I see the blood vessel, then coagulate and cut. And repeat the same sequence and continue the dissection. Like this. So, dry cut and inject and dry cut again. Go in. And open the wound with the tip of the ST hood. And the tip of the knife is inserted by the dry cut. Then inject and dissect. And like this.
Stefan, I really have to say that it's amazing to see how Professor Yamamoto just prepares very precisely through this, I would say, blue lagoon, and probably the method could,
yes.
a blue lagoon method. So, which precisely he's preparing through these layers, and how it's impressive how he used just one instrument. So it's for cutting, for incising, for dissecting, and for coagulation. Is actually just one instrument to be used, and how effective actually this spray coag mode is to coagulate the vessels. So it makes it easier. So that's what I see, that you don't have to exchange
yes.
the instruments. And it makes the procedure like quite of calmer, I think.
Yes.
Yeah, thank you very much. I think we got another impression from this procedure, and it's really fantastic. And I think we will come back when you're close to finish this lesion, and we continue with the next case. Thank you very much.
Thank you.
So we're going back to, or coming to the next case. It's case number 7. It's a patient we saw just on a routine base. He's 59 years old, and he had a bariatric surgery, lost around 60 kilograms. And he suffered of reflux disease before this bariatric surgery, and now just came for a routine checkup after bariatric surgery. And we saw a lesion at the junction from the rest stomach to the esophagus, quite a tiny lesion. And the colleague took a biopsy, and there was a low-grade dysplasia in the Barrett's esophagus diagnosed. So we saw him again and did some magnifying endoscopy. It looks a bit irregular, took a biopsy again and found again low-grade dysplasia. But still we think from this lesion that it might even contain more. And from biopsy side, I'd love to have Everton Macchio here to show us a bit how it looks like and what he thinks about that lesion. Thank you for coming.
Thank you, Stefan. So here's we have one set of 4 biopsies in the Z line by 35 centimeters, 1 hour. We can see here some acanthotic squamous epithelial, and as well here the critical areas from the cylindric epithelium. In the higher magnification, we could here appreciate one of the glands showing some goblet cells that are, for us, the requirement for the diagnosis of Barrett esophagus, different from other countries. What we see here in this area, more papillary-like structures and slightly complex glands. If we go further in higher magnification, here the glands tend to be a bit more back-to-back, but you can see, even from this magnification, that the nuclei are starting getting hyperchromatic and also reach easily more in just this fragment from all 4, the surface. However, we still have some granulation tissue and some inflammation that goes in the epithelium. So the criteria for the diagnosis of dysplasia are fulfilled. What we discuss internally, that at least we keep it in the low-grade dysplasia. It's possible that the lesion would be a higher grade in a larger excision. And of note, we compare both set of biopsies, the first and the other with 3 months, and we had particularly the same setting, and this, what I show you, was the largest. Here you can even appreciate further what I just mentioned to you, that the polarity of the glands are starting to get higher, but anyway, you have quite some inflammation, granulation tissue. So we kept as Barrett esophagus with low-grade epithelial dysplasia, and of course we went through all the quality measures as internal second opinion, sets of step sections, deeper levels, and as well a P53, but these were all not informative and didn't allow us to go higher in the diagnosis.
Thank you very much. Okay, so we have some pictures from the endoscopy, we have your pictures from microscopy, and we get another impression now by Jacques Devier and Jan Borovica, who take a look at that case in the operating theater.
Yeah,
Jacques Bergman and Jan Borovica, please, show us the case.
Thank you. I had that happen before, actually. But then again, being mistaken for Jacques Devier is probably a very good compliment. So Jan is with me, the excellent team here from Hірсланден is with me, and we have been looking at this pretty small Barrett segment. Probably had to do with the title of my lecture yesterday, that they gave that to me. Maybe if you have endoscopy as well, because now you're watching us. Okay, so what we're using is a Pentax zoom scope on the new Inspira platform that Pentax has. And thanks to Pentax, actually this zoom endoscope was flown in earlier this morning. It's brand new, it's a little bit stiff like a stick. And that allows us to demonstrate to you how this 4K output of this new Inspira platform looks if you have this excellent transmission like you have there. We have a small distal attachment cap that will help us to stabilize the endoscope a little bit if we use the zoom function. And you can see that you've seen the previous images that Stefan shown you about that the lesion was looking maybe even more suspicious on those images than they are here. Using the zoom function to get a little bit closer to this small Barrett's tongue that endoscopically was already abnormal, now has been biopsied twice. So it becomes a little bit difficult to distinguish the reactive changes from the dysplastic changes. But looking at the previous images and the pathology, this does look abnormal, Jan. Do you agree?
Yeah, it looks, maybe there's some inflammation, but there's definitely a changing of the pattern, and it should be at least low grade, yeah.
So I think the combination of the prior endoscopies, the pathology, and the fact that we know that low grade, if you do an endoscopic resection, may harbor more advanced neoplasia, justifies us for doing the estimated, the planned resection here. We scan down here, this also looks abnormal, and then here becomes difficult to distinguish reactive changes from normal mucosa. But if we're going to do the resection, we likely will extend it all the way down here. I'm struggling a little bit to get this into view, but you can see that the irregularity here is not that much, of the mucosal pattern here is not that much different from these areas here that look normal.
So, Doug, this is very your conclusion also. Even in the pathology, there are only low-grade dysplasia. This is not an indication for radiofrequency ablation, etc.
No, not. First of all, this does look visible. This is a visible abnormality, so it's not completely flat. So if we would come back and this would be the tongue, and it would be completely flat, and that patient would have like a Barrett's like this all over the place, just with regular pattern mucosa, yet the pathology was confirmed to be low-grade dysplasia on multiple occasions, that might be an indication to consider to use radiofrequency ablation. But based on your prior images, and the fact that he had multiple times low grade here, that this is a visible abnormality that you should not ablate, you should resect for proper staging purposes. Just to show you, he has a gastric sleeve, so his remnant stomach here, because this is where his diaphragm is at 40 centimeters. It simply does not allow me to retroflex here. There's not enough space to retroflex this scope without running the danger that I just damage the mucosa. It's not likely that it will cause a complication, but it may start to bleed. Here you can see some of the stitches of the previous surgery. So it's going to be quite a simple procedure. We're going to mark this with electrocoagulation. So never do an endoscopic resection without placing markers. Logically, for an ESD, you need the markers to guide you during your cutting, but you also need a pre-procedural plan to do the endoscopic resection. Now, we don't necessarily need to mark it like we were doing for an ESD, just like 5 or 6 markers will be enough. But never be tempted to just think, I can find it back, because once we have the duet kit assembled, you can see that the endoscopic imaging is significantly reduced. So it's just a wise idea to place markings. So we're using the snare we're going to use for the duet resections, a hexagonal snare of 7 French, and we're just going to place a little bit less of the snare.
So,
a couple of markers that will help me to orientate later on.
Yeah. Thank you very much for the demonstration. So you showed us Barrett's with a brand new endoscope, which arrived yesterday evening from Hamburg. And now you will change the scopes for a therapeutic scope, and then that time we will switch back to Professor Yamamoto to see how far he's now with the huge rectosigmoid adenoma.
Okay.
Okay, we'd like to switch rooms to Operation Theater 10.
Like a small bow, I think. It's like, let's not argue with
Professor Yamamoto, we're back for you.
It doesn't matter.
We are back here.
Okay.
Yeah.
Okay, this is the submucosal space. So, needle out. Is it out? Okay. Then, using the dry cut and inject through the knife. and open the wound. And here is the blood vessel. So I stop here and coagulate with the spray coag. And from the other side, coagulate again, and make sure it is coagulate well. Then clear the field, go in, and dissect with a dry cut, slowly. In this way, I can prevent the bleeding, I hope. Coagulate again. Then cut. And coagulate. Then cut. Inject through the knife and cut with the dry cut. Okay. Again, inject through the knife and cut with a dry cut. Inject through the knife, dry cut. And coagulate again. Inject, dry cut.
Okay, Professor Yamamoto, thank you very much. It's
Okay.
really, really impressive, and we come back later on. Thank you. We're going back to Operation Theater number 9 with Jacques Bergmann and take a look how the procedure will continue. Thank you.
Okay, the Stefan twins, we're back. So we assembled the duet kit on this therapeutic olymposcope. And you can see that these black rubber bands, they actually take away quite some light.
Okay.
And we're going to
We're waiting for the endoscopic picture. Thank you. Okay, we're back.
So knowing that I'm not going to do like 6 bands for the resection, it makes sense to release some of these bands. And logically, you can do this inside the patient, but I'd prefer to do it outside because sometimes the wires need to be slightly repositioned so that they're not in the way.
So what is the advantage of this move? Is it to have a brighter view or better
Well,
view?
you can see that now there's much more light because the light would be absorbed by the black bands, and then my glove would be a little bit more darker, would be like more or less in a tunnel. So basically, this just improves the imaging. So in the two-way mode, so that I don't accidentally release a rubber band on the uvula. Would make for a good image, though. Carefully moving in. And the foot pedal for the water jet, sorry for that. Yeah, perfect. So it's all about preparation. So And by the way, we actually found out after we sedated him a little bit less and could inflate his gastric remnant that he had a Roux-en-Y gastric bypass. But you start out by emptying the stomach. So if the stomach is, let's say you clean and there's a lot of water, etc., in the stomach, and then you do your resection and then it bleeds, then you have to be prepared for any complications. So the stomach has to be empty, and you need the delineations. And then this is a straight cap, so I can actually approach this at 12 o'clock or at 6 o'clock. That, at this case, doesn't really matter for the suction. And then you just apply a test suction, just to see what happens if you would suck the lesion in. And if I press down like this, and now open up the cap to 12, the tissue at the lower end will open up. So this will likely come in as a big chunk. So if we are here, I'm stabilizing the scope for the upper marking so that I'm sure that the upper marking will come in. So applying suction slowly, opening up the cap to 6 o'clock, continuous suction, and now so the tissue will enter at 6 o'clock. Maintaining suction, go to the firing position, and release the band. Release the suction, and just pull back. Squirt of water. And now we can advance the snare. You can still see that this release of this band, again, still the position of the wires they are now slightly in the way. This is simply the way how this is manufactured. The wires are not really in a straight position, so it can change between one resection and the other. Try to stay away from the rubber band, so not pushing against it. Now this may be a good example, actually rotating the scope to the 6 o'clock position so that there is more room to see and to open up the snare above the lesion. Yeah, open up the snare, completely open. And then try to rotate the snare, push down, and then just push the snare parallel to the esophageal wall so that it will close underneath the rubber band. So close, 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 completely closed. So now I want to go back to the 12 o'clock position because that's just a more relaxed and comfortable position to do the resection. Okay, so we're going to transfer the snare to me just for practicing. So if you zoom into the hands, actually we did not practice that. Zoom into the hands here. So I want you to close the snare.
From camera side, please zoom in.
Just to see how the nurse should transfer the snare. So I want her to put the thumb up like this. Hold up, take away your hand. So now you can transfer the snare. So now you do that. Put your hand underneath, yeah. This hand underneath, and thumb up, thumb up, thumb up, thumb up, so that it does. So hold it again, practice here, and hold with this finger that it cannot open up. So then you can transfer the snare to me. I should have practiced that before we did this one, I'm sorry. Excuse me for that. So there's all kinds of way of doing this resection, but it's a 7 French snare, and we're pretty used to using force coagulation for this. So I will squeeze hard and just burn with force coagulation effect 4, just squeeze my way through.
So you are not afraid that?
Well, in this case, we probably take the specimen and go out because of the Roux-en-Y. Don't want this to go down his bypass. But generally, we don't need to do that. We just leave the specimens in the stomach and then collect them afterwards. It's actually the first time that I actually had to do this because of the Roux-en-Y setting. Don't want to lose the specimen. It's the same with an amplectomy. You first grab the specimen and then you come back to see what you've done. So logically we can inspect for bleeding, but the main question is are there any markers left? Because at least not here on here's a marker, but that would be okay given where it was positioned. The proximal one should be gone because that's where I started the suction. And distally here. So I would say that there is actually no need to do an additional resection. because, well, there is a marker here. So for safety reasons, we'll just take this small to grab this lower marker. Controlled suction, just test the suction. Before I do this, empty the stomach first. So that will not be in the way if I get into a bleeding. Then to do a test suction to see what happens. And then if I'm pretty much okay, not going for a full-blown resection here, because we only need a small piece. You don't necessarily need to remove the snare in between these resections. So generally we leave it in. We had to remove the endoscope and then it made sense to have the snare removed, but usually you just leave the snare in. The compliance of the tissue is the dependent factor on how much you get into the cap, not the suction power reduced by the snare. So if you open up the snare here, it's completely open, and then I will pull back, stay close to the specimen. So now we'll demonstrate the 12 o'clock position. Basically the same thing. You push yourself underneath, parallel to this, and now close the snare completely. The band doesn't show up because it's whitish. There's a white rubber band here, indicating that this is band number 5, if I'm correct. Okay, now we practice the transfer of the snare. Are you ready for the challenge? I think so. Okay, then hand the snare to me. So take this hand. Push up this. Keep it closed. Keep it closed. In this hand needs to fix the snare. Now, now like this, Your thumb up. That's perfect. Good. And then you can transfer the snare easily to me. Yeah, and then let go.
Thumb up.
So that should be basically it. Again, run for the specimen. Take a picture so that we don't have to come back. I think this concludes the treatment, guys. Any questions here at this point?
Yeah, my question would be, you know, in the cardia you have still some vessels, and if there is a rebleeding, usually in my cases it was at the cardia side. So would you try to close it a little at the cardia, or does it make a difference?
No. The only thing that we would likely do if this is really low grade and we think he needs an additional RFA of these tongues, given the fact that he has, we would actually do the RFA in the same session, because you can nicely position your focal RFA catheter next to his and then do a circumferential ablation in the same session. That would save him a procedure, but that was not scheduled nor discussed with him, so we will not do that today.
But you don't do anything else to reassure that there is no bleeding after mucosectomy?
The bleeding risk for delayed bleeding after this is 0.8%, and actually 80% of those are on patients that have anticoagulant therapy.
That's sometimes
so he doesn't have that. So his chances are less than 1 in 1,000 to have a bleed from this, based on a series of 3,500 procedures in 25 centers.
So if he had anticoagulant, you would close the mucosectomy?
No.
Not.
I would then just insist that he takes his PPI properly. We will restart his anticoagulant therapy probably the day after the procedure, and then accept a small risk for bleeding that we generally treat conservatively. So if he comes in, he would come in a week with a bleeding. We would not necessarily go in and rush in there and treat, because generally these are not severe bleedings. In those 3,500 procedures with the 0.8% bleedings, none of them was considered severe. None of them ended up on the ICU. So this is a really very, very safe procedure, even in patients that need anticoagulant therapy 1 or 2 days after the procedure.
So there is also no need for a second look, right?
No. No, we would.
At least in this case.
No, generally we would discharge patients with procedures like this. We keep on for observation for 1.5 hours and then discharge back home. We don't admit them.
Okay.
Okay. Thank you very much for this demonstration.
Thank you.
Okay, we continue with the next case.
Sorry for that.
Thank you. So Stefan, next case is number 8.
Number 8, we are waiting for the slides. This is a 77-year-old male, and he got in 2020, 21, and 22 an ERCP because of choledocholithiasis. And then cholecystectomy was performed, and the patient developed a papillary adenoma. The problem is that the papillary adenoma is near to a juxtapapillary diverticulum. And this is here the endoscopic assessment. So you may nicely appreciate the diverticulum on the right side, and then we have a status after papillotomy, and you see here this adenomatous tissue. So when we have a case like this, the biopsy is very important, but the biopsy has to be reconfirmed by a GI endoscopist, because from the French study from Napoleon, from a prospective trial, it had turned out that in almost 15% of the cases after the papillectomy, it turned out that it was no adenoma. And that's why I beg now Everton Macchio to demonstrate us the histology.
So here is, as Stefan said, was a biopsy that was performed in another institution. We got is also a second opinion. Here we can nicely see small bowel mucosa with this finger-like villi, and here at the left-hand side a more cellular proliferation, more bluish. In the higher magnification, here just the normal for sake of comparison. And the proliferation made up from small tubuli that also reach the surface. And if we go in the higher magnification, we have clearly hypercellular tubules, and also, but no polarity changes. There is some film mitosis, but it's still in a low-grade setting. So we confirmed the external diagnosis of intestinal type adenoma with low-grade dysplasia.
Thank you very much. So the diagnosis is confirmed. It is a papillary adenoma. And when we perform papillectomy, the second workup before is an MRCP, because theoretically, patient could have a pancreas divisum, and then a cannulation of the pancreatic duct is not necessary. And I beg now Mishka Patak to demonstrate us the MRCP.
So what we see again is the transversal T2. We see this is the bile duct, the main bile duct. This is the pancreatic duct, and when we look, we see this is a flow void. This is not a stone, but this is the pancreatic duct, and you see a dilatation of the pancreatic duct, and there's some signal void in it, and in comparison, you see this one is a flow void because at the lower side where the patient lies, there's still a bright signal. This means it's not a stone because the stone goes down. And there you don't have a bright signal, and that means there could be a stone. So we have an intraductal, or we thought it could be an intraductal stone, no pancreas divisum.
Okay, so the plan is now to perform endoscopic papillectomy. However, this is also not an easy case for Professor Maideo, because first we have the problem of the diverticulum, and second, an endoscopic papillotomy was performed before. So we will see how he will manage this procedure. Amit, are you there?
There. So thank you, Stefan, for this more challenging and probably more easy case.
Wrong room. We have to go to room number 1.
Hold on. You want me to push it, hold it on?
Sorry,
Can you hear me?
Just a second, Amit.
Yeah.
No, just hold it. Don't hold it. Just hold it.
Okay. Wow, I don't think I can reach that.
Yeah, perfect. We're back with you and with the endoscopy picture, please.
Can you hear me?
Yes.
Yes.
Okay, so can you see here the situation? I'm inside the second part of the duodenum, and here you can see this ampullary adenoma, which is just on the edge of a diverticulum. Now, there are various techniques of doing an ampulectomy, and I usually follow a method by which I first try to cannulate the pancreatic duct with a guide wire, and I inject a little bit of methylene blue in the pancreatic duct, so that after we have done the ampulectomy, sometimes it becomes easier to identify the pancreatic duct orifice. But if you have secretin, then this is not required. I can directly proceed by holding it with a snare and see whether I can catch it. Because if you have secretin, then we don't need that methylene blue, because in case you can't identify the pancreatic duct, then we can just give some secretin and we will see the spurt of pancreatic juice coming out. So now first let me see in which best way I can just support it from down. Thank you. Once again, I'm supported and assisted here by one of the best endosonologists of the world, Dr. Sham from Orlando. Yeah. So I'm going to use the captivator snare. Yeah.
So you don't want to do a pancreatogram before you...
No. It is not required to do a pancreaticogram because this patient has already got an MRCP and it is not showing an abnormal pancreaticogram. So what I'm going to do is go above the lesion over here. Okay, can you open the snare now? Open. Okay, gently open. And now so what I'm going to do is pull it back a bit. Pull it back again, close it. Close the snare. Oops, scope has come out. Okay, scope has come out. So I'm going to go in again. Yeah. So trying to do it in a semi-long loop position to bring the position in a better way. Okay. You won't go. Keep it there. Open the snare now. Open. Yeah. And now as she's opening the snare, open more. Wait. Open the snare fully. When I tell you, close it now. Close it. Now, when I tell you to open, gently open it fully. Yeah. Open now. Open. Fully open. Full open. Full open. Oh. Open. Full open. Full open. Oh. It's not opening.
It doesn't look like it.
Yeah. Now you can open. Open fully. Is this a 15 mm? Yeah. That's a little better. Now I push the scope in slightly. Enough. Very gently.
Push the snare out.
Very gently. Yeah. Now I'm going to turn the scope here and gently close the snare now.
A challenging position.
Yes. Gently close the snare. Close. Okay.
I don't think we have the full...
We haven't caught it fully. Open it now. Open it again. Open full. Yeah. Now possibly better. Okay, gently close it. Gentle closing. Still not.
Think
Open it.
Open it again.
Open it.
It's a very challenging case.
He's going to follow. Careful.
It's got caught inside. Okay, leave it. Leave it. Yeah, it's come out now. Let's try to go from below upwards.
When I did the pre-assessment, I placed the snare also, and I sucked.
Okay, close the snare now.
Bit.
Okay, now open it over here. Open. Full open. So now gently push the scope in, push the scope in, push the scope in.
Floppy papilla just moves out.
If I continue this performance in this way, I'm quite sure Stefan is never going to invite me again for this meeting. Right, Stefan?
No.
Sometimes people learn from how not to do things, Amit, I think.
Okay, close the snare. Close it.
I mean, you think there's a different kind of a snare will be helpful?
Yeah, let's try.
Oval snare or something?
Let's try this one first.
Okay.
The position is very, very abnormal.
big.
Hold it like this.
Okay.
Okay, open now. Open. Anna? Yeah, open. Open full.
Fully open.
Full open.
Yeah.
Okay, you want to use a bigger snare then?
I think
we
we're making some progress here, I think.
So I need to suck the polyp now.
Suck
it a bit.
Suck
it a bit. Gently close the snare.
No,
but it is not on that side. Okay, now you see. Gently close. Gently close. Looks like I've caught something.
Yeah, but not the base.
What do you think, Stefan? Some of the polyp is still left behind, right?
Yeah. There is a polyp.
Yes, but I think 80% you have, and then you can see from there.
We should cut it here?
I think so.
Yes, I think so.
No, that's a different story.
Can you open it slightly? Yeah, slightly. Open more. Let me see if I can go.
For some reason, the snare is not...
not opening, no?
I mean, shouldn't be too this...
No, because...
I don't understand.
Now it is a little
maybe
better. Now you close it.
Okay.
Oh, scope has come out. Scope came back. Okay, open again. One more try. Open again. I want to go well beyond it. And now gently suck it. Keep the scope pushed inside a bit.
Okay.
Yeah. Gently close it. Little bit better.
Okay.
So I'm going to cut it and see now. Oh,
it came
already
through.
Cut?
Yeah. It's like almost like a cold snare.
That was
the
quick.
thing. All right. We got a residual tissue. Maybe grab the polyp before it runs out.
Yep. Open it now. Open the snare.
I think you should just come out with it. All right.
Okay, catch it.
Closer. Yeah.
So we go and park it in the stomach. Open it. Close it now. Close it. Okay. I'll take it out. Take it out.
So
at least we send it for histopath.
As I mentioned, we not only have the diverticulum, but also the status after endoscopic papillotomy. And that makes it for sure difficult because in the upper part you have scar in this case.
Yeah, first let us see whether the remaining polyp, can you pull it out? Can you take the head up? Yeah.
Okay.
You have any other snare? This is which one? Captivator? Same one or new one?
Same one, but new one. Here's one with them.
Okay.
Is it okay, or would you like to try it?
You want to try the Olympus one, the snare master or whichever?
Snare Master Olympus?
15, yeah?
Ah, okay.
Little bit is still there.
Yeah. Yeah, that's still polyp.
Okay, now we'll try to catch it with a different type of a snare. Let's see.
So you use now the 1.5 centimeter snare or the 10 millimeter? Did you use now the 10 or 15? Ahmed, can you hear me?
Yep.
Have you used now the 15 or the 10 millimeter?
I use the 15 mm.
Uh-huh.
Too big.
Maybe now the 10 millimeter would fit.
I use the 15 millimeter captivator snare. First time. Now let's try with another one. Okay, the scope is gone. Okay, let's try now. Open here. Ooh. Open here. No, wait. Ooh. Moves like crazy. Yeah. I'll keep it open fully. Gently push it inside. Okay. Slowly close the snare. Slowly close. No. Slipping out. Maybe you can try a smaller snare.
I think so.
Smaller size. Yeah, we can try that. Okay. Thank you. Okay, can you open here? Open. Okay, gently close it.
Position.
Got it? It's cutting too fast. This is like a piecemeal resection.
I think so. Yeah.
What?
Trap.
No, I'll just see what we have removed.
That looks good.
Yeah, so we just want to check it out. What is left behind. So what we'll do is, at the place of the sphincterotomy, we'll go inside the bile duct.
So, Ahmed, do you think you should grab a wider margin around the papilla, maybe?
Yeah. But you know, my worry is
because the tick is way on the
okay, we'll
3
try
o'clock.
that.
So I would just take out the whole because there are some changes if you look at it carefully.
Below, right?
Yeah. So I would
Okay,
take out the whole.
snare here?
Yeah,
Open the
the
snare
whole
here.
thing. There you go.
Open full?
Full.
It's full? Okay. See what is happening? The snare is slipping. Okay, then you give me a wider snare again. Open full.
Fully
It's full open.
Okay, all right. I think you're making some progress, although the direction is a little
And scope is
funny.
falling out. Scope is falling out. Okay, what I'll do is now you give me a larger, bigger snare.
Okay, Amit, we will let you do. We will come back later.
Yep.
And then we will see from there. Dear colleagues, for the second year running, we are giving out the Young Investigator Award, and we try in our own way to support and to promote the best of the best up-and-coming talents in endoscopy from highly rated centers of endoscopy in the world.
This year we have 4 very talented endoscopists from Germany, Japan, the Netherlands and Poland to present their cases. And you, my dear colleagues, are able to choose who's your winner. And that is possible via our webpage or via the EndoSwiss app, which you can download from the App Store or from Google Play Store. Or we also have the QR code here, which you can scan right now. And we'd love you to do so in between the next 2 hours to vote for the talents. And coming to the cases, we'd like Mayao Tanabe to present her first case. Mayao Tanabe is an associate professor for the Digestive Disease Center in the Showa University of Koto Toyojoi Hospital. She comes from the same hospital as Haruo Inoue and is a rising star in endoscopy who will be talking about an anti-reflux therapy, which is called ARMA or RMP. And what that is, you will explain us now.
Yes.
Thank you very much.
Thank you very much. So, can you put my slides on? Okay, thank you very much for a kind introduction, Professor Stefan. Good afternoon, ladies and gentlemen. Today, I'm excited to discuss a breakthrough in the field of GERD treatment, anti-reflux endoscopic therapy. Despite acid suppression therapy, a significant percentage of patients continue to experience persistent GERD symptoms. While laparoscopic anti-reflux surgery has been the gold standard for PPI refractory GERD, there is a growing need for less invasive treatment options. In 2003, we experienced a groundbreaking case that demonstrated how mucosal resection or mucosectomy induces an anti-reflux effect. Based on this remarkable case, we named this procedure anti-reflux mucosectomy, ARMS. During our pursuit of less invasive procedures, we discovered that ablation techniques could also induce scar formation, providing the same anti-reflux effect. Ablation is a relatively straightforward procedure that has proven effective. This video shows the typical course after ARMA. As you can see, the wide open cardia significantly shrinks after the ablation, and the resulting scar folds centralized in the lesser curvature. This is the mechanism behind ARMS and ARMA. Several systematic reviews and meta-analyses have already confirmed that ARMS and ARMA is a safe and effective treatment for GERD. However, we encountered 2 key challenges: the approximately 1 month time required for complete scar formation, and a 5% risk of bleeding after the procedure. Today, I'm excited to present our solution, anti-reflux mucoplasty RMP. RMP is our newly developed procedure that combines mucosectomy with immediate mucosal defect closure to address these challenges. The goal is to ensure effective results, reduce post-procedure adverse events, and achieve faster symptom relief. Let me walk you through the procedure. First, we perform a standard cap EMR after submucosal injection and pre-looping of the snare inside the cap. Typically, 2 to 3 sessions of CAP EMR resection are performed to ensure ideal size of artificial ulcer. Once the resection is complete, immediate hemostasis is ensured. Now the crucial step is to close the defect. How do we close this? We utilize a novel technique called the Loop 11 technique, which enables continuous traction with the thread during the closure using line-assisted clip closure. First, clipping is performed on the anal side of the defect under the forward view position. The subsequent clip is deployed adjacent to the first clip, and the following clip was deployed on the contralateral side. In this manner, the mucosa and submucosa were grasped and closed alternately. The submucosa at the base of the ulcer is clipped in a zigzag manner, while the thread is gently pulled for optimal closure. Once the closure is complete, the support thread is removed from the loop. And the final clip is deployed to anchor the mucosa on the oral side, ensuring the sutures remain secure. The result is an efficient closure of the cardiac opening. As you can see from these images, RMP achieves a remarkable approximation of the mucosal defect, effectively addressing GERD. I'm excited to introduce our new project, EARTH, which stands for Endoscopic Anti-Reflux Therapy, establishing endoscopic procedures for GERD. This initiative aims to further advance our understanding and application of endoscopic treatment for GERD. In summary, ARMS, ARMA, and the innovative RMP procedure represent less invasive, highly effective, and cost-effective treatment options for GERD patients. By continuously exploring new techniques, we strive to improve patient outcomes and quality of life. Before I conclude, I'm delighted to announce that we have recently launched our YouTube channel. It features a wealth of procedural videos and lectures by renowned endoscopists, providing valuable insights and educational resources. Thank you all for your kind attention and for being a part of this important journey towards revolutionizing GERD treatment. Thank you very much. Dankeschön.
Thank you, Mario, for this very interesting presentation. So it is somehow a procedure between PPI treatment and between laparoscopic fundoplication. Two short answers on two questions. So in how many % of the patients you could reduce PPI? And second, what is your longest follow-up?
Thank you very much. Actually, for now, we have conducted more than 20 cases of RMP, and 70% of patients have already discontinued PPIs. And I think the first one was half a year ago, so it's been only a half a year, but we have to follow up for further results.
Thank you very much.
Thank you
We are
very
looking
much.
for more results. Thank you.
Thank you very much.
And now we are coming to the second presenter, Lisanne Patinama. She's a research fellow and PhD candidate from Amsterdam Medical Center. She is one of the rising stars from Jack Bergman's group, and she will talk about preemptive VAC stent placement to prevent anastomotic leakage after esophagectomy.
Yes, waiting for the slides. Thank you for the kind introduction. So my name is Lisanne Patinama. I am a research fellow at the Amsterdam University Medical Centers. And first I would like to thank the organizers of EndoSwiss for the nomination. And I would like to tell you about our plans for the PREVENT feasibility study. So during an Ivor-Lewis esophagectomy, a gastric conduit is created with an intrathoracic anastomosis. And leakage of this anastomosis is a severe complication which is associated with increased morbidity, mortality, and of course, also prolonged ICU and hospital stay. And the incidence of anastomotic leakage after an Ivor-Lewis esophagectomy is 10 to 15%, but even described higher in literature. At our center, since 2018, the primary treatment for these patients is endoscopic vacuum therapy using a sponge. And during the implementation phase of endoscopic vacuum therapy, we conducted a case series of patients with anastomotic leakage treated with such a vacuum sponge. And we saw a success rate of 74% with a relatively low adverse event rate. And recently, the VAC stent has been introduced as a new treatment for these patients. And the VAC stent is a fully covered nitinol stent with a polyurethane sponge attached to its outer surface. And for this treatment, the VAC stent is endoscopically placed over the defect and attached to a vacuum pump, which then generates a negative pressure around the stent, causing closure of the defect, drainage of fluids, and stimulation of perfusion and wound healing. And additionally, the vacuum prevents the stent from dislocating, and the stent allows for oral intake and seals off the defect. So at our center, we conducted a case series with the first patients treated with the VAC stent, and we included 23 patients, of whom most had an anastomotic leak after an Ivor-Lewis esophagectomy. And we saw a success rate of 91% without any adverse events. So this VAC stent works very well. But what if we go back and could prevent anastomotic leakage from occurring in the first place? So we hypothesize that placement of a VAC stent right after an Ivor-Lewis esophagectomy reduces the risk of anastomotic leakage. And during this preemptive treatment, the patient can have intake, so the enhanced recovery after surgery protocol is maintained. Furthermore, this VAC stent stimulates healing of the anastomosis by eliminating contact with gastric and bowel fluids and stimulating perfusion. So with this, prevention of anastomotic leakage may be possible, and with that, also the reduction of the morbidity and mortality that goes along with it. And after 5 to 7 days, the VAC stent can then be removed. So what do we know about preemptive endoscopic vacuum therapy? Miller et al. Have looked at prophylactic vacuum sponge placement after an Ivor-Lewis esophagectomy in high-risk patients. So they looked at 67 patients and found a low AL rate of 7.5% without 30-day mortality. And this was in high-risk patients. They are also currently conducting a randomized controlled trial on the same topic. But as we know that with the VAC stent, oral intake remains possible and the success rates are possibly higher, with this prevent feasibility study, we will be looking at prophylactic placement of a VAC stent after Ivor-Lewis surgery in 20 patients. And with these results, we can then set up a randomized controlled trial on the same topic. And with these studies, we hope to gain insight in the potential of preemptive endoscopic vacuum therapy after esophagectomy to reduce the rate of anastomotic leakage. So, in conclusion, prevention of anastomotic leakage after an esophagectomy could reduce severe morbidity, and the VAC stent preemptively could reduce this risk of anastomotic leakage. Furthermore, more research is ongoing to assess the best indications and techniques for endoscopic vacuum therapy, both in a preemptive way, but also for treatment of defects. So currently we are setting up a multi-center endoscopic vacuum therapy registry or database, first in the Netherlands, and we are also going to expand internationally. Furthermore, we have recently launched our new website, which is evt-academy.com, where we share our experiences on endoscopic vacuum therapy in the upper gastrointestinal tract, including presentations, protocols, videos, and an expert panel for any questions or cases you might have. So with that, I would like to thank you for your attention, and if there is time, I would love to take questions.
Thank you. Thank you, Lisanne. I think this is a very important study for the clinical practice every day. I have one short question. Do you place the stent intraoperatively or after the surgery?
No, it's really in the operating room. Yeah, so right after the surgery.
And after how many days you remove the stent first time?
We will remove it after 5 to 7 days. It's also due to maybe when it's possible in the schedule of the endoscopy room.
Okay, thank you very much.
Thank you.
Next talent coming up is Thomas Lux. He's a multi-awarded endoscopist from the University Hospital of Würzburg, who will be talking about AI-assisted documentation of colonoscopy, building a community-based development and evaluation pipeline. Thank you for coming, Thomas.
Yeah, thank you and good afternoon. Thank you for the nice introduction and also for the opportunity to present my work. So basically, I want to show you how we think the future of AI in endoscopy might look like, essentially building sustainable structures. So if we look at polyp detection, this is the main thing of AI in colonoscopy right now, and many studies have shown AI is able to increase adenoma detection rate and therefore should mostly benefit screening colonoscopies. But if we look into the studies a bit more in detail, we find that less than 30% of the patients in all of those studies, in most of them even less patients, were screening patients, which makes measuring ADR as primary outcome a bit shady, and we thought that maybe there is more to explore there. So we jumped the hype train. We also built on polyp detection AI, did a multi-center evaluation study, which will be published soon, hopefully. And without spoiling too much, we can definitely confirm Gartner's cycle of hype. We went in there on the peak of inflated expectations, and our results are not as beneficial as we hoped. And now we are looking into how can we address this and use AI efficiently in endoscopy. So first of all, what is an obvious limitation of polyp detection AI? So AI can analyze videos, but AI doesn't make the videos. And in a nice clinical trial from Switzerland, published a few years ago, they monitored withdrawal time and adenoma detection rate of endoscopists for 3 months. And then they did a miraculous intervention and monitored for 3 more months. Then they compared. And we saw an increase of adenoma detection rate of 15%. The miraculous intervention was telling the endoscopists that their withdrawal time is timed. So maybe we should also focus on the endoscopist's part in there and the real-world working conditions. So within clinical trials, also yesterday we heard there's the drive to overperform, and especially if you're told that you're watched, then this helps to do your work good. But also this makes it impossible for an AI to detect something which isn't visualized on a video. So in our opinion, requirements for successful AI integration should be that it's easy to contribute data. And not just academics, but everyone should be able to contribute data so we can tackle and address the problem of generalizability. The next thing, standardized data. All of these studies use different classifications. They use different size clusters. For example, addressing 5 or 10 millimeter polyps to a size category is quite inhomogeneous in the literature. So this makes problems. We need to focus on standardized data. And also to get the people to actually contribute, we should give them an immediate benefit in their working days. So a brief introduction of our structure, of our pipeline would be, we begin with data acquisition. We use a setup which is commercially available for around 800 euros and supports all endoscopy processors I know of. And then we need to go forward and care about how do we process data, because this is the most important part. If you want to contribute data, you need to merge the files, reports, and videos, and also you need to anonymize it. For this, we developed a tool which identifies sensitive information like examination date, name, birth date, faces, and remove it from videos automatically. We also do the same thing for endoscopy reports, and we not only remove the information, but before removing it, we use it to merge the files together, which is currently mostly a tedious task for students mainly. And this isn't an option if you want to have centers contribute their data, because they don't have the resources for that. So the acquisition and data acquisition pipeline would be recording, then semi-automated or mostly automated processing of the data, and then uploading to a research database. The database needs to have a structure like we told before. For this, the example of polyps at least, we screened the current guidelines, which information does have clinical impact, which is of consequence, and which is required or recommended for reporting. This is just like not everything for a polyp, but most of it. And as you see, it's like a directed graph. The specifics aren't important, but it's complicated because depending on the size of a polyp, the features which should be or which are recommended to describe differ. So it's completely unreasonable to have a human understand all this and check all this. So we want to have a graph which represents these structures, and then we need to populate the database, which is also currently a very tedious part. And this is where AI comes in, because I don't think that we should go to the tip of an endoscopist's performance and do like polyp detection and characterization before laying the foundation. So we are building an AI toolbox which helps us extract basic information from endoscopy videos, which would be something like automated withdrawal time measurement, which is automated detection of interventions, of intervention times, and also extracting interesting images. So images with polyps on there, images where NBI is active, images of the cecum, stuff like this. And also another tool which was recently published in endoscopy is automated size estimation of polyps, which is also an important feature. And the more information we can get in a structured manner automatically, the better. So to summarize the process, we have a pipeline for like open access data acquisition with a low threshold of engagement. We have a way to, which will be improved, but we are building more and more assets which can extract information automatically, and we parse it into a pipeline. And with that, we want to achieve a barrier-free data contribution to really get all data, even if it's new methods, if it's new devices which get published and stuff like this. And also, we want to make this accessible for everyone. And then, depending on what your purpose is, if you're a researcher, that's nice, you can use that for research. If you are a physician and like want to be a good endoscopist, you can use these images, which are available to many people, for training. And also, we can see in which cases, on which images, the experts have different opinions to see if we can work on that. And we will try this in the multi-center trial in Germany first, and are happy to introduce this technique and these methods also elsewhere if the baseline is set. And yeah, thank you for your attention. And if you're like interested in updates, my email address is down there. Just let me know, and then as soon as we are ready to make the next step, I will contact you. Thank you.
Thank you very much. Just one question. As I understood, it's so far just post-processing?
There is the possibility to do it in real time, but this is real time during the intervention has the problem that you need high computing power, which makes it unfeasible, at least currently, to do it in practice. But if you record it on a hard drive and take the recording to post-processing, you can have the results within 20 minutes.
Okay. Thank you very much.
Thank you.
We are coming now to the next talent. It is my honor to introduce Jakub Kryszkowiak. He's an upcoming gastroenterologist from the famous Marie Sklodowska-Curie National Research Institute in Warsaw. And he's coming from the famous group which published a lot of articles on colonoscopy from Michael Kaminski's group, and he will talk about short and long-term outcomes of endoscopic removal of large colorectal polyps by morphology. Please, Jakub.
Hello everyone, thank you for the nomination, and it's a great pleasure for me to present today the results of our study on short and long-term outcomes of endoscopic removal of large rectal and colonic polyps. Although polypectomy is one of the most common procedures in gastroenterology, there are still some significant knowledge gaps in the field of large colorectal polyp resection, such as short-term effectiveness by lesion, location, rectum versus colon, in different morphologies, like pedunculated polyps, sessile lesions, and laterally spreading lesions. The second gap, which is significant in clinical practice, is long-term risk of recurrence and the risk of colorectal cancer in the future after resection of a large colorectal lesion. So the aim of our study was to address these gaps. And this is what we did. We assessed all the lesions larger than 20 millimeters detected during colonoscopies performed in our center between 2000 and 2015. After exclusion of not attempted resections, IBD patients, and missing data, in the final analysis we included 1,651 endoscopically resected lesions. And in the follow-up, we assessed technical success, complications, histology, recurrence, and the risk of colorectal cancer in the future after resection of a large colorectal polyp. Just to give you an idea of the analyzed population, here are some baseline results. The median age was 64. Years old. There were more men than women in the cohort. 26% of the lesions were located in the rectum, and over 40% of the lesions were more than 30 millimeters in size. And the morphology, around 1/3 of the lesions were pedunculated, 44% were laterally spreading lesions, and 25% only were sessile lesions. We followed up patients in the hospital records and the National Cancer Registry for median follow-up time, which was around 8 years. And this is what we found. The technical success was high. But there was a significant difference between rectum and colon, which was driven mainly by a high rate of success of resection of laterally spreading lesions in the colon. The same trend was seen in another A point, which was bleeding. And again, it was driven mainly by high bleeding incidence for rectal laterally spreading lesions, which was over 15% in the rectum versus only 6% in the colon. Then we looked at the advanced histology, the high-grade dysplasia, and the PT1 cancer. There was a significant difference between colon and rectum in both of them, in high-grade dysplasia and PT1 cancer. And again, it was caused mainly by the difference in laterally spreading lesions between colon and rectum. And in the, as far as the PT1 cancer is concerned, the difference between colon and rectum for LSLs was as high as 9.3% in the rectum and only 1.6% in the colon. So a really, really high difference. Then in long-term results, we found that the risk of recurrence was three times higher in the rectum than in colon overall. And again, the highest difference, the most evident difference, was observed for laterally spreading lesions. It was also confirmed in multivariate analysis. As you can see, the hazard ratio on the right. And for the long-term colorectal cancer risk in the future, after resection of a large colorectal lesion, there was also a difference, the same trend, but in this case, the results didn't reach the statistical significance. But the result which drew our attention was that 70% of the lesions of the colorectal cancers were found in the same location as the large polyp resected in the past. So it was, it was 70%, a high percentage of the colorectal cancers. And in conclusion, the risk of technical failure, of bleeding, of high-grade dysplasia and PT1 cancer, and for recurrence, was much higher in the rectum than in colon. The same trend was seen in the risk of developing colorectal cancer in the future after resecting a large colorectal polyp, and it was driven mainly by the differences in the laterally spreading lesions. It should lower our threshold for en bloc resection, especially in the rectum. Thank you very much.
Thank you very much, Jakob, for this very interesting presentation, these data. How can we put this now into the clinical practice? I think the problem is sometimes that when we have larger polyps, often when you see only the pictures, there's an underestimation, and then patient comes and you are prepared for an EMR, but not for an ESD. How you deal in Warsaw with this problem? Do you scope every patient up front again before you do the resection, or how's your strategy?
Well, yes, we try to check it by ourselves, but if it's possible, every time we try to switch, and if we consider that en bloc resection is the right method, then we try to do that.
So finally, in every of such procedures, you are prepared for EMR and ESD as well?
Well, we try to be, we try to be ready for everything. So if it's possible, we try to switch.
Thank you very much.
Thank you.
Thank you very much. And once again, thanks to all 4 participants for excellent work and excellent presentations. And to you here in the audience and on the screen at home or wherever, once again, please vote for the candidates. You have the chance now to do it via our website or via the EndoSwiss app. And in the EndoSwiss app, you can go straight to the voting part, or also on the website to the voting part, and you can also get linked to it via the email we have sent you. And of course, if you don't have the app yet, please download it at the Google Play Store or the App Store, and you have around 2 hours time to vote for the candidates. So thank you very much, and we'd like to present our last case for this session, which is a very interesting case. And coming to the next slide, please. It's a 70-year-old lady who suddenly started to bleed per anal, and she found some dark red blood clots in her stool, and then afterwards it turned black, and she had a drop of hemoglobin down to 8.2. And for that reason, she got a gastro and colonoscopy and an abdominal ultrasound, which revealed no bleeding site. Besides, she had a diverticulosis, which was known before, but it showed no bleeding in that area. From the history, the only suspicious thing is that she took some NSAIDs with diclofenac 75 milligrams for 1 week because of a rheumatoid arthritis. But that was already 5 weeks ago, and the bleeding appeared 3 weeks later. So she was bleeding for the last 2 weeks, and that was the reason why we did an CT scan with contrast, an angiogram. And Mishka Patak from our Radiology Institute would like to show you the pictures right now.
Oops. Oh, it's the only.
Yeah, it's on.
Oh, just one. Okay.
We shortened it a bit, sorry.
Okay. So what we see, this is a so-called MIP. So we took several slides and put them together that we have a better information on the angios. And what you see is that on this side, in the small bowel, you have these small little contrast-enhancing dots within the bowel wall, which are quite suspicious. And we didn't see any active bleeding, but we see these knots of contrast enhancement that was read as being pathologic.
And in the operating theater, we already have Thorsten Beiner and Christoph Schlag, who will tell us how to manage such an overt bleeding and in the GI tract, or especially in the small bowel. So we go right there. Thorsten, Christoph, are you with us?
Hello, good afternoon. Can you already hear us?
We hear you, now we see you.
Hello?
Hello,
so
we can see you.
I suppose you can hear us. So, welcome back to room number 9. And it's a great honor for me to have been given this interesting case. You have seen the case presentation, but first of all, I would like to mention that it's a great honor for me to work here together with my good friend from Germany, Christoph Schlag. He's now here, you know him very well, here in Zurich, at the University Hospital. And I'm very honored to work together with the local team, Borsena and Sharon and Salome. So thank you very much. So you have seen the case presentation, and we are going to perform deep enteroscopy, and therefore we are using the novel Olympus PSF1 power spiral enteroscope. And you can see it. I have already the scope in my hands, and have a close look here onto the enteroscope. This is the motorized version of the spiral enteroscope, and it's a little bit different from the manual spiral because we have here a rotation coupler that is located 40 centimeters proximal of the endoscope's tip. And this rotation coupler is used to connect a short spiral overtube. Christoph, you have it in your hands. And the first thing you have to do is that we have to safely connect the overtube to the system. And we need a lot of lubricant before, so have lubricated using the Olympus Endolan. This is the only lubricant that is approved. So now we heard the first click, and now it's important, maybe we can show that to the camera. You can still see here the yellow ring, and we now need the second click. Yeah, push it until...
A little bit of the lubricant now on my glove.
So, okay, we have to push it a little bit.
Now
so now
yes.
we have a second click, and you could nicely see the yellow ring completely disappeared. And this is important to have a safe connection in order not to leave the spiral overtube in the patient. So first, where's the foot pedal? We have to look. So rotation of the spiral enteroscope, of the spiral overtube is done using a foot pedal switch. I put it a little bit in, maybe we need a little bit more cable. Okay, we have it here. So first of all, we have to go through an inspection mode to guarantee safe function of the motorization. You can see here on my left hand, this is the handle of the endoscope. Here we have an electric motor that is integrated into the handle, and that force, the rotational force, is transmitted to the rotation coupler over the flexible endoscope that is more or less like a pediatric colonoscope. So first of all, maybe we can show now the endoscopic image as well, so that you can see the monitor of the spiral rotation force indicator. Yes, now you can see it. You can see now only the backward sign is blinking. What means I can press the backward pedal. We can see the spiral is rotating in the counterclockwise direction. And you can see, we can see 3 LED bars, so no increased resistance. And now I bend the scope a little bit. I bend the scope, you can see increase in the resistance, but no, not too much, so this is very well working. And now I use my hand to squeeze the spiral I squeeze the spiral, and now you can see the spiral automatically stops. And now I have to do the same in the clockwise direction. Bend the scope, squeeze the spiral, so the automatic stop function works properly. So we can now proceed to enteroscopy. We have the patient that is here. In this case, the patient is intubated. We can also do it in patients that are under deep sedation, but now we have very good controlled conditions here. So we have the patient in the left lateral position. And the first step that we do is that we intubate the patient's mouth. So we go alongside the tracheal tube. And here we can see the tracheal tube, and at that point, I just intubate the esophagus like we do it with a regular gastroscope. So I insufflate the esophagus a little bit, and now we extend the patient's neck, because now the spiral comes into contact to the upper esophageal sphincter. And now I activate forward rotation, and we can nicely see that the spiral goes in very smoothly. It's okay, it's okay. We have it on top. This is okay. So we have endolan already on top of the spiral fins. We can nicely see that the spiral goes smoothly in. No increased resistance. Okay, we now are with the tip of the endoscope. We are already in the stomach, but keep in mind the spiral is still in the esophagus. So we continue very smoothly going in. So still we are now in the esophagus with the spiral part, but we can now already target the pylorus. I push the scope a little bit forward and have the pylorus in front of me. Now we can see here, so if you ask questions, so it's difficult to understand, so we don't have here sound. So if you ask question, maybe you can increase the sound a little bit. We are confident that you understand us at least.
Yeah, no.
So we have here near the incisors of the patient, I think you cannot see it now, we have the 80 centimeter mark. This is also on the scope. So this means that the scope is not now entirely in the stomach, and the spiral is not engaged to the pylorus anymore. So I can move the scope forward and backward without rotating the spiral. That's important before you advance through the pylorus. So I push the scope forward, activate forward rotation.
So then a question from me, if no one can.
Yes, please.
So if you have struggled to parse the upper sphincter, what would you do? Is it a problem, or does it usually not a problem?
Usually it's not a problem, but of course we have a bulky instrument, and if we have problems, so if the patient is intubated, sometimes the blocked tracheal tube can be a problem. So if we encounter higher resistance, we deflate the cuff a little bit, and then this sometimes is enough. But if we have higher resistance with motor stops, we go back, inspect the mucosa, and if we don't see any lacerations, we try again. But we can also proceed to do a wire-guided bugination of the upper esophageal sphincter. In most of the cases, it works very well. But we don't do it in routine. Yeah. So now, with the tip of the enteroscope, we are in the duodenum, and now the spiral has to go through the pylorus. No? So keep in mind, we have the spiral behind us, and here we activate forward rotation. You can see I have to push a little bit, just a little bit, pushing. I suck the air here from the lumen. I activate forward rotation, let the spiral engage here, the pylorus. That takes some time. It takes maybe 10 seconds or even longer. And now you can nicely see that we are going forward. So, and now we reach with the tip of the endoscope. I think we can see that we reach here the area of ligament trite. So don't be afraid if you don't see the lumen, because you are not actively pushing, but you're pleating the bowel onto your scope. So still I have to push a little bit to let the spiral go through it, and from a certain point this pleating will really occur. So here, now as you can nicely see, I suck the air from the lumen, and I have both hands here. I just activate forward rotation, and now you can see that the spiral is smoothly going in. I decompress the lumen, and now this is what we have reached. We are distal of ligament trites, and now the motor and the spiral does the work, and we can just observe. I don't insufflate too much. So at that point, we usually create a little loop in the stomach. So this, as you can see here, some compression from outside of the stomach is here really helpful. But we can release the compression now, because we are very confident now the spiral does the work. And I even can, while maintaining forward rotation, pull back the scope to straighten the scope in this position and let the motor do the work.
And Thorsten, from your routine setting, I think in the beginning all patients were done under general anesthesia, and I think
Yes.
nowadays you,
Yeah.
what is your routine? You do it in propofol sedation, or?
Yes, routinely we do propofol sedation in the patient, except the ones with severe comorbidities, ASA3 and worse. And if we expect some problems in the upper airways, for example. But most of the patients, I think 90% we do under deep sedation using propofol and midazolam. It's also a question of availability of general anesthesia, but we have seen no complications in these patients, and this is also something that we discussed with our anesthetists. In the beginning, in the first trials that we have published, every patient was intubated to be on the safe side. So what's your strategy in Zurich? What do you do?
Actually, honestly, we are still intubating them, all of them, but like you just convinced me, it's probably not a big need to do so. I mean, the worst thing which could happen, that an airway problem occurs during examination, I think then we just discussed it already before. No easier way to do an intubation in a patient where the esophagus is already blocked, because then the airway tube will go the right way.
So while we are advancing the scope here and looking for some lesions, most probably we will see at some point maybe an AVM, angiodysplasia, for example. But let's see, we can just have a look that also, although the scope was introduced into practice before introduction of the X1 system, the scope is of course compatible with the new X1 platform, and that means that it's also all the different advanced imaging techniques can be used. So I just can show you. Okay, this is like okay. We can use, of course, the new TXI technique, the structure and color enhancement mode. Sometimes that makes it easier to identify also the red lesions that we are looking for here. For bleeding spots, for example, can switch off TXI. You have the full spectrum. You have this bright NBI that we can use. And also, we don't need it at that moment. We could use the RDI mode that is more or less used to. Yeah, we can even switch it on if you don't mind. We can here put on B this. Now we don't have a bleeding site, but we can at least look for deep vessels below the mucosa. And as you have seen in the morning, that can be really helpful if you're looking for the bleeding spot in a severe bleeding when the entire screen is red. So, but luckily we don't have a severe bleeding here at the moment. So we continue a little bit. Maybe Christoph, can you switch off the RDI? Okay. I activate forward rotation. I decompress the lumen here. And we continue our procedure. So the scope is also equipped, and that's also helpful with a dedicated irrigation channel. So sometimes, if it's difficult, we can even perform not only underwater ESD, but also underwater endoscopy that will then even facilitate deeper intubation. Some maneuvers are very helpful to go really deep. So as you have seen, I keep forward rotation active here. You can see it on the screen. But I pull back the scope. And this means I straighten the scope's position. And this usually pushes the scope a little bit forward and then helps to pleat also the next, the small bowel from the next fold.
So at which side do we actually expect the lesion? Because we have not seen the CT demonstration. Was it in the jejunum or in the ileum?
Mishka, can you ask? Mid of the jejunum.
Mid
to
of
end
the
of the
jejunum.
jejunum.
Okay. Would you also go for the antegrade approach first before you do the retrograde one?
Yeah. We usually start with the antegrade. However, as we know that we can go really deep from both sides, by the way, there were total endoscopies from both sides. We could also think about our strategy in the future, especially in the circumstances where antegrade procedure with intubation could be a high-risk procedure. We could also start from retrograde. I think this is also a common strategy using balloon techniques. Also with our Japanese experts, we discussed it like this, and then just complete from antegrade if something remains unseen. So here we have a sharp bending. I again irrigate to open up the lumen. Then we push a little bit forward. I suck the air from the lumen, straighten again the scope, and then hopefully pleating will reoccur. Yes. I suck the air here, and we are around.
And you also would agree that it feels a lot more comfortable than doing balloon endoscopy.
Yeah, it's really to be honest, it changed totally the attitude towards endoscopy in our unit. So we know that very good results can be achieved by the masters in balloon endoscopy. It's no doubt, but maybe this technology is also very efficient in the hands of endoscopists that are not so familiar with going really deep with balloon endoscopy. However, we have to keep in mind we have a new technology. It's the first motorized endoscope that has been introduced into this wide clinical practice. So, and I'm very convinced about the concept that Olympus has to have this dedicated training program before you can use this in your unit on daily basis. No? So, even the model that has been developed by Olympus engineers it's really helpful to learn about the critical parts of the procedure. That in the end, if you know them, this is not critical. But if you don't keep this in mind, that can be difficult to overcome. So we are very sad, but we at the moment we cannot present a finding to you.
Right, we're also watching, and after behind each corner we suspect something, but so far
we keep on going. Huh?
And I think we would shortly go for a coffee here and come back right afterwards, and then maybe you can present us something.
Yes, okay. We do our best. We do our best.
So we do a 15 minutes break for coffee, and afterwards we meet again here in the audience. Thank you very much.
Kaffee hat er gesagt.
Kaffee.
Ging ja auch jetzt. Spirale macht die Arbeit.
Grundsätzlich geht es ganz gut. Ne? Bitte. Ja, sehr wird vielfach gelobt.
Wenn du dir das so über die Studien anguckst, von Antegrad 20-30% Full Endoscopy, würdest du auch denken, es ist mehr, oder?
Ja, im Prinzip schon. Meisten,
Du
den
hörst
meisten
halt vorher
Teil pflegen
auf,
wir es
ja.
ja gar nicht. Genau,
Ja.
das ist ja das. Aber auch wenn man es drauf anlegt, ist in den Studien ja nicht mehr rausgekommen.
Ja, das ist
was ein bisschen überraschend
komisch,
ist.
ja?
Aber wie oft braucht man es denn wirklich, ne?
Das ist irgendwie schon so, das ist das erste Mal, dass irgendwie Enteroskopie zumindest wieder ein bisschen Spaß machen kann, mal. Weil ist ja irgendwie, oder? So die
Macht es immer noch nicht so richtig.
Nee, genau. Es ist nicht immer wieder nicht ganz oben auf der Favoritenliste,
Nee,
ja,
nee,
aber schon deutlich weiter als der Ballon.
Ja, genau, definitiv. Ah, da ist er. Nein. Das sah gerade aus wie es war die Spirale, ne?
Ja, ja.
Ah, das wäre schön gewesen, jetzt zu zeigen. Ja,
Von
ist
9
wieder?
auf 8,5, ja?
Ja. Und
Okay.
hat sie noch mal wieder Blut abgeführt,
Ja.
blutig abgeführt? Ja. Es wäre schon schön, entweder was zu finden oder ganz bis ins Zirkum zu kommen. Damit, ja.
Fujifilm is a pioneer in diagnostic imaging.
Aber dafür brauchen
With
wir
over
gleich wahrscheinlich
70
ein
years
bisschen
of expertise,
ja,
we
also
put
im Moment noch
cutting-edge tools in our
ich sag
customers'
Bescheid,
hands, so patients
Hat
get
gerade schon
excellent
super geklappt
results.
im Magen. Vielen Dank.
Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice.
Okay, welcome back. We'd like shortly to go back into the operations theater and see what Thorsten Beiner's doing. So Thorsten, Christoph, how far did you get? Can we see the cecum or lesion? Okay, can we switch to the operations theater? No, so we go to operation room, not room number 1, OP9. I guess I'm still working. The spiral was deep inside. From technical side, possible, or? Okay, so Joachim, Wim, we start with you then. Thank you. But we try to get back to the spiral later on.
Thank you very much. Darf ich noch Ton bekommen? Sehr gut, hervorragend. Vielen Dank. Well, thank you very much. It's my great pleasure to, first of all, present two very distinguished colleagues. Wim Lalleman, who's coming to us from Leuven, and who has been spearheading the development that is now named endohepatology. And as a hepatologist, I'm obviously very happy, and gastroenterologist, I'm very happy that the hepatologists get hands-on in terms of advanced endoscopy. And he's doing this, and he will show us how he's doing it. On my left side here is Rainer Wiest. Rainer Wiest is the physician-in-chief in Bern and a very dear colleague who couldn't be a better person to discuss with me, since he has since his training, really been focusing on liver hemodynamics and also been an interventional endoscopist. So he's the perfect panel discussion partner. The case that I would like to present to you, if I can have the slide, please, is can you continue, please? Next slide, we're not used to the same. Okay, is a almost 70-year-old male patient who has a known metabolic syndrome for many years. He is diabetic, he has a coronary heart disease, he is obese, and he has a coronary and valvular heart disease. He also has a known metabolic toxic hepatopathy, and there's been some discussion how advanced this might be. It's never been biopsied, but FibroScan really indicates that he's a high-grade fibrosis, probably cirrhosis. There were no esophageal varices visible, but he has now been diagnosed just recently with a single nodule hepatocellular carcinoma. It's 28 millimeters in diameter, would be a BCLC 0 stage. And now the discussion is, what's the best therapeutic option for the patient? Next slide, please. So here's the discussion between our energetic liver surgeons who say we do curative resection because we know outcomes are better when we resect instead of local regional ablative therapy. And there is obviously the interventional radiologist who says, but we are great and we can do this, and it's more apt to this rather ill patient in terms of his comorbidities. And now comes the point where the surgeon and both of them say, we need a pressure. Our discussion and our decision will be based on portal venous pressure. And we have all heard this before, the surgeon who comes and says, I need to have a pressure first, and then I can say whether I can operate. And here comes this new technology, and I would like to dive right into the case presentation. As you may have noticed, Wim is not able to be at two places at the same time. We have recorded this case briefly before, so we can have him right here to discuss that.
Visiting here our dear colleagues in Zurich, and so this case is a very interesting case as proposed, and so I will try to take you step by step through the procedure of doing an EUS PPG. So we use a linear echo endoscope. We already introduced the scope up to the level of the cardia and the proximal stomach. And so there are several steps that you need to respect in order to do a good procedure. So of course a good indication is a good start. Another thing is of course checking platelets and coagulation. So we respect a minimum INR or a maximal INR of 1.5 and platelets of minimally 50,000. The next thing what you need to do is identify pertinent vessels. And so the pointer is here already at a hepatic vein. And so it's very important to identify the important veins. So this is the hepatic vein. The portal vein we'll survey later on. But so if we confirm this vessel by Doppler and even by power Doppler, so I'll try to give you a heads up. So this is the typical pulse wave of the hepatic vein, and you can see that this is either the middle or the left. I think personally it's the left. I'll try to go back. But so at this point, I think I can already give a heads up to our nursing team to start preparing the needle. So in that box you get a 25 gauge needle, you get a plastic tubing, and you get a digital manometer. So, so the manometer we already checked, and so it was here on this platform, and so it was measuring 0, which is of course the basis for our measurement. The next thing when preparing the needle is to make sure that you flush the system quite adequately, because again, if you have an air bubble in the system, then we will get a false reading, which of course is not what you would like to have. And once the tubing is connected to the needle and the manometer, we flush it again. So just to be sure that we don't have any problems with bubbles. So this is about 24 millimeters from the takeoff of the vena cava. So this is in essence an ideal position. So we'll freeze the image again. Okay, thank you very much. So we're now taking the needle. So this is your standard FNA needle, 25 gauge, which like any other needle you lock onto your echo endoscope. And so we just, like every needle, we are positioning it here. So we are putting the zeroing or the manometer here on the level. And so we keep it stable. I'll now try to come out and you will see the sheet coming out of the echo endoscope. So it's here. If I use and so I need to go in a straight trajectory towards the hepatic vein. So this is a good position. I'm locking my system. I'm unlocking the needle. And so you can see that the needle is coming. And so you can nicely see the needle. And we go through and through. So that means that in fact I'm going through the vessel. I'll try to show you. Okay, so this is not a problem. And it's even better because if you pull back, I will put a little bit larger. So we're in the middle of the vessel. This is a good position. Okay, so what we'll do now is I'll try to keep this position like this. So I know I'm in the middle of the vessel. What we now need to do now, and I'll try to show you, is in fact flush. So that we know that we're in the middle of the vessel. Okay, you can flush. And then you see the little bubbles appearing. So this means that we are free with the needle. And so now we're measuring the pressure. I just need to take a relaxed position. So this is very important, that we relax the needle in every possible way. So I think we can record this. So now it's 16, 15. So we are at 15, okay? So we can stop the measurement for the hepatic vein now, which is what is important, and what I would like to point out to the audience is also, just don't pull back like that into the tissue. Just come back in the liver, and then stay in the liver, and then use your Doppler to see whether there is blood coming behind you, because this is a very important safety issue. So normally you should not have any blood coming back because the tissue will tamponade the trajectory. And so in the case you would have a trajectory coming behind you, then it's just a matter of waiting a couple of minutes because it will usually clot by itself. Okay, so I don't have any blood coming back, and so I'll gently pull back my needle, and so we're out of the hepatic vein. Okay? So this is the part of the hepatic vein. Now we need to touch for the portal vein. So here we have nicely a big and large portal vein. So again, we have a go. So this is the Doppler, and then we put on. So this is the continuous venous hum of the portal vein, which all of you know. So we know that this is the portal vein. We could already suspect it from the cuff that is typically around the vein. So this looks like a good entry point. So just to give you a heads up, so in terms of measurements, this would be about 2 centimeters. Okay, you can flush. So this is quite too high. That means that I'm still not in a good position. I'll have to draw back the needle because I'm not okay. So the tissue is so hard that I'm getting pushed away all the time. Okay, now I'm in. So I'm in the vein. So you can flush now. Okay. And then we just gently hold the scope. The strange thing is that we have about the same pressure as we had in the other position. So that's interesting, because it probably proves the point that what I measured there was in fact the same, because we have 50, which is exceedingly high. So if you will flush again, indeed, and I had the same position when I was at the portal trunk. Now I'm in the left portal vein, So this is exceptionally high, but it confirms what we had in the beginning. So that would mean that we would have a gradient because we have to subtract the hepatic. So 15 minus 50 that we have now, that would mean that it should be a gradient of 35, which is possible, but exceptionally high. So we're still again at 50, okay. So we flush again last time. So we're always about that magical limit of about 50. Okay, so I think we should accept the measurement as it is. And so again, so it's very important. Again, you can see that I'm in the middle of the vessel. I'll try to show it here. So we flushed on occasion. So this means we would have a gradient of about 35. And again, the same maneuver as you would have in the hepatic vein. So don't pull back the needle because you're finished. Just go back gently and just follow your needle trajectory. Back a little bit more. Okay, so I think it's safe to pull back. And so this should preclude, in fact, this procedure. So you see, it's not always straight ahead, but if you take your time, everything is possible. So there's no problem with distance towards the portal vein. Consider the hardness of the liver as a potential factor that might make you have to puncture once or twice. And you saw that I punctured several times. And so this does not really make a difference or a problem for the patient, because if you would consider an additional transgastric liver biopsy, you would even puncture with a bigger needle and also do several passes. So you can nicely see also this is a very fibrotic liver because you can see all the nodules between scar tissue. And so I think this should finalize our procedure from here. And so we'll remove the needle. Thank you for following this procedure, and I think we'll go back to the room. Thank you very much.
Thank you very much, Wim. And I just heard that now we do actually have a cameraman in my room in Operation Theater 9, so we can briefly switch back to Operation Theater 9. And I'm happy if Stefan can probably connect back to them.
Hello, can you already hear and see us?
Yes, we can hear you.
But no picture. But,
not yet, just a second. Give us a second.
Yeah. The picture is actually not so nice, huh? Because meanwhile...
maybe the reason why they don't even want to show us.
Yes, maybe, but...
okay, here we are. Now we can see it.
Yeah, we are here. As you can see, this is not small intestine anymore, so we reached the cecum. And relatively quick, so we had some trouble waiting here while the technical problem was solved, and meanwhile we had this very nice impression of the ascending colon here. Mm-hmm. So what's interesting, so we first of all we didn't see any erythrocyte on our way in, but usually we inspect the mucosa also on our way back, and we can see the stool in the colon is not bloody in any form. That was what we were discussing. So now the tip of the endoscope is in the cecum, and you should not, coming from the antegrade approach, pass the ileocecal valve with the entire spiral. So I have last week I read a case report that this was done, but it's not recommended by the manufacturer, of course, and also not by me. So now Salome did a great job. So sometimes, if you want to go really deep, it needs a little bit of, it's not like abdominal compression, like in colonoscopy, but it's like abdominal massage. Our assistants don't like this term, but it's actually what it is. And Salome, although I think it was your first procedure like this, did an excellent job. Maybe you can now release your pressure. And I activate backward rotation, and we gently go back into the distal ileum. Here, this is the ileocecal valve from the antegrade view. And what we are now going to do is that we step by step release the small bowel from the enteroscope and inspect the mucosa.
Okay, impressive. Thank you very much.
Yeah, so we will tell you if we find a lesion, but anyway, we can at least tell the patient, even if we don't find a lesion, we have seen the entire small bowel and can exclude a bleeding source there.
Okay, thank you very much, Thorsten.
Thank you.
Bye. Sorry to interrupt you.
So, coming back to the liver after these beautiful images, going back to Wim, and I'm happy to have him present on this technology of measuring portal pressure endoscopically.
Okay. Kann man auch, genau. Ja, genau.
So if I
Kommt
can
man auch
have
bis
my
zur
slides.
Papille, wenn man möchte.
First of all, I would like to thank Stefan and Joachim for the kind invitation. It's both a pleasure and an honor to be here and to participate in this prestigious meeting as a hepatologist, and maybe I can call myself an endohepatologist. So
let's see if you find
endohepatology was a term that was coined in the
das sind wir selber gewesen.
I don't know if
wir haben relativ lange an dieser Stelle gestanden und da hat es gedreht.
Could you please switch off the sound of Operation Theatre 9? Thank you.
Okay, good, thank you very much. So the term endohepatology was coined in 2012 by Kenneth Chang, where in fact he defined endohepatology as the integration of endoscopy within the practice of hepatology. I would rather like to rephrase it to the integration of advanced endoscopy within the practice of hepatology. And in essence, we have two pillars. So first of all, there's the pillar that is dedicated to the hepatobiliary tract, and it's mainly of interest as a hepatologist for PSC and biliary complications after transplantation, as driven by ERCP, EUS, and cholangioscopy, as we've seen also today. And then the other pillar is in fact directed for parenchymal and vascular liver disorders, and is mainly driven by EUS. And this is in fact where the field has exploded in the last couple of years. And so you can see all the interventions. I unfortunately don't have the time to address them all, but we will discuss EUS PPG, of course, EUS guided liver biopsy, but there's also the EUS guided coil plus glue injection for stomach varices. There is EUS guided portal vein sampling, which for a hepatologist is the Valhalla, because there you have the gut-liver axis that is finally accessible, where it has not been for over a decade unless we go via TIPS. There's also the EUS-guided intratumoral therapy, which you could make the analogy with the pancreas that is now also being targeted via EUS. So the future is bright for us hepatologists and certainly those who also combine it with endoscopy. And so we'll discuss EUS-guided portal pressure measurement and EUS-guided liver biopsy. I'll start with the last. So EUS-guided liver biopsy, in fact, emerges as a safe, well-tolerated / appreciated and effective alternative to traditional liver tissue sampling. And I'll try to give you some arguments why I at least prefer this method. So the patient is, of course, central in everything we do. And I must admit, I've done percutaneous biopsy, transjugular biopsy, and now I do EUS-guided liver biopsy. I have always had difficulties in trying to convince a patient to come back for a second or follow-up biopsy, and ever since I do EUS-guided, I did not have any problems. So the reason is simple. Patients are sedated. They have a lower post-procedural discomfort, and they have a faster recovery. So these patients, I can send them home after 1 hour and a half, where with a percutaneous biopsy, you need to keep them for 4 hours at least. The second thing is that if we, and this is a question we get asked more and more from our oncologists, puncturing liver lesions in the left lobe. So you can have targeted biopsies and you can have the aid of auxiliary visualization techniques. I think this audience needs no introduction in those techniques. And then, of course, we have real-time guidance in avoiding critical structures, which is, of course, pivotal for a safe procedure. And then the other thing for a hepatologist is that we are able now to target 2 lobes. So we can take bilobar biopsies. We can take biopsies from the right lobe when we come from the bulb. We can take biopsies from the left lobe coming from the stomach. And in fact, the pathologist is very happy with this approach because usually they get a tiny piece of tissue, and it's been said, and it's dogmatically been said that the smaller the biopsy you deliver, the milder the disease the pathologist will give you as a protocol. So now we give them half a steak, and so they should be happy with what they get. The other thing that is important is, of course, cost effectiveness, because I can think of people already thinking, okay, EUS, sedation, needle, this must cost a lot. Well, if you combine all of these procedures in one, so screening for varices, For example, also screening for biliopancreatic disorders, as the case we've seen this morning by Dr. Vadarajulu with the cystic lesion in the transplant patient. So, I mean, if you combine all these in one procedural timing, well, then of course it becomes a one-stop clinic, and obviously it becomes cost-effective. And then overall adverse event rate is 2.3% if you look at the aggregated literature, and the primary is minor bleeding in 1.2%, so this is in fact not exaggerated in comparison to the other manners. And most of all, here you can see an example of the amount of tissue. This is one procedure I did. So you can see the amount of tissue that you can acquire when doing these procedures. So I'm just going to give you the scientific proof in one slide. So this is in fact the comparison between percutaneous, EUS-guided left lobe versus transjugular. And so the prerequisites for an adequate or high-quality liver biopsy is minimum 11 portal tracts and a length preferably 15, preferably 20 millimeters. And if you look to the difference, so this is the total specimen length, this is the complete portal triads, well then in fact EUS liver biopsy is as good as percutaneous and transjugular. And if we go to the lower row, there we combine both lobe EUS, so right plus left, then you see that we even outperform the other means. And so the pooled successful histological diagnosis is 94%, which is very good, at least in my view. Okay, there are some technical issues, and I think for this audience it's probably one of the more important things. So how do you do this in a proper way? So there are 4 items that you need to address. First of all, don't go for a small needle. Everyone is afraid of puncturing the liver. 25, we use it for the EUS PPG, okay? But if you want to do a liver biopsy, you need a 19-gauge needle. Preferably the Francine needle. So there has been a comparison, there has been substantial literature. In my unit, we don't dispose of the 19 Francine, so I use the 19 FNA, standard working Hurst needle, and so that already gives me satisfactory results, but you should at least use a 19. Everything smaller than this is suboptimal, to put it optimistically. The other thing that is important is that you need to consider the heparinized wet suction technique. So you need to do 2 things. First, you need to remove the stylet up front and flush with heparin, so 100 units per ml. And so the reason herefore is that you want to avoid clotting in the needle when you in fact penetrate the liver and in fact want to fill up your bore of the needle with clot. So you need to flush with heparin. And then the other thing is the wet suction technique. So you fill your suction syringe with 2 cc's of saline to give you in fact a good readout. When you are puncturing the liver, you will see the fluid column going up, giving you information on the fact that you are acquiring tissue. And then once you're in the liver, so you need to do 3 actuations as a minimum. So this does not mean that you go in and out 3 times. No, it means that you stay in the liver, but at least you pass like funning, but in 3 different directions if possible. And then the last issue is that instead of what you do with the percutaneous liver, you just drop the tissue in a kind of vial with fixation, is that you need to capture the tissue on a tissue sieve or a tissue cassette. This immediately gives you an idea in the room that you have acquired the necessary tissue, and secondly also gives you an opportunity to rinse off the blood that often comes along. So these are the 2 manners, and then you can transpose it to the vial for processing. So this is for EUS-guided liver biopsy. I'm now coming to EOS portal pressure gradient, of which you saw the challenging case. So why would you want to measure portal hypertension? Well, for hepatologists, we want to know when our patient with chronic liver disease develops clinically significant portal hypertension. This is important because this is in fact the main driver in the development of all of these infamous complications, so ascites, esophageal varices, encephalopathy, hepatorenal syndrome. And this is of course decisive in terms of prognosis, but also of management of the patient. And we are changing our paradigm. So in the last Baveno 7 meeting, we are now, as a primary aim, we're not going for primary prophylaxis anymore of varices, we're going for prevention of decompensation. So we want to prevent all of these complications, which means that we need to detect clinically significant portal hypertension. And we've been doing that, in fact, by performing hepatic venous pressure gradients. So CSPH, so clinically significant portal hypertension, is defined as an AHVPG equal or more than 10. and we've been doing these procedures via liver catheterization. So this HVPG is an indirect portal pressure measurement, and I want to emphasize indirect. So what we do is we come through via the jugular vein, we put a catheter in the right hepatic vein, and first we measure the free pressure, which gives us an idea on the pressure after the liver. And then we inflate a balloon, which then occludes, in fact, all the blood in front of the balloon and gives us the wedge. And by subtracting the free from the wedge, we get the gradient. And so this is the current golden standard. I put with a smiley, no longer best available, but that's a personal touch, sorry. But so golden standard measure to assess portal hypertension. And you can immediately assess, or you can immediately think, well, this seems quite invasive, this seems quite technical, it's quite specialized, and that's also the problem we've been facing. HVPG has failed practical implementation and broad dissemination because of its technical issues. And so there we are, stuck with our patients and a lot of colleagues that do not have access to HVPG. And so in the last couple of years, we've been looking and trying to look for alternatives. So going to liver stiffness measurements, spleen stiffness measurement, but it's for sure it does not cover the whole load of these patients. And so there comes, in fact, the EUS PPG platform that you've seen in the case. So I'm not going to explain because it was nicely illustrated, I think, in the video. So this is the system. It comes in a box, as you've seen. And so what we do, you've seen it as well, so is we puncture the hepatic vein, and then we puncture also the portal vein. And at this point, we are still making the gradient in analogy with the HVPG. But of course, there is a discussion, and it's not solved yet, whether we really need to make a gradient because we're going back to the direct portal pressure measurement as in fact in the initial days of portal hypertension. And if I can put the two measurement methods next to each other, so HVPG being the golden standard, EUS PPG being the novel platform, as already mentioned, this is for the dedicated hepatologist, interventional radiologist, typical for tertiary units. There are, of course, much more endosonographers than there are people doing HVPG, so this is already a big step forward because we have broader applicability in terms of patient management. For HVPG, you need dedicated equipment, training, and X-ray. Here, of course, you also need some training, but you don't need X-ray, so we did it in the room here in the hospital in the conventional endoscopy suite, so we didn't use any X-ray. The disadvantage of HVPG is that it only assesses sinusoidal portal hypertension. I hope most of you still know the concept of sinusoidal, but with this technique, we can also measure pre-hepatic and pre-sinusoidal portal hypertension, which of course is of added value if you consider patients with non-cirrhotic portal hypertension, which usually is this category. Which HVPG don't have any problems with coagulopathy and ascites. Here you need to be somewhat careful. So if there's ascites interposed between the stomach and the liver, then I would abort and not do the procedure, safety before everything. So this is rather for the patient with compensated advanced chronic liver disease. This is, of course, for the decompensated. And then, as already told you, you can combine this with screening for varices. You can combine it with the biopsy. So in a one-stop clinic, you can do this HVPG without anesthesia or with mild sedation. We've been doing for the study that I will explain you later on, the procedures for the moment under general anesthesia because of the purpose of safety in the context of a trial. But you can also do this with mild sedation. Procedure time is comparable, and both can be done in an outpatient procedural way. And so just to give the strengths, so EUS guided PPG, because this is also one of the disadvantages of HVPG. If you occlude the balloon, you are supposed to get an idea on the portal readout. But if there's, of course, a veno-venous shunt, so a backdoor, then, of course, you get false low wedge, which gives you a false idea on the context. So this is the advantage of the direct measurement. We don't have to consider these bypassing vessels. As mentioned, we can consider pre-sinusoidal and non-cirrhotic. We are cost-effective in a one-stop clinic situation. And most importantly, at least in my view, this is an alternative to HVPG where expertise is not available and certainly readily available if EUS is accessible. So this is the big step forward. Just to give you an idea on the current status, so this is a very young platform, so I would say it has reached adolescence, but not yet maturity. So if you know that the first go, or the first preclinical experience in a pig model was published in 2016. The first human pilot by Ken Cheng was performed in 2017. And on the basis of this, FDA approved it. Quite surprising, but okay, we're not complaining. And then ever since, we have real-time cohort from our American colleagues. And the only conclusion we can make there is that it's safe and feasible. So that's the conclusion. But there is, in fact, no study, except for one Chinese study, to my knowing, that compared the EUS PPG directly to the HVPG, the golden standard. And this was in a peculiar population of sinusoidal obstruction syndrome and Budd-Chiari, which is not your average liver patient. So for that reason, we are doing the Encounter trial in my center, Leuven, together with colleagues from Rotterdam and Barcelona. And so what we are doing is, in the same patient at the same time, we are comparing the interventional radiological approach versus the EUS PPG approach to get an idea on, in fact, the correlation between the two. And I will just show you a picture. So this is during a TIPS approach. So the interventional radiologist is already in the portal vein. You can see our linear echo endoscope here, and we're coming from the left. So we literally meet in the portal vein for this peculiar study. So the results are expected second half of the year. I cannot tell you more. Maybe I'll come back next year, I don't know. But so at least there we are. And so this is a kind of algorithm that you could consider in the future. So first diagnosing with elastography the compensated advanced chronic liver disease, but even there are pitfalls. So then you could do your EUS with portal pressure measurement, even combine it with the liver biopsy, stratify your patient into risk categories, aim for prevention of decompensation, look at antifibrotics, intervention, study the gut-liver axis. So I'm completely wildly enthusiastic about bringing this into practice because it has several advantages. And so this is my last slide. I think endohepatology, because I could not tell you everything, just two things, but it's clearly going on the rise. And with this, I would like to thank you for your attention and take any questions you have. Thank you.
Thank you very much, Wim. I think this is a very impressive and very exciting joint venture of hepatology and endoscopy. I'm not going to extort you on the data on comparability of the two values. Plus, we may really have to relearn about portal venous pressure. If I get you right, just very briefly, if I get you correctly, then the safety and tolerability is very comparable, if not better, for the EUS PPG measurements. Is that true?
I would not say better. I would say at least the same. I mean, a lot of patients, of course, have problems with the liver catheterization. On the other hand, we also have to introduce an endoscope, so some patients also have some problems after the endoscopy in terms of nuisance in the throat. But for me, this is very straightforward in the sense, as an endoscopist, I mean, you get access via EUS. You can do everything you need to do from a hepatological perspective. So this is the hybrid way I would like to continue, at least as a hepatologist. So, yeah.
I mean, if I may follow up on that, I mean, are there contraindications? I mean, like a transjugular you can do with 5 platelets, or you can do an INR, or, I mean, so in terms of
we follow the guidelines for the percutaneous biopsy, so a minimum of 50,000 and an INR of 1.5 to the max. I've done in worst, but I mean, this is also obviously you need to look at a case by case, but I've done it without substitution in INRs 2.5 and 30,000 platelets. The EUS PPG, the biopsy is something else. There I would, I think, respect the traditional cutoffs. But for EUS PPG with a 25 gauge needle,
I mean, therefore, just breaking the ice, I mean, people sort of, I mean, that's what I was trained as. I mean, in the US, you're not like on purpose hitting a vessel. So, I mean, looking at this case with a PPG of 50, this vessel is under pressure, and you target it at the first place even at an extrahepatic site. So that tells me the threshold of going for it in your terms, in the expertise and the caseload that's out there is safe.
This was an exceptional case, I must say. There's something in the drinking water, I think, in Zurich, because it was a brick of a liver, because the needle really also went a little bit, bended a little bit. And in the beginning, the first puncture I did, I was quite sure that I was in the portal vessel, but the value was so high that I questioned whether I was not against the wall. So we pulled back, and then, but because we confirmed it in 3 different positions, in the end we needed to conclude that the value was okay, or was correct. But again, you saw, I mean, you need to respect, of course, if you're finished with measuring, don't pull out. You need to go gradually. It's the same for the EUS guided liver biopsy. I mean, you also go step by step and look if you don't have any blood. If you would have blood in the trajectory, you just keep the needle in place for 2-3 minutes. Usually it will coagulate by itself and the tissue will tampen out. So it's very important to try to stay or to have a kind of transparent chimal trajectory if you do EUS PPG, because it will tampen out itself. In the case that the blood would stay, and I'll touch wood, I never had it, but Ken Chang described a manner where he in fact used the principle of a blood patch, where he in fact just reintroduced the stylet and pushed out the blood that was in the needle that meanwhile clotted. So that's also what the anesthesiologists do when they have a leak, for example, with the epidural punctures.
Coming from the Baveno, discussions, and obviously the probably internal debates about what we're going to do with this new technique, and many of us have been used to HVPG measurements for a long time. There is always, and we discussed this when you did it before, that there is always this question about you have an awake, locally anesthetized patient who has a puncturing of his jugular vein versus a more or less deep sedated patient on your endoscopy, in your endoscopy room. What difference does that make in terms of pressure values?
That's a very good point, and it has been proven that in fact deep sedation influences the HVPG. So for the purpose of the trial, we're first doing the awake HVPG. Then the patient is intubated because we first wanted to confirm that they have clinically significant portal hypertension. Then the HVPG is measured again under deep sedation, and then we start. For the purpose of the trial, we were obliged to do it under general anesthesia because our ethical committee wanted full safety, which is obvious in such an approach. But we've done it with off the trial with minimal sedation. So it has been proven also, if you want to give your patient some comfort, that you can allow 0.03 milligrams per kilograms midazolam. And even there's a recent Chinese paper that even has shown that fentanyl is also not a problem in terms of influencing HVPG. So you need a minimal of sedation to do these procedures. You cannot do them awake, but you can in fact introduce a minimal degree or light sedation, which should in fact not impact. But this is of course something which we'll have to further evaluate. So this is one of the major elements that you correctly touch upon. So
I'm assuming it's, I mean, you do not need to convince me, but assuming it's safe and then counter pays off, so we have quality, because things in medicine sustains the test of time. It's safe if it's quality, benefit, and if it's practical. So I think the 4 things are quite realistic. Even pushing it, could you think of, I mean, it has been measured in the previous, invented for preventing complications. So if you already are cirrhotic, you mentioned, I mean, you have an advantage with pre-sinusoidal. I mean, we have a lot of obese patients. I mean, could you comment on an add-on value of the technique, which is even more beneficial to patients rather than the cirrhotic ones?
You're an equal hepatologist, so you know that we are struggling with non-invasive manners to assess compensated advanced chronic liver disease. So we have elastography. We try to make non-invasive fibrosis scores, FIB4, and okay, these help us to a certain extent, but we are still left with a gray zone of patients where in fact these tools do not work and even can be falsely positive. So in the end, in some cases, okay, it might be clear cut. I mean, if the patient has ascites or has already a variceal bleeding, then it does not make much sense to go for a portal pressure measurement. I think your case, Joachim, was a very good one, because you were doubting in going for resection or locoregional therapy, and I think correctly the surgeon asked for the pressure measurement. And I think in these patients with what we saw, I think it would have been suicide to go for surgical. I don't know what they did in the end.
Did not.
Okay, so I think this was a right call, and I think it saved the patient a lot of morbidity and even mortality. So I think for preoperative situations, for grain zone situation in patients with compensated advanced chronic liver disease, and the whole MAFLD, because we need to call it, the name has changed since this morning. So it's fresh from the press. So with the whole NAFLD, I'll still call it, epidemics, I think we have a lot of work as hepatologists and as endohepatologists. Or you need to team up as a hepatologist with your advanced endoscopist, so it depends on your local setting, provided that your endoscopist has a kind of hepatological mindset or was introduced in a hepatological mindset.
Thank you very much. I think we have to wrap it up. One last question, very practical, very endoscopic. How long does it take to train me to be able to do it?
3 minutes. Well, there's no short answer for that. I think there is no study to say when are you able to do that. I mean, the SGE has given guidelines or has made a position paper on how to train EUS. Personally, I would advise you to first do the course of 250 endoscopic ultrasounds, have indeed FNA, FNBs in pancreatic lesions or mediastinal lesions, just to get acquainted with the needle principle. Once you have achieved those limits, I think you can easily transpose to the liver. So once you've obtained those, I think you can go on. There are people and there are situations like, for example, the colorectal surgeons also do EUS of the rectum. So there are people who do dedicated EUS. You could imagine if the hepatologist has some endoscopic proficiencies that they transpose to doing just the EUS of the liver. But yeah, of course, volume makes practice. And so I think you cannot advocate to do this as your first procedure if you just have been given an EUS scope. So I think I would go the easy way or the gradual way, train in EUS as a whole, and then try to move on to the liver. That would be my advice at this point.
Thank you very much. I'm sure we'll hear a lot more of this. And I'd like to conclude that bit of the EndoSwiss. Thank you very much.
Pleasure.
Ladies and gentlemen, therapeutic endoscopy has grown tremendously in the past 30 years, and this will not be possible on the one hand without dedicated endoscopists and on the other hand without people from the industry who have invested their time and money to support talents and ideas. Such a person is Don Wilson. Don Wilson is the co-founder of Wilson Cook Company, which is today Cook Medical. And Don made tremendous efforts in spreading endoscopy and collaborating with expert endoscopists from all over the world. To honor him and his legacy during EndoSwiss, we created in 2017 the Don Wilson Memorial Lecture. And with us is Minda Eddie Wilson, the wife of Don, and we are very honored and happy that she's with us today. I'm also very happy that Professor Amit Maideo accepted the invitation for this memorial lecture, and we are looking forward to his lecture.
So it is a tremendous pleasure for me and a great honor and a privilege to deliver to you today the Don Wilson Memorial Lecture during EndoSwiss 2023. When Stefan asked me to select the topic of the lecture, I selected it as flexible endoscopic surgery. Will it be the future of interventional endoscopy? There are several reasons why I selected this topic. The first reason is that I am myself a surgeon by training who went into therapeutic endoscopy and then other interventional endoscopy. And second important reason is over the last 3.5–4 decades, endoscopy has exponentially metamorphosed from being a simple diagnostic endoscopic modality to interventional to therapeutic. And lately, in the last decade or so, as you will see from the next 20 odd minutes, interventional endoscopy techniques have almost become similar to surgical techniques. And that's the reason I selected this topic. After seeing the two procedures which I performed today, some of you may be wondering in the audience why I was selected to give this lecture. Because both the procedures which I did were extremely difficult. And there were various reasons for that, but I think one of the main reasons was luck was not by my side. And there were some technical issues which made these procedures difficult. And I was in fact wondering whether I showed you how to make a simple procedure difficult. But to tell you that it was a difficult case, and finally in the last case, we completed resection of that adenoma, except for a very small portion in the center, just at the biliary epithelium, and after which we have placed a pancreatic stent, which was prophylactic. So at least we have not done harm to the patient, and maybe Stefan can follow it up later and remove the residual portion of the adenoma. So coming to my talk, my first introduction to Don Wilson took place when I was a young boy, just finished my MS, and I finished my GI surgical training from Mumbai. I finished my onco-surgical training from Mumbai, and I was introduced to Professor Nip Sohendra when he had come to Mumbai for a conference. And when Professor Nip Sohendra accepted me for training in his unit, I initially went for only 6 months, but ultimately stayed for almost 3.5, 4 years. And I got transformed from a surgeon to an endoscopist. And actually, it was that time that I met Don. It was quite regular. I used to find that Don used to visit Nib Sohendra. And as the youngest trainee from the Universität Krankenhaus Eppendorf at Hamburg, and funnily speaking, even that time, his department was called Abteilung für Endoskopische Chirurgie. That means it was endoscopic surgery. I never imagined that that name, Abteilung für Endoscopic Chirurgie, was basically because it was a endoscopy department belonging to the surgery department. But it indicated that this is like endoscopic surgery department, because this is exactly what has happened 3-4 decades later. And when Don used to visit Professor Nip Sohendra, I used to be a young boy inside, usually the first to reach his unit and the last to leave the unit, preparing some accessories, preparing some sphincterotomes, preparing stents for him. And that was the time Don got interested in me, and Don, after I finished my training with Nip Sohendra, on my way back to India, he invited me to visit the Wilson Cook factory. And somewhere in 1990, on my way back to India, I went to Winston-Salem, and I visited his factory. And Don actually introduced me to his R&D chief. There was a lady. And he made me sit down in the factory and discuss with her and show her how you should make the sphincterotome so that the wire comes towards 11 o'clock, what should be the length of the wire, how to try to make a pre-cut sphincterotome, and what the various other techniques which we could incorporate in his manufacturing. Well, I spent the whole day with that R&D lady, and then the evening he invited me, Minda and Don invited me to their house for a glass of wine. And when I was leaving, Don came back from his inside room and he gave a catalog of Wilson Cook to me. And he said, Amit, now you're going back to India, you're going to need instruments. So just open this catalog and decide what you want. Just tick. And I will give you a full packet of accessories to take back to India. And that's what he did. And I, like a young boy, I selected a lot of accessories, including the Savary-Gillard dilators. Everything was packed and sent to my hotel room, which I took back to India. And the same Savary-Gillard dilators I'm still using for the last 35 years. This was my introduction and my memory of Don Wilson. He was a lion by heart. In fact, he himself came to pick me up from the airport in his Rolls-Royce. I never imagined that. and he took me to his house. And that's why it gives me tremendous pleasure to deliver the Don Milson Memorial Lecture. It was way back in 1986 when I was working with Nip Sohendra. I saw that Nip Sohendra had already started changing the field of endoscopy, and techniques like varicose sclerotherapy, cyanoacrylate glue, percutaneous endoscopic gastrostomy, esophageal dilatation with bougies, esophageal plastic stent placement, of course, biliary pancreatic sphincterotomy, stone extraction, plastic stenting, mother-baby, cholangioscopy and EHL, polypectomy, piecemeal resection of flat adenomas, endoscopic ampulectomy were routine procedures from 1980 to 1990 in his unit. Now, for me, this was a complete game changer because I'd never ever imagined that therapeutic endoscopy had such a vast spectrum. In fact, if you see here, this is a video which I had borrowed from NIB. And metaplastic or dysplastic Barrett's esophagus, even that time, without any cap, without any submucosal fluid cushion, he used to just resect the entire Barrett's with a freehand snare technique. And it was truly the beginning of endoscopic surgery. And this is the way he used to do a complete circumferential resection of the lesions. Well, it so happened that 1990s I returned back, and somewhere in mid-1990s, 1995 or so, in fact, the decade from 1990 to 2000 was the decade of explosion of endoscopic technology. And in this decade, high-resolution endoscopes were manufactured, introduced, enhanced imaging techniques, self-expanding metal stents came in 1995, hydrophilic glide wires, various types of sphincterotomes and steerable catheters, dilatation balloons, dissection and resection knives, suturing equipment, stapling devices, hemoclips and closure clips, and defect closure devices. And the field of endoscopy literally blossomed. And along with the explosion of technology, in 2000 to 2023, there was an explosion of technique. It became routinely possible to clear difficult CBD and pancreatic stones, resect early cancers or tumors by EMR, ESD, EFTR. We started performing endotherapy of GERD in the form of ARMS, ARMA, or full-thickness plication, or TIF, or MACE. Third-space endoscopic procedures blossomed, like POEM, Z-POEM, D-POEM, STIR, submucosal tunneling ESD, PRAME, POSE, and G-POEM. Bariatric endoscopy started playing a role, like balloon placement, gastroplasty, and various other procedures. And in fact, some endoscopists even started breaking barriers. Here, for example, even extremely large stones, some stones which we had to finally refer to surgery, we reached a situation today in 2023, as you have seen from the live demonstrations here, that it is virtually now possible to remove any stone of any size located anywhere inside the bile duct or intrahepatic duct. So the need of sending this patient for surgery is probably less than 1%, or maybe just 1%, or maybe even 0. Well, similarly, the same story for pancreatic stones. Today I showed was a little different, but whether you had radio-opaque or radiolucent stones with a mixture of ESWL or with balloon sphincteroplasty of the pancreas, it became possible for us to clear pancreatic stones in indications where the patients had to have a clearance and relief of their relentless abdominal pain. Submucosal tunneling and resection procedures, the endoscopic procedure started changing. And instead of only cannulating ducts, what we started doing, various centers in the world, you can see here, the whole field of endoscopy has started changing. It started looking like surgery. We started cutting, we started lifting, we started dissecting, we started closing the defects. And procedures like ESD, POEM, STIR, G-POEM, etc., came to be established as routine procedures in day-to-day practice. Including patients with GERD, procedures like ARMS were invented by Professor Inouye. You see here, it became possible for us to resect the lesser curvature mucosa, and at the end of 1 month, you can see the result by a simple endoscopic mucosal resection procedure, we could get a result as if you have performed a laparoscopic fundoplication, or of course, a simpler procedure like ARMA, and finally, the procedure of endoscopic full thickness plication by using various stapling devices like this Gerdex device. And as I told you before, in addition to other procedures, bariatric procedures came to be established. We started performing endoscopic sleeve gastroplasty, or you see the TOR procedure here for reducing the outlet from gastrojejunal dilated anastomosis, and of course the EDGE procedure where we could actually perform a ERCP by performing a gastro stomach from the stomach to the excluded stomach anastomosis by using a lumen opposing metal stent and suturing it. And similarly, defects could now be closed. We saw examples, Professor Inouye telling us about the loop technique, but suturing device could be used for closing full thickness defects like this. For example, a large duodenal defect after a duodenal full thickness resection can be closed quite easily by using this suturing device. Or you see here a full thickness defect in the esophagus where we removed a leiomyoma which had invaded the layers of the muscle, and after removing there was a big defect on the posterior wall of the esophagus, could easily be closed by using the suturing device. So what happened is we actually started performing endoscopic procedures which were similar to surgical procedures. But some endoscopists of the world did not stop at that level. They went 2 steps ahead and started breaking all barriers of traditional endoscopy. And procedures were performed in humans, for example, a transcecal appendicectomy. And you see here making a hole just at the cecum, at the appendicular orifice. You could go out with a scope, dissect the appendix out, and take it out of the colon. And these procedures could be performed, or for that matter, even a transrectal cholecystolithotomy, where the gallbladder could be preserved. You could go on the anterior wall of the rectum, enter inside the peritoneum, and go and open the gallbladder, take out the stones, close the gallbladder, and then come out back out of the rectum. Similarly, non-stenting transgastric gastrojejunostomy without placing a lambs. With the EUS guided, you could puncture the stomach with the jejunum, and just around the wire, kept on dissecting. All these procedures were being done in humans, not routinely clinically acceptable, but these were breaking all traditions of endoscopy and sometimes even traditions of normal surgery. Sometimes they also attempted lymph node dissection, and this was done in porcine models or even in humans. For example, lymph node dissection could be done in the mediastinum by going outside the esophagus, and also in the mesorectum or mesocolon by going outside the rectum, going in the mesorectum or mesocolon, and taking out lymph nodes in patients with cancers. Now the issue here is that endoscopists, after 3.5–4 decades of explosion of technology and technique, literally had started feeling that they were going to start replacing surgeons. And I could actually witness this growth from diagnostic endoscopy to interventional endoscopy to therapeutic endoscopy to flexible endoscopic surgery. And this was a cartoon which was published more than 30 years back in GI Endoscopy in an editorial. And this was exactly the state where some endoscopists started feeling that they could actually replace the surgeon and perform most of the procedures by flexible endoscopy, and the surgery could be used only as a standby. But we have to remember that as we go ahead, for a gastrointestinal endoscopy to become an endoscopic surgeon, there are 3 important things which we have to remember. First is the GI physician endoscopist has to change the mentality. Number 1, you need to change the technique. And number 3, you need to change the technology if you really want to do flexible endoscopic surgery. Now, what is the mentality? A physician endoscopist or a typical physician, you see here the inherent characteristics of a physician is a person who thinks carefully before acting, deep intellectual curiosity, interested in mental stimulation, more receptive to emotions, and vivid power of imagination. Whereas a surgeon, inherent capabilities are ability to adapt at a moment's notice, like to see concrete results at the end, Then stamina to sustain long procedures, quickly adapt to unexpected situations, and always pragmatic. So for a gastroenterologist or a GI endoscopist to become flexible endoscopic surgeon or to start performing all these procedures in the future, there has to be a blend between these two mentalities. If you're a surgical endoscopist, you should develop the characteristics of a physician, which I've mentioned in the left. And if you're a physician, you have to develop some characteristics of a surgeon, what I've mentioned in the right. And next is, very important, is we have to understand the basic principles of surgery. The two main principles of surgery are optimize exposure and permit triangulation. All of us have seen various ESD procedures, various resection procedures. Everything is concentrated on how to lift the specimen and then you can dissect. So triangulation is extremely important. Unfortunately, the existing endoscopic technology we have has got tremendous limitations to perform flexible endoscopic surgery in the true sense. The main reason is lack of multitasking endoscope. Limitation in the number and size of access channels of the endoscope, inability to position, stabilize, and fix instruments, it keeps on moving, inability to retract and expose, and most important, inability to triangulate. You can't triangulate, you can't lift with one hand and cut with the other. So what is the ideal platform for flexible endoscopic surgery? The ideal platform is, it should be ergonomic but flexible, it should provide a stability to perform complex tasks, have multiple large instrument channels, triangulated instruments, end effectors, high-resolution imaging, ancillary ports for CO2 insufflation, irrigation and suction, and a full set of articulated and flexible surgical instruments. You know something, 15 years back, many companies thought about this and started developing some instruments. And these are the initial development of endoscopic surgery platforms. First came from Karl Storz, second from Boston Scientific, third was the Endo Samurai from Olympus. But somehow they never came into commercial production because they were not truly achieving the purpose for which they were meant. In fact, certain special scopes were also made, shape lock transport. You see here endoscope, the Cobra triangulating endoscope, and the double bending R scope from Olympus, which they stopped manufacturing. It never got introduced routinely in commercial practice. COVID hit us, 3-4 years, pandemic, and almost the entire world had come to a standstill. But fortunately for me, even though work was less, routine endoscopic procedural work, this was the time I was exposed to this world's first flexible multi-armed robotic endoscope. And you see here, this endoscope had a console, which is going inside the patient, where endoscope was attached to this console, and this was the physician's console, where we could sit here, and by moving these two levers, and by some foot pedals, we could actually start performing these flexible robotic procedures. And then it so happens that I collaborated with this company, and somewhere in the mid of the pandemic, when we had hardly any work to do, engineers from this company flew over to our center and stayed with us for almost 8 months. And within these 8 months, we conducted some trials. These were the various instruments which we could use through the flexible multi-armed robotic endoscope. You should have the needle driver, Debicki's forceps, the curved scissors. You see here various forceps which are almost similar to surgical instruments. And this started changing the whole scenario. So we did experiments first outside, in vitro, you see here, on this small model, chicken model, where by these two arms we could actually take sutures. And here you can see on one such colonic model, we could actually perform dissection. By lifting by the left side, by the left arm, and on the right arm, we could actually dissect it. Now see here, this was actually as if you are performing a surgical procedure intraluminally. And this changed the whole scenario. We also learned how to do suturing. It was a very, very tedious, let me tell you, sitting on that robotic console and trying to learn this technique was very, very difficult. It took almost 3 to 4 months even for youngsters in my team to really judge it and to be able to do it with reasonable efficiency. And then finally, we decided to do these procedures in the human being. And It was a few months later that we started performing these procedures, and around 20 patients, we did this procedure in the upper GI tract and in the colon. In the colon, it was relatively easy, but in the upper GI tract, we realized very soon that this endoscope did require some further modifications, where we had to reduce the size. Then the channels of the endoscope, of that special flexible scope, had to become more durable because they used to kink. And this scope could not go very easily across the bends of the stomach and the duodenum. Taking a U-turn was almost impossible. However, the company was very proactive, and even today, this product is not commercially available, but it is in production and in development, and I'm quite sure that in the next few years, we will be having a commercially available, ready-to-use, multi-armed, flexible robotic endoscope, which is truly robotic, not the ones which are presently available in the market, which are partly mechanical and partly robotic. So this is going to be a truly robotic instrument. So therefore, how do we perceive this whole growth of diagnostic endoscopy to flexible endoscopic surgery? Is it really going to replace the various surgical procedures? I feel it's not going to happen so soon. And just because that we are able to do a particular procedure and go in the mediastinum or go in the fourth space, as I call it, or peritoneum, doesn't mean that we can do it. However, as we are sitting on this time when we have come to that era where such type of an endoscope is also now going to be available, which is going to increase our armamentarium tremendously of the future interventional endoscopist, I'm reminded of the words of Bernard Lown, who was a famous cardiologist from Harvard, who also incidentally won the Nobel Peace Prize, who had said a long time back that only those who see the invisible can do the impossible. And finally, as we are on the brink of flexible endoscopic surgery, getting introduced into our life, we should never forget the wise words of Peter Cotton. The second time I'm quoting Peter Cotton, though I'm myself not a student of Peter Cotton, I'm a student of Nip Sohendra, where Peter Cotton had said many times, many years back, that it is important to see the patient as a whole, not just the hole in the patient. Thank you so much for your attention.
Ahmed, thank you for this outstanding presentation. For us, it is also a great honor to have you here because we follow our tradition from Hamburg, not only in the examinations, but also with the invitation for our faculty. Thank you very much.
Thank you.
Yeah, dear colleagues and friends, we have a last highlight of our meeting, and this highlight is the announcement of the Young Talent Award. And I would like to ask the technique if they could start with the presentation. The winner is Jakub Kryszkowiak from Poland, and please, Jakub, come to the podium. So, congratulations to your outstanding, please come to the podium. Congratulations to your outstanding scientific work, and Stefan will pass you the award and the prize. So thank you very much for coming, and we are very happy that you have been here. Thank you, and also congratulations to the other three presenters. They also showed excellent scientific work, and we are looking for the next award. So we are now at the end of a long day, and it was an exciting day, and first of all, we would like, Stefan and me, we want to thank our international faculty. We had outstanding presentations, live demonstrations. We have chosen intentionally difficult cases. We had great discussions. It was a fantastic day. And the last information I got, we had almost 800 people in the internet who were following our program. So thank you very much for coming here to Zurich. You notice that until the end of the meeting, the room is still full of people. We are very happy about this, and we would like to invite you to our next EndoSwiss meeting, end of June in 2 years. Thank you very much for being here. Thank you. Thank you. Good.